वक्रतुण्डमहाकाय सूर्यकोटिः समप्रभा
वक्रतुण्डमहाकाय सूर्यकोटिः समप्रभा
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुण्डमहाकाय सूर्यकोटिः समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
Very good morning to one and all present here. Ladies and gentlemen, welcome to the Nutrition Symposium, Decoding Diet Dilemmas. As we embark on this journey of knowledge and inspiration, I'm thrilled to introduce our esteemed chairpersons present here today, Dr. Amin.
Sunil's Diabetes Care and Research Center. She is an Honorable Secretary at Indian Dietetic Association, Joint Secretary at Association of Diabetes Educator. She has presented various research papers at IDF, ADA, and RSSDI, and has published a lot of articles. Ma'am, over to you.
Yes, I just, oh, yes. No, because here I can just see a very small thing. Okay. Okay. I think something went wrong. And may I have the technical team here just to help me out? Something? Yeah. Okay. I just want to know when it is full screen. Oh, okay. So, very good morning to one and all. And at the outset, I would just like to thank A big gratitude to Dr. Manoj Chawla sir and Dr. Purvi for having all of us over here. And I'm so thrilled to be in Mumbai, Amchi, Mumbai. It's always a pleasure because it's a city which never sleeps. And that too, when we're going to start the session with the nutrition again, when I'm sure that we're going to have a power packed hall as well. So here, with so many dilemmas in diet, I'm going to speak upon millets. So millets have been again, it's been a topic of concern, especially from 2023. So I'm going to speak on different topics like what are millets. I'll take you browse you towards like understanding of millets, understanding the nutritional value, how can we actually incorporate millets in our diet, and what is the final take home message. So, in fact, I am actually also happy that 2023 was known as the International Year of Millet. But, friends, let me tell you that millets is not something new. It was there in our plate, I think, way before, decades before it was there. It has been an integral part of our diet way before, like centuries before, also. And, however, I would also like to thank Honorable Minister Modi ji, who has brought millet to the limelight and who has, made millet as the important nutri cereal. And it is like because of that, 2023 was labeled as the International Year of Millets. But friends, it's not only 2023. I think it should be always there in our plate. And when we talk about millets, it has been grown in a number of countries, and especially in Asia and Africa. It has been the ancient food grain. And millets, if I tell you that it was the first crop which was domesticated in India, and it was only after the Green Revolution, that is only in after 1960s, millet took a backstage because it was being replaced by your wheat and rice. However, today again, millet has come, to the picture, and it is now termed as the yesterday's coarse grains, but today's nutri cereals and the future crops. Just a minute, can I have the timer? Can I see the timer somewhere? No. Okay, so
Will
I'll
help
just
you.
request the chairpersons to keep me, updated with the time. So, millets are a group of small and round whole grains which is grown in India, and if I just take you, there are different types of millets. When I was like making this presentation, I think I just happened to browse over that there are different types of millets, which is actually also divided into two categories. I think most of the dietitians will also agree we have not learned much about millets. Frankly speaking, it's only about from 2023. Yes, we also woke up. Okay, yes, we also need to understand about so many millets. So millets are divided into large millets and small millets. So the large millets are the jawar, bajra, the foxtail, proso, finger, which is also known as ragi, and the small millets, that's the kodu, barnyard, little, dini, brown top, fonio, and the jobs tears. So these are the different types and the different varieties of millets which are available over the shelf. And I think whenever we are talking about millets, we all know only two or maybe three. So that is jawar, bajra, and ragi. What about the other millets which we were really not aware? So here, we're going to take a dive into these different millets. And let me tell you, they are sustainable crops, and they have a low water and a carbon footprint. So basically, they have a short life cycle. They need less of water, in cultivation. So basically, that is why they are also friendly to the farmers. As compared to the wheat and rice, which requires, a maximum of around 20 to 24 weeks. So now the question is, when we are comparing cereals to millets, so especially cereals, that is your wheat and rice, to the different millets. So again, I would like to bring to your notice that the energy and the carbohydrates of wheat, rice versus your millets, your jawar bajra is almost the same. We can't really say that, the millets have low calories or low carbs. They have here, if you can actually here, if you can actually notice, the energy and the carbs are almost the same. However, the protein content and the micronutrient content, the fiber content of the millets are relatively higher as compared to wheat and rice. Here, if you can see that the protein of jawar and bajra is high, foxtail millet, samwa, china, the protein content is high. Even the iron content, if you see, so I'm going to take a little more time on this slide because this is something which is important. We should know the iron content of bajra, even the sanwa, the little millet is high as compared to your wheat and rice. The calcium content of ragi is high. The potassium content of bajra is high. So these things, I think we need to focus. The energy in the carbohydrate of the cereals and the millets are the same, only the proteins and the micronutrients are much more in the millets. Even when we are comparing the fiber content of the millets are much more than the cereals. So yes, millets come with a number of benefits. They are low glycemic index, they are gluten free. So all those who are on a who have celiac disease, of course we can uh, you know add millets to their plate. The barnyard and the millet sauce again as a rich source of iron and fiber. Finger millet is a good substitute for oats and cereals. Foxtail is again rich in minerals and vitamins, and bajra is a good source of iron and fiber, and which can be added to your patients, whenever and as in required. So millets overall, you say it is around 7 to 12% of protein, around 5% of fat, and around 65 to 75% is carbs. So this is again important. But however, the dietary content, the dietary fiber content is high. So millets are again, it is why are we actually talking all about millets? Again, it is gluten free, it is hypoallergenic. Then again, these can be organic because it needs less of fertilizer. I mean to say, less of pesticides are needed. And again, it is loaded with micro nutrients and antioxidants. We've already talked that millets are nutritionally superior because they are rich in dietary fibers, resistant starch, vitamins, minerals, and they're also rich source of essential amino acids. So these are important, and they are again uh, they are a potential to generate livelihoods, to increase the farmers income, because overall the less of fertilizers, less of water is needed. So overall, if you see that millets are a superfood for all, it is good for your gut. It improves your gut dysbiosis. It is good to the farmer's pocket as well. It's economical because it needs less irrigation, less fertilizers, and it's also good for the environment with low carbon footprint. And finally, it's also good to the consumers, to the patients. It is gluten free, low GI, rich in fiber. However, what does the research says? So there are a number of research papers which has shown, and this is a research paper which shows a meta-analysis of 99 studies, which a number of millets, which has shown, which here we can see the glycemic index of different millets. So here we can see that most of the millets have a low to intermediate moderate GI as compared to rice and wheat. And again, the glycemic index of different millets, the kodu millet versus the rice. So again, here we can see that the glycemic index, of course, of kodu is favorable, and it is less as compared to the rice. Again, the pearl millet. So number of studies which has proven that the glycemic index of the millets is less as compared to cereals. What about the long-term consumption of millet in fasting blood glucose in non-diabetics, pre-diabetics, and diabetic subjects? Again, it has shown favorable uh, it has been shown that it is favorable for all these the diabetics and pre-diabetics and diabetic subjects. It has also shown reduction in HbA1c. So millets had a significantly lower GI than the white rice, refined wheat, even the glucose or the white bread. It has a long term and the long term millet consumption lowered the fasting and the postprandial blood glucose values. And there's a significant reduction in HbA1c, and minimally processed millets were 30% more effective in lowering the GI of a meal. So, if you say that millets are beneficial in, in managing and reducing the risk of developing diabetes. So, it finally it concludes that the meta-analysis confirmed that the millets evaluated have a strong potential in dietary management and prevention of diabetes. Then we have these the nutritional and the functional roles. Yes, it has a high energy yielding nourishing food. It is also is considered as the potential prebiotic and the probiotic benefit, and it's an excellent source in insoluble dietary fiber, lipids, and minerals. And when we are talking about millets, there's one more thing what we want to would like to share, that the germination and the fermentation showed a positive improvement in the overall nutritional characteristics of the millets. This we've already talked. So, are there any disadvantages of millets? Yes, these millets are, they contain some polyphenols and tannins and phytates, which may interfere with the bioavailability of the micronutrients and protein digestibility. They also have a goitrogenic compound. So how are we supposed to do? We have to have millets in the right way. First, we can have it in an unpolished way, because that's how it will increase the nutrient content. We can soak the millets. So soaking millets will enrich the bioavailability of the calcium, zinc, and iron. Fermentation, we can also ferment the millets. It enhances the protein digestibility. We can do the germination, which will again improve the micronutrient availability. And also cooking the millets, always make sure that you're going to cook and consume. So, because millets contain goitrogens and may interfere with the absorption of iodine. Hence, always make sure that you're cooking it in a proper way and then consuming it. Um, Again, excessive polishing. So make sure that you're going to have whole grain. Do not polish. Do not use the polished millets. So which millet is it good for every age group? Yes, it is good for every age group. In fact, the ICMR NIN 2024 guidelines have also added millets even for the children. So we can introduce millets gradually, because yes, we are not our children, especially our children, are not they are not accustomed to the taste of the millets in the plate. And I think somewhere we mothers are responsible for that, because we have always been feeding them on wheat and rice. So I think here is the day when we need to gradually introduce millets to the plate, and it can be done for every age group. And my talk would not finish if I pay my humble gratitude, my salute to Dr. Khader Wali, who is the unsung hero. He's the millet man of India, and who has been driving a silent revolution for creating more awareness, for millets. And I'm sure that the government has also done several campaigns last year. In fact, it had a lot of dishes which was introduced in the parliament canteen, and I think we can use our culinary skills to use millets in your everyday snack, breakfast, meals should be added. So my final take home message is, so whether your millet is a hype or a superfood, I suggest, I think can I have a round whether it is a superfood or a hype? Can I have, okay, a superfood? Yes. And a hype? Yes, a little hype. Yes, it is a hype. But overall, I think my take home message is whatever it is moderation is the key. We can't say that, okay, doesn't have the energy content. And that is why I was focusing on the energy and the carbohydrate content. I think that is what we need to tell our patients, ki, okay, it has the same amount of carbohydrates. So we need to tell them that yes, millets do have an extraordinary nutritional value, but yes, we can include a variety of millets in the plate with different types of millets. I suggest when we are talking about rotation of our oils in our plate, I also suggest we should have rotation of millets in our plate. And when we talk about ICMR NIN 24 guidelines, here it suggests that a balanced diet should provide not more than 45% calories from cereals and millets. So millets have found their way to our guidelines as well. And when you, if you can see the plate, the my plate, so even in the my plate they have added the millets in the plate. So with that, millets have changed from being a grain of the poor to being a nutritious grain. And with that, I would just request all all of us here, we should include millets as a part of a plate, maybe in one of the meals as well. So thank you so much.
Thank you, ma'am, for the wonderful presentation and taking us and clearing our concept related to the millets. As we are running late, so we'll take the question answers in the
Later.
later.
Okay, thank you.
So now
Yes,
yes,
I think I just end the show.
we take one. Okay, so we can take one question. Yeah.
Yeah, excellent talk. I hope we get to eat millets in one of the 7 meals that we'll be having here through the course.
Sorry, sir. Sorry.
I said excellent talk,
Yes, sir.
very
Thank you.
informative. The most important take home message was that pearl millets are goitrogenous, so we need to avoid them giving in excessive to our female patients at least.
But sir, we can actually
Yeah,
soak them,
soak them.
or
Yeah,
then we can
yeah.
use them.
So
We need to consume them in a cooked manner. Then it is good.
yeah,
However, it's also rich in other nutrients, so
yeah.
we need to have a rotation of millets as well.
So I hope we get to eat millets in one of the seven
Yeah, I
meals that
think we
will be
need to.
served.
I think I
So
also
let's
request
hope.
that we should have millets in our
Yeah.
conferences as well.
Yeah, my question was,
Yes.
uh, many diabetic patients also have other comorbidities like a high lipid, hypertension, and thyroid. So, are there any specific combinations that are advised to such patients? That was my question. Like, do you, tailor make your prescriptions or your advice to patients who are only diabetic and diabetics with a comorbidity?
Yes, sir. MNT is always tailor-made. So, as per their comorbid conditions, always I think all the dietitians will agree. It's tailor-made as per the. We always see the physician's prescription and also their biochemical parameters, and only on that basis we start taking the 24-hour dietary recall and everything.
Madam, good morning.
So we'll
Uh,
take this last question. So.
Yes.
okay. You see, this jawar or sorghum is associated with pellagra. You may be knowing that.
Sorry, sir. It is associated with.
Pellagra, it is pellagra that is defined as dermatitis, diarrhea, and dementia. So, how far it is safe to consume sorghum or
Jawar, sir,
jawar?
I have not read that basically. I don't know if anybody could help me, but as of now, I have not read papers like how Jawar is, because Jawar has been in our plate since
Since,
decades.
yes, since decades,
Yes,
since
yes.
childhood, I know that. But this is associated with pellagra, and that pellagra is defined as dermatitis and dementia and diarrhea. So
Okay.
you
So
please,
I would also say that every food is different for every person. I think you need to understand your symptoms, your you know, and then you can take it forward. A particular food. You can just not take any food blindly.
So
Uh,
we'll,
Can we? I think.
excuse me, sir,
Doctor,
we'll take your question.
one more.
Sorry.
Dr. Kavita, let me compliment you for an excellent presentation.
Thank you.
Originally, I am from Gujarat,
Uh-huh.
and in North Gujarat, especially in Saurashtra, these pellets are absolutely a staple diet.
Yes.
Bajrina, rotla, and kadhi
Yes.
is a people have been eating for years and years together. I would request you, if a study can be done, that in this population who have been consuming this for a long time, are there chances of type 2 diabetes there? Number one. My second question is, if a proved case of type 2 diabetes switched over to millets, what benefit that person comes, or can it be reversed? Number two. And my third question is, are there any side effects if person consumes for a long time? Are there any side effects, or is there any limitation that you should take in a particular? I think one, but last
So
Sir,
I
one
have
sir,
slide.
already shown a number of studies which has shown beneficial effects in reducing the fasting blood glucose levels, even postprandial blood glucose levels. So there was a meta-analysis study
sorry,
which has shown that.
sorry
So
to
there
cut
were
you.
beneficial effects, yes, especially in your type
Yeah.
2 diabetics. Okay, thank you.
Thank you, ma'am. And now our next speaker don't need any uh, uh, introduction, Dr. Cheryl, ma'am. She has a rich experience of over 24 years in the field of diabetes and dietetics education. She is a author for award-winning book Diet and Diabetes Simplified. Ma'am is an advisory council member of ISPAD. She is leading an ISPAD special interest group for nutrition. She is a faculty at Science School for Healthcare Professionals and have received various awards. Over to you, ma'am, and help us with the today's topic.
Thank you so much, and good morning, everyone. It's wonderful to be here. Dr. Manoj and Dr. Purvi are very good friends, so it's always lovely being here. And what a better honor than having your own students as chairpersons for your session.
It is an honor for
Amazing.
us too, ma'am.
Okay, so it's really wonderful, and again with friends as co-faculty. I'm sorry I'll have to push my session ahead because of certain other commitments, but we're going to be talking on a. I think today you must be seeing, whether it's social media and so many things. There's so much, food pharma. I don't know how many of you all have seen him. He's become so popular. Okay, and we were always scared about calling out brands because you are worried about litigations and companies being after us, etc. But I think he has done something which is really really gutsy and gained so much of popularity. Now to begin with, let me ask this audience, how many of you all really read food labels? Can we have a show of hands? Excellent. I think that's because it's a learned audience. How many of your patients, when they come to you for the first time, read food labels? Exactly. So then my session, I'm going to be covering a few of those aspects. So it's food fraud get label wise. Like today you go to a supermarket and honestly, the aisles have so many, and everything is shouting out healthy, whether it's biscuits, whether it is muesli, whether it's breads, and so many new products. In fact, sometimes so many of our patients keep sending us this on WhatsApp, asking us, is this good? Is this good? And then you go and research. So there's so many products available out there, and then you get confused which one is really good. Okay, now let's decode food labels. Let's first understand what does a food label really have. So one is that the food label actually, for you it may just look like a packet, but it's got so many things which are mentioned, which you really need to spend time to read. And that will mean taking another 5-10 minutes, of your time at the supermarket to understand this healthy, compare two different products so that you get to know exactly, what it is. Is it really healthy or no? Now, this was an interesting survey that was done with around 3,231 respondents in the age group of 18 to 60 years, where they tried to understand that when they're looking at a packaged food, what do they really look at? And look at the findings. They're not very surprising. First thing that they read is the expiry date, which everybody reads. That's the first thing you look at. And what they don't really read is nutrient information, allergens, veg, non-veg, now people have become more educated. But if you look at the nutritional label, nobody really pays attention to. So that is something that we need to focus on and emphasize our patients and consumers to start reading. So let's look at the food label. Now, when you look at the nutrition label on a packet, it will first tell you the serving size. Now, you may look at one packet of biscuits, but it may be 4 to 5 serving sizes. So the person may think that that entire biscuit packet is what I should eat. So very important first thing is to look at serving information. So if you look at this packet, it's got 1 cup is 227 grams, but it's got 4 servings. That's 227 into 4. That is the amount which is there in this packet. Second is we look at calories. Now, very important, people will think that this entire packet has got 280 calories, when actually it is just that 1 serving which has got 280 calories. So it's 280 into 4. Then comes to nutrients. The same thing. People will look at protein, carbohydrate, fat, and they'll think, oh, this entire packet has got only this, but this is only per serving. So this is a very, very important thing that we need to explain to our consumers, our patients, on how to decode the food label and buy the right product. Then comes the daily value. This is per serving of what you're eating, how much of the nutrition you're getting for your daily calorie and nutritional needs. And this is based as per the 2000 calories. Of course, you will have to tailor it to the person's caloric intake. Now, when we look at the food label also, there are various things which are mentioned. One will be definitely calories, then comes carbohydrate, then you will have fiber, you will have sugar, added sugar, you'll have fat. Sometimes they mention the saturated fat. Unfortunately, not too many people mention the sodium. And therefore, they will say it's a healthy food, but you will see that it's got a lot of salt. And most often, the diet foods, so to say, are more salty because you have to make it palatable. We like tasty food. We talk health, we talk diet, but honestly, you feed anybody diet, you will not see that person buying the product again. So, what are the nutrients which we should look at getting less of? Saturated fat, sodium, and added sugars. What you should get more? Definitely in a protein deficient country like India. And we still say that we are protein deficient because we do see in our dietary records that people do not meet their protein requirements. So, protein, dietary fiber is another important nutrient, vitamin D, calcium, iron, and definitely all the other micronutrients like B complex and potassium, etc., etc. Now, this is something which we need to focus on because we are in a diabetes congress. Is carbohydrate. And whenever we are looking at food products, it has to be moderate in the carbs. But we have to, and today FSSAI has made it mandatory that any type of added sugar, because in the past, if they added jaggery or they added honey, it was not really mentioned as sugar separately. But today, FSSAI has mandated it that any kind of sugar has to be mentioned as added sugar. So it is going to be in the total carbohydrate. So if you look at this, total sugars is 15. But out of that total sugars, 57 is coming from your added sugar. So that will tell you that this food has got a lot of added sugar in the form of sucrose or jaggery or honey or maple syrup, brown sugar, and the different forms of sugar. And the other part is from the naturally occurring sugars. For example, fruit sugar or from your lactose, which is coming from milk and milk products. Now, this is again most important thing which people do not read. It's the ingredients. We have to look at the ingredients. Now, if you look at this, what do you think of this? Is it good or bad? It says refined wheat flour. Okay, so refined wheat flour is 57% sugar and then comes palm oil. So the first 3 ingredients we should definitely tell them to have a glance because it starts from the highest order to the lowest order. This is in companies which are reputed companies. We do have a lot of products which are there at our local kirana wala, which have no food label ethics and everything is wrong and inaccurate, which you can report. But this is how we should tell them that it has to be, it's usually from the highest amount to the lowest amount. Again, allergy information, because today we do have people having peanut allergies, lactose intolerance, gluten intolerance. So we have to educate them that, how do you know that the food product has no gluten to it? For example, even hing. I don't know if you all know, but the hing available in the market also has gluten. So if you're dealing with a person with celiac disease, you have to tell them that please buy the gluten-free hing or the gluten-free sauces because even that will have gluten in it. Again, this is something which people look at, definitely. Most people, date of expiry and use before date. Because if you looked at the survey also, this ranked first in the respondent list. Logos, today you have FSSAI, SI, you have AgMark, veg, non-veg. In fact, the blue dot also, which Dr. Purvi and all were a part of, it was a diabetes-friendly food. And then today you have organic food and you have irradiated foods and all of that. So fortified, again, we have different foods which are used as vehicles for fortification. So, again, the fortification logo, etc. Now, this is something which is really misleading, and we know a lot of organizations which are working for this, like Consumer Voice, ASAI, and all are working because the FSSAI doesn't really control as to what can be in the front of the label. If it's got oats, you can write oats biscuit. If it's, you can claim the product to be healthy and not really talk about the product, which is, for example, sodium. You're talking about an oats biscuit, which will have a lot of sodium, but you need not really spell it out. You just say oats biscuit, and you will see that the sales will be double because people want to buy something healthy. So that is the front of package. So we have to tell people that just don't look at the front of pack labeling. Look at the back. Look at the ingredient list. Look at the nutrients, and it's only a one time thing, because then you know that, okay, this product is good, you've got it vetted by the healthcare professionals, and next time you go and buy the same thing. It's not like every time you're going to do it. Again, label claims can be deceptive. Usually you will see that people think it's healthy. I deal with a lot of people with diabetes, and then what happens is they will buy sugar free cakes on their birthdays and eat it by the kilo, because in their mind it is sugar free. So sugar free does not mean calorie free or fat free. In fact, you need to add more fat. And fat free doesn't mean sugar free. For example, you have a very famous brand of cereals which says it is, fat free cereal. But if you see the amount of sugar, it's very, very high. And we see a very sharp spike in blood glucose on the CGM graphs. So be a food detective. So, there's so many hidden forms of fat, of sugar, of salt, which may not realize, like baking powder, baking soda, garlic salt. And I'm sure we have a wonderful session on salt. That's another big thing today. Pink salt and, all the colored salts, and everything is getting an adjective. So how much sugar is added, or hiding in our food? Ketchups. Children love ketchups, and then they will have ketchup with everything, whether it's their bhajiyas or whether it is anything needs ketchup. So you see that is also a source of sugar. Your biscuits, yogurt. Today, a lot of people will buy yogurt from the market, and you get them. They're a little expensive, but if you tell them to buy yogurt, they will go and buy flavored yogurt. And one cup, small cup of flavored yogurt has easily 3 teaspoons of sugar. So here you're avoiding sugar in your tea and coffee and then having flavored. So anything which says flavored, whether it's flavored milk or flavored yogurt, is going to be having sugar in it. Now let's look at this. I've got a few examples. Multi-grain biscuits. Don't all our people with diabetes eat it? Sham ka chai, we need chai mein kuch dubane ke liye. They'll say chai to aise pee nahi sakte. We need to dip something in it. So multi-grain biscuit is supposed to be very safe. How many of you all eat multi-grain biscuit? Or advise multi-grain biscuit? So let's see. What do you think? Is it healthy? Not healthy? Crunchy, definitely. Tasty, yes. Okay, so let's look at it. Okay, so let's look at the food label. So what is the first ingredient on the food label? It says multi-grain. Okay, it's refined wheat flour, which is spelled out as maida, 45%, sugar, and then refined palm oil, then cereal products. And again, if you look at the added sugar, it's around 18.9 grams out of 20.3 grams, which is added sugar. So what do you think? Is it healthy? So you'll have sugar-free tea with multigrain biscuits. Okay, so again, this is again very important because people don't understand. They will buy the biscuits because they want to eat something healthy, but they're used to that crunch. And then they will go and buy something which claims to be healthy. But therefore, looking at the food label becomes important. Now, this is very interesting. Today I just spoke at a blueberry conference yesterday on how berries are so healthy. And I'm sure after yesterday's talk, everybody's going to go and look for blueberries or berries. Okay. So oats and berries, deadly combination, because oats is very good, beta glucan, excellent for diabetes, very good for weight loss, good fiber. And then comes berries, anthocyanins and antioxidants. I gave a lot of gyan on that yesterday. Okay. So very, very good combination. What do you think? Is it good or not? How many of you all think it's a great combination and should be included in our diet? He's very now. He's saying show the food label. Wait. Okay. So this is your oats and berry biscuit. Now look at the ingredients. So what do you expect in an oats and berries biscuit? Do we look for more oats or more maida? Do you think there'll be any maida in an oats biscuit? But can you see here? 64.5% is maida, even more than the multigrain. Look at the amount of oats. Oats comes only fourth. So again, sugar, then palm oil, and look at oats. Oats dikhaya hai. It's like that Karwa Chauth ka vrat and you see the moon. So this is like showing the moon, oats. So this is how it is. So you get 5% of oats and look at the sugar. Now very interesting is berries. How much of cranberry? That also dried, sweetened cranberry. 1%. Would you eat it? Okay, I'm sure this company is going to come chasing me after this. Okay, so look at the amount of sugar, 24.6 grams of added sugar in total sugars is 25.6 and carbohydrates. So nearly, one third to more than that is actually coming from your sugar. So this is again very important because people will pick this up thinking it's healthy.
Ma'am,
Now we come to,
we have
yeah,
2 minutes.
I'm done with two more slides. Jawar millet talk on millets. And today now we are going to start eating millets. What do you think? He's already saying no. Okay, so Jawar millet cookies. Now look at this. It's supposed to have Jawar, right? Look at where Jawar comes. First is oil, then comes sugar, then comes whole wheat flour, then comes corn flour, and then the poor Jawar gets some place in it. So again, this is what, and it says it contains wheat because typically a person who's got celiac disease, who's on gluten-free diet, will opt for Jawar cookies, not realizing that there is wheat in it. Remember, whether it's breads or cookies, even if they claim to be without having Jawar or millet, will have gluten in it. So we have to look for it. Then comes our very famous brown bread. So we tell people don't eat white bread. So what they'll do, they love bread. So they'll go and eat brown bread. And instead of eating 2 slices, we'll eat 4 because we think brown matlab bahut healthy. Okay, so what do we think? Okay, so let's look at the ingredients. Atta is only 32%, remaining is all maida. So what they've done is they've caramelized the sugar, made it brown and added maida to it and made it brown bread. And we pay a premium amount also for brown bread. And then we eat also double because in our mind we're thinking it's brown and then our sugars have a nice spike. And then we're coming to the doctor asking, why is my sugars going high? Or patients come to you, right? So this is again the story of brown bread. So what I want to really emphasize here is, or the takeaway point is that please, emphasize on reading food labels with our consumers. Maybe you can have these packets in your clinic where you can educate them because they will go back with a message and then they become advocates for healthy eating. They will educate their family. It'll have a ripple effect. So the society at large gets educated, and I think that is a big job for us to do. Muesli, again, you have different kinds of muesli. I'm done. Now, again, this is a fruit juice, which is claiming to be healthy, but the FSSAI has again put a mandate that you can't say 100% real. Okay, so you have a lot of people claiming that fruit juices are real and 100% fruit juice, but today, again, there's a mandate on it, and we can complain to FSSAI, ASCI, and I've seen people really taking up cases really quickly. So my takeaway message is don't get fooled, get label wise. Thank you so much for your patient hearing. And I have a chapter on this in my book, Diet and Diabetes Simplified. Thank you. So I'm sure I hope I've convinced people not to eat biscuits after this.
Completely.
Right. Ask a question, Dr. Cheryl.
Uh,
Yeah, multigrain atta, again, we'll have to see, sir, the food label. So if you're buying a ready-made atta, if you're making it at home, you know what it is. But if you're buying it from outside, we would tell them to read the label because even that we'll have to see what really is. And we would tell them when they're talking about mixing cereal and pulse, always mix it in the ratio of 3:1 because that is where the complementation of protein becomes good quality protein. So instead of mixing too many millets and too many cereals together, it's better to mix cereals with pulses. For example, a sattu atta or something, or a chana, roasted chana atta, that would be better. Somebody had a question for me. Yes, yes, there are a lot of them. In fact, I left that for Neha to talk on, but there are quite a few healthy labels as well. But due to paucity of time, I did not, and I cannot even endorse brands. But yes, we did. In fact, we did a full workshop on this, Kavita and I, at the RSSDI conference, and just showing all the different kinds of products. But there are a lot of genuine ones in the market. Unfortunately, you will see the smaller ones, these who are, from the home or really good, genuine brands, you do have them. So that is why it's important to identify and then select them, which we do help our consumers do.
Thank you, ma'am. We'll take the questions later.
So Cheryl, excellent presentation. Good for very good for scientific person. Let me tell me, 50% of the people are uneducated. They buy these products. How many people they really read it? I challenge, there are 100 people around here. We buy a product. How many of us will really go through the prescription or the things which are written? You created a good observation. I think it is worth doing. But if everybody starts reading what is there in the label, I'm sure you will create a big revolution in this country.
Thank you,
you.
sir. I'm hoping we start from here. And definitely, even if a percentage, even that number comes down, the survey, even if we see a small kind of an improvement there, I think it's a job well done. Thank you so much.
Thank you, ma'am. Wonderful session. It's my pleasure to introduce our next speaker, Aditi Deshmane, ma'am. Let, let us join me to welcome her. Aditi Deshmane, ma'am, is a consulting dietitian and nutritionist and a diabetes educator. She is advising medical nutrition therapy, especially for conditions like diabetes, thyroid, and obesity. Assistant Professor, Indian Institute of Food Science Technology. Academic Counselor and Thesis Guide, Indira Gandhi National Open University. Providing guidance in research topic selection and thesis writing for MSc Nutrition students and BSc students as well. She is a life member of Indian Dietetic Association, Mumbai chapter, life member for Research Society for Study of Diabetes in India, RSSDI, and she has publication, 7 paper published and 2 communicated to the journal.
Thank you
Yes,
for
ma'am.
the introduction. And before I start with my presentation, I would like to thank the entire DRS team for inviting me, Dr. Purvi, Dr. Manoj, for giving me this opportunity. And today I'll be talking on different types of milk and the confusion which is there in our minds pertaining to different types of milk. Now, as healthcare professionals, we very well know that diet is fundamental component in diabetes management, and we always find ourselves at the intersection of science, nutrition, and patient care. We are always providing guides to our patient for selecting food or giving them proper guidance for what to eat and what not to eat. And one such area that grown increasingly complex is milk, even though it has been a staple in our diet for ages. So we were barely coming to know what is whole milk and what is toned milk or standardized milk, when now we come to see a lot of other milks like soy milk, oats milk, and any different types of milk. And therefore now if you go to a grocery shop, it has become a battle of choices, what to choose among all these. So I'll let you know that all of these come with their nutritional benefits, some risks and controversies. So today I'll try to unravel the confusion surrounding these different types of milk. Now, first, it came into debate when people started following a paleo diet. Then again, it was a topic of hot debate when animal welfare supporters started talking about it. And now the researchers have also linked this milk to various health conditions such as cancer, diabetes, and cardiovascular disease. I have put some of the studies here. For cancer, it has been proven to have a higher risk for breast cancer and uterine cancer, while it has shown to be having a protective effect for colorectal cancer. Similarly, it was seen that cheese was associated with decreased but butter with increased risk of myocardial infarction. But they also said that if the diet is low in dairy fat, low fat dairy products, then there was no association seen with any adverse effects with myocardial infarction or cardiovascular disease in all. The same goes with type 2 diabetes also. There are studies which have linked cow milk with the risk of type 2 diabetes. One such a study done by our very own respected V. Mohan sir and his entire team show us that when low-fat dairy foods, especially the yogurt, exhibit a beneficial role in preventing type 2 diabetes, while they also say that most other food products are not associated with the risk. However, when it is linked with the lower risk of type 2 diabetes, it has been linked with the higher risk of type 1 diabetes in children. It has been proven that early cow milk introduction or exposure to the babies, that is even before the age of 4 months,
and breastfeeding for less than 3 months have been associated with high risk of developing type 1 diabetes. And again, the protein present in the milk is associated with the islet autoimmunity in the children only in those who are at a higher genetic risk of developing type 1 diabetes. So today, uh, another confusion in our mind is whether to have an unprocessed, unpasteurized, or homogenized milk or have it. There are claims saying that homogenization causes the increase of uptake of protein called xanthine oxidase, which can lead to atherosclerosis. Similarly, pasteurization, they say that it destroys the good bacteria as well when it kills the other pathogenic bacteria. And many vitamins and minerals are also destroyed due to the high heat treatment given to the milk. But let me remind you that these claims, they are basically not supported by any scientific evidence, and there is a high risk of food safety when you have raw milk. So here I'll attempt to give you different types of milk, their nutrient values, and how we can use them while prescribing our patients. Now, what is milk basically? By definition, it is a nutrient rich fluid female mammals produce to feed their young ones, and it being a sole food for the young babies to survive, it is packed with nutrients. The commonest form of milk consumed in our country is basically cow milk, followed by buffalo milk. So here you can see there are many health benefits related to milk. Basically, it is rich in calcium, other vitamins and minerals. It is a good source of high biological protein. Again, it is good for bone and dental health, and again also our digestive health. If you can see here, almost 1/4 of our daily requirement of all the vitamins and minerals can be provided by just 1 cup of milk. So now we'll look into different types of milk. This is cow milk. We'll start with it because it is the most commonest we consume. Now 87% is water and 13% is solids, out of which 4.8% is lactose. That is the sugar present in the milk. When we compare it with the human milk has 7% of lactose in it. It is a good source of calcium, phosphorus, and the fats present in the cow's milk is basically triglycerides, and therefore there are few studies linked with cardiovascular disease and the triglyceride levels. The protein in cow milk is 80% casein and 20% whey. Casein again has 4 different components like alpha, beta, kappa, and gamma, whereas the whey protein contains alpha lactoglobulin, then beta galactoglobulin, and other forms. And this protein as well as lactose is said to cause GI disturbances. Again, there are few cases or we can say issues where how these cattle have been raised. Then comes the A2 and A1 milk, a very much talked about milk and hyped, I can say, because here what is A1 and A2? It is a type of beta casein with an amino acid different at only position 67. It is said that A2 milk is much better than A1 milk. This A1 milk protein was associated with type 1 diabetes, and because of that, A2 was uh, very much talked about. And you can see at the last point, it was sold out about 150 rupees a liter. And if you see, the ghee made from A2 milk was sold at almost 4,000 rupees per kg, which is very high. But then last week, FSSI has put a ban of using this label as A2 milk or A1 milk because in India, the milk which we get from cows and milk, buffaloes are A2 milk. Then we'll look into buffalo milk. It is much thicker than cow milk because it has 3 to 4% more of fats as compared to cow milk, and this gives a satiety to everyone when we consume it. It is also rich in other nutrients as compared to cow's milk. Now, here are different types of milk, cow milk and buffalo milk, which we get. And the difference here only is in the fat percent. If you see, where regular cow milk or buffalo milk will have 3.5 and 8.5 fat, the standard milk will have 4.5% fat, whereas toned milk will have 3% and double tone will have 1.5. So these are only different in the fat content, rest is the same. Now we'll look into the goat milk. Now this is not very commonly used, but yes, there is an option available for us today, goat milk. It is low in lactose, high in oligosaccharides. Therefore, it is a good source for those who are lactose intolerant. Then it is more in calcium riboflavin as compared to cow's milk, but it has more of saturated fats. And again, it is costly also. Then is the camel milk. Again, it is not very widely used, only can be seen consumed in areas like desert areas. However, the protein is linked with diabetes, I mean protective diabetes effects are seen with camel milk. Then we'll look into the alternative types of milk, like these were all animal milk. Now we'll look into the plant-based protein alternatives. They are basically the water extracts from cereals, pulses, nuts, or seeds. So first we'll look into almond milk. It is one of the lowest calorie milk. It is lactose free, but it is not a good source of protein. So you have to consider other sources of protein when you're consuming almond milk. It is not suitable for babies below 1 year. Then we'll look into soy milk. It is typically again low in carbohydrates, contain almost the same amount of protein as regular cow milk, higher in vitamin D, C, and iron, promotes weight loss and said to prevent osteoporosis. However, there are mixed claims about the isoflavones present in them. Some say it is good, some say it is bad. Then we look into oats milk. It is generally more has calories as compared to other types of milk. It is also high in beta glucan, a soluble fiber, which is said to help lower LDL cholesterol. But again, it is not nutritious as whole oats are. Then is the rice milk. Contains similar number of calories to cow's milk, but almost double the content of carbohydrates and therefore high in glycemic index. So it contains less of proteins and fats. So again, you have to look for other sources to provide it. And lastly, coconut milk, which has been used in our cuisine for long, and it has a thick and creamier taste because of the high fat content. The same has been put into a table. You can see, you will get a better picture here. Now here you can see that buffalo milk provides highest calories, whereas almond milk provides you the lowest calories. If you look at the carbohydrate content, rice milk will give you more of carbohydrates. Again, almond will give you low of carbohydrates. If you look at the proteins and the fats, you will see the difference. And last column is the cost, where cow milk and buffalo milk is usually, we get it around 50 to 70 rupees a liter, but all these different types of milk, we'll get it starting from 150 and it goes till 1000 also. Now this is the table for minerals and trace elements. You can see all milks are good source of calcium, but the almond milk is the most richest one. Iron also you can get magnesium. And this is the vitamin content. This is the glycemic index of different types of milk. Now you see here, mostly all milk come under a low glycemic index level, except for rice milk, you can see, and coconut milk and oats milk. So these are the recommendations given. ICMR has also given recommendations for the milk and milk products. It is usually 1 to 4 servings per day. And if you see other regions also, it ranges to 1 to 2 servings. So what to choose? The question lies. Well, it will depend on different things, like I'll say the type of milk which you choose should be low in fat or skim milk to reduce the fat content. Then the portion size,
Again, consume milk in moderation and can help you manage your calories as well as the carbohydrate content. Then individual tolerance has also been taken into consideration. Dietary needs of an individual should be taken care of, and then let the label lead the way. Now, Cheryl has given a beautiful talk on reading labels. So please go ahead, read the labels, and then choose which type of milk you want to consume. So my take home message would be milk may be a valuable part of our diet when consumed in moderation and as a part of balanced meal plan. It's important to consider individual health, monitor blood sugar levels, and seeking professional guidance to make informed dietary choices. Thank you.
Thank you, ma'am.
My recommendation? Okay. But I'll say pasteurized and homogenized because it has a long shelf life also. Hmm. Okay. Hmm. 5. Yes. Our health. Yeah, fine. Absolutely, you can. But then again, you will have to look at the nutrient content also. When you take raw milk directly from a milkman, the fat content is almost high as 10 to 12%. Huh. Okay. So it is individual choice actually. Right. Plant based. Major issues. Okay. Thank you. No, no, there are no such studies as far as I know that having tea or coffee can increase the risk or increase the blood sugar levels. But yes, the way they take tea is very important. Like when patient come to us, they say that I am taking sugar-free tea, but still my blood sugars are not controlled. But then when we take a detailed recall, we come to know they have stopped 1 teaspoon of sugar, that is 5 grams, which will give 20 calories, but they have increased the milk content in the tea. When they were having regular sugar tea, they were having 50% of milk and 50% of water. Now they are taking 100% milk. So the fat content and calorie wise also, it increases. And at a whole, when you look, the carbohydrate intake and the calorie intake of that person is increased, and that leads to the uncontrolled blood sugar levels. So you'll have to look at the portion size.
Thank you, ma'am.
Our regular cow milk, buffalo milk, the nutritive, then I showed you the nutrient content of all milk. The same will be there for yogurt also. So it will depend on what type of nutrient you are looking for, and then you can choose the type of milk which you want or the yogurt you want. Yeah. And again, it depends. I mean, the ICMR has advised 1 to 4 servings of milk and dairy. Now, dairy is an umbrella term. It includes the yogurt also and paneer also and different types of dairy products. So, in total whole day, what you have, including milk and yogurt, is what you have to look for.
Thank you, ma'am.
Thank you.
Okay. Choosing the right oil can be confusing. Let's hear it from Dr. Niti Desai, ma'am, as to what oils do we choose. Niti Desai, ma'am, is a consultant nutritionist and diabetes educator and has a clinic in South Mumbai. She is attached with Columble Hill Hospital from 17 years. She is an honorary secretary, Association of Diabetes Educator. She writes regular columns in health and nutrition for 18 years. She has been the co-editor of IDA's latest clinical diabetic manual and has authored chapters from various textbooks. Now let's welcome Niti Desai ma'am and hear it out from her as in what oils do we choose.
Thank you very much for the kind words. On the outset, I would like to thank the DRS team and doctors Purvi and Manoj Chawla and Cheryl for having me here. So we are continuing the series on the dietary dilemmas. I'm sure all of you will agree that this is one of the most common and frequently asked question in a clinic. Which oil should I be using? So again, we all agree that we do need to bother about fat in diabetes also because diabetes is associated with 3 to 4-fold increase in the risk of CHD. Nearly all diabetics have one or more lipid abnormalities. And fat intake, of course, contributes calorie only second to carbohydrate intake. So there is a significant footprint of the fat in our diet. Specifically, the saturated fats increase insulin resistance, while the MUFA and the PUFA decrease insulin resistance. So again, one more reason why we do need to talk about fats in diabetes. So we are always looking at a low-fat diet and not a no-fat diet. Very often we see very enthusiastic patients who are trying to follow a no-fat diet. That is not required at all. And there are two most important factors which we need to consider while talking about fats is of course the quality of fat and the quantity, both of which we will be discussing. Now the story of fat has been a saga. In the 80s, we were told that we have to avoid fat altogether. In the 90s, we were supposed to replace the bad fats, the fats with carbohydrates, which in hindsight was considered a disastrous decision. And now here we are, where we have the latest ICMR NIN guidelines, which tells us that the fat should contribute less than 30% of daily calories, which could be coming from the visible fat, which is basically the fat we use at the table or in cooking, the invisible fat, which is inherently present in all the foods, be it cereals or pulses or dairy, and of course the hidden fat, which is found in processed and ready to eat foods, which we are all supposed to avoid. Today, we are obviously going to be talking more about the visible fat. That is what is our topic. Now, as the quality of invisible fat cannot be changed much, the amount of fat which is inherently in cereals and pulses, the intake of visible fat acquires added significance because it is amenable to modification. It's something which we can change. And in fact, we do find in practice that this is one of the easiest and most actionable dietary changes that can be brought about because there is high compliance. Everyone asks you, which oil should I be using? And most of them are ready to do that. We might have to negotiate to initiate physical activity, to cut down carbs. There will be a lot of resistance, excuses for that. But the change of oil most of the time is one of the easiest step that can be taken. So again, the latest guidelines show us that the visible fat should contribute around 15% of the calories. I don't know whether I can use this. Yes, uh, 15% of the calories should be coming from visible fat. And in numerical terms, basically for an adult man, sedentary man, it would mean 25 grams of fat, which is basically 5 teaspoons of oil. And for a sedentary adult woman, it would be 20 grams of fat. And this is what generally we see in practice, which is 4 teaspoons of oil. Now, all fats and oils are basically composed of glycerides or fatty acids, which make up 95 to 99% of the composition. And then there is a very small non-glyceride component, which would be the tocopherols, the lignans, the phytosterols. A very small component, but they have multiple health benefits. They have antioxidant in nature, they're anti-inflammatory, and of course, hypocholesterolemic. So are all fatty acids the same? Now, all oils consist of three types of fatty acids in varying proportions. And these three types are basically differentiated on the basis of structure, as you can see in the diagram. The saturated fatty acids have the hydrogen atom. There is no bond which is double bond or unsaturated. Monounsaturated, as the name says, has a single double bond, while the poly will have multiple double bonds. And based on the highest proportion, the edible oils or the fats are classified. They are PUFA rich or MUFA rich. Now, again, the guidelines further tell us that of the 30% fat calories that we are looking at, 10% should be coming from sat fat, 10 and 10% each from MUFA and PUFA. Besides that, this is something we need to keep in mind, and the guidelines tell us that we obviously need to get the essential fatty acids from the diet, because these are the fatty acids which the body cannot synthesize and have to be obtained externally. These basically comprise of N6, the linoleic acid, which is a precursor for all the long chain PUFAs, and the N3 or the alpha linolenic acid, the ALA, which is again cannot be synthesized, and it's a precursor for DHA and EPA. We all know that these are N3 acids which are very fatty acids which are very important. And in fact, the guidelines tell us that even the DHA and EPA should be had, some amount should be had from the diet, because the conversion of N3 to DPA and EHA is a rate limiting step, and we do not get the full conversion. So it's like if you eat a lot of N3, that does not mean you will get sufficient EPA and DHA. Further, again, to add to the complexity and the confusion, the RDA for ALA is 1.6 grams for men and 1.1 gram for women. And at least 10% of the ALA should be contributed by EPA and DHA, as I just mentioned. ICMR also quotes FAO, Food and Agricultural Organization, recommendation that 300 milligrams of EPA and DHA should be had per day, of which 100 milligrams should be EPA and 200 milligrams should be DHA. This adequate intake and the optimum balance. The balance is what I'm emphasizing between the N6 and N3 is also very necessary, even for the prevention of metabolic syndrome. So the ideal ratio that we are looking at between N6 and N3 is 5 to 10 is to 1. But the problem is that the Indian diet is giving us a ratio of 20 is to 1, which means that we are taking a lot more N6. And N6 is there in most of the oils, the long chain PUFAs. So we're getting sufficient or more than sufficient of N6. The challenge is to get sufficient N3 to adjust this ratio. So this is the prescription for the oils. We want a PUFA, MUFA, sat-fat ratio of 1 is to 1 is to 1, and then N6, N3 of 5 to 10 is to 1. So we are in the search for this oil, okay? Now, the consumption of oils in India is obviously driven by, since ages, by the local preferences and of course the availability, and not by the ICMR guidelines. So in the West, it is primarily groundnut oil. In the East, a lot of mustard oil is used, while in the South, we do use a lot of coconut and till oil. if you can see this, check in this diagram, this graphic, where it is the fatty acid composition of vegetable oil is shown, there is no equal red, green, and blue bar, which means that there is no 1:1:1. And the N3, which is shown by the yellow bar, you can see that very few oils have got N3. Um, so most oils are not close to the ICMR and recommendations to achieve the desirable ratio that we are looking out for. And therefore, again, the guidelines suggest that we should be using either a combination, a correct combination of oils, or a blend of commercial blend of vegetable oils to achieve the intake of all kinds of fatty acids. So in very simple terms, either we need to tell our patients to use a combination of oils, so which is very often done more commonly in the East. Some dishes are prepared in the mustard oil and the other dishes are prepared in another oil. So prepare some foods in one and some foods in another. Use a combination of oils. Use a commercial blend of oil, or rotate oils, as Kavita was just mentioning about rotating millets. Rotate oils, we ask our patients to, every time you buy a oil, you buy a different oil. There also we've seen that people have been buying the same vegetable oil or sunflower oil, but different brands. That is not what we are looking at. It has to be a different vegetable oil. So again, there are recommended oil combinations. So if you've been traditionally using groundnut, til, cottonseed or rice bran oil, then one must also use along with it either mustard, canola or soybean to get the ratio right. And of course, there are various blended oil combinations available in the market. Um, at the moment, the combination, a blend of rice bran and soybean seems to be ideal. So again, a common question asked, can we blend at home when we suggest buying blended oils? They say, why can't I have 2, 3 oils, I'll just mix them at home and use them. This is a activity which has to be actively discouraged. It is not possible to mix oils at home. Mixing of oils at home is not allowed for various challenges that I've mentioned here. I won't go into the details there, but if you want to use a blended oil, it has to be a commercially blended oil. So besides using this combination of oils to get this ratio right, there are other ways also where we can work on this ratio. There are certain families where there are seniors, there's a joint family, and the seniors are completely resisting to change the oil because they are used to using a groundnut oil or whatever. So then there are other ways also. So to meet the N3 requirements for a non-vegetarian, it is easy. If one includes 250 grams of marine or freshwater oily fish per week, then one meets one's N3 requirements. And these are the common Indian fish which will do the job. Okay. For there is also now krill oil supplements available. The omega-3 in the krill oil is even more bioavailable than the fish oil because it's present in the phospholipid form. So even vegetarians who are open to taking a capsule can be offered this. But then we also have very strict vegetarians who refuse to take any fish oil supplements also. Then there are algal oil supplements. So basically it's the marine algae which produces or synthesizes the EPA and DHA, and that is what actually goes into the food chain, and that's how the fish also have it. So the vegetarians can do with algal oil supplements, which are available now. And for those who do not want to take any supplements, of course, we would suggest foods which are rich in ALA, plant foods. But the caveat here is, as I mentioned, it's a rate limiting step. Not all of it is going to be converted to EPA and DHA. Whenever we start discussing oils in the clinic, and I would ask what is the monthly consumption, lot of patients will say, oh, I use olive oil. So it's the like ticket to good health. You don't need to ask me how much I use because it's olive oil. I can use any amount. Uh, Obviously not true. Of course, olive oil is one of the richest sources of MUFA, and enough studies and meta-analysis has shown that extra virgin olive oil has lot of benefits, especially when it's a part of a Mediterranean diet. If we are going to have extra virgin olive oil with our vada pav and samosa, I don't know how beneficial it remains. It is. Uh, and when we are talking about Indian foods, Indian cooking, there are some drawbacks. First of all, olive oil has a very low smoke point, extra virgin olive oil. So it cannot be used for Indian cooking. Uh, and also there are other challenges of increased carbon footprint because we are importing it, and of course the cost. Also, traditionally, we have enough locally available sources of MUFA. So we have a mustard oil, rice bran oil, and of course, all the nuts. So it's not that olive oil is the answer. Again, cold press versus refined oils, another ticket to good health. Everybody started using cold press oils. I need to make clear that there are only some cooking oils that can be even thought of eaten raw or as kachi ghani ka tel, which is coconut, mustard, sesame, groundnut, and olive oil, while other oils have to be refined to make them edible. So sunflower, soybean, rice bran, corn, cottonseed have to be refined. They cannot be had raw. Uh, Kachigani oils are more healthy. Yes, well, they have better flavor. The antioxidants are retained. But along with that, there are some undesirable products such as the gums and the waxes and the pesticide residues and some allergens which will also be retained. Also, most importantly, these oils have a short shelf life and hence cannot be stored for long. I think this one needs to emphasize. The patients need to buy them. First of all, identify a source where you can get it fresh. If it's lying on a supermarket shelf, we don't know how long it's been there. Buy in very small batches and use it up in few weeks or a month. These are not the oils which can be stored. I mean, there are families which store oil for 6 months and even for a year. So kachi ghani cannot be used in the traditional way.
Ma'am, we running out of time.
Ghee and coconut,
Ma'am, we running out of time.
yes.
Continue, finish.
Yeah, I'll just finish. Give me 2 minutes. Ghee and coconut, again, ongoing controversy, to be used or not. So the the controversy is that these are short chain saturated fats, and perhaps they are not as harmful. However, on coconut, the American Heart Association advisory tells us that coconut oil increases LDL cholesterol and it has no known offsetting favorable effects, and therefore advice is against the use of coconut oil. Ghee is to be used in moderation and not as the sole cooking medium, which again, a lot of people are turning to using ghee as the sole cooking medium. Everything is being cooked in ghee. That is not what we are looking at. Trans fat, we all know we need to avoid because it completely disrupts the lipid profile. And the most common sources of trans fatty acids are, of course, the partially hydrogenated vegetable oil, what we call vanaspati. Besides that, the margarine, the commercially baked products like khari, butter, cookies, and of course, oil which is continuously being used for frying and refrying also has a lot of trans fat. Margarine versus butter, again, an ongoing controversy. Margarine has trans fat, though now we have margarines which are trans fat free, but you cannot forget that they still have all the calories. Uh, Indian cooking, because we are keeping the oil on gas for a very long time, from tadka to sauteing ginger and garlic, uh, we need to make, and of course frying, which is a very common practice whether we like it or not. The PUFA in the oil is obviously an unstable entity because of multiple double bonds, and therefore it's susceptible to oxidation. Lot of total polar compounds are produced on frying and refrying, and in fact FSSI has fixed a limit for the amount of TPC that can be in the oil. So avoid using oil for refrying. These are some good practices for frying. Use an antioxidant fortified oil for its stability. Do not use oil for refrying. Filter the oil after frying and reuse it in next 1 or 2 days. Do not add fresh oil to the oil because it is less in kadai, so you add more fresh oil and refry it. Don't do that. So I leave you with this take home message. Thank you for your attention.
We'll take the questions later.
Sure.
Okay. Separating facts from fiction, salt and sugar. Let us invite Nazneen Hussain ma'am as she uncovers the truth behind these two essential ingredients, debunking myths and revealing surprising facts to help us make informed choices and healthier lifestyle decisions. She is a founder director at Freedom Wellness Management, co-founder at Shamrock NutraScience, a digital nutrition app and software company, nutritional executive committee of IDA, nutritional advisor at Indian Navy, INHS Hamla Joint Service Training Institute, advisor and consultant to nutraceutical companies and food corporates, nutritional counselor for famous sports nutrition celebrities and Bollywood actors. So let us invite Nazneen Hussain ma'am and understand salt and sugar getting the facts right.
Thank you, Vidya. At the onset, a big thank you to Dr. Manoj Chawla and Purvi Chawla for inviting us. A big thank you to our very dynamic chairpersons, Vidya, Anam, and Ami. Uh, it's a very, very interesting discussion. If I were to begin to say that agar aaj khane mein salt, supposing Western people didn't forgot to put salt, would we like to eat it? No. Okay. अगर खाने के बाद डेजर्ट सेक्शन भूल गए लगाना, would we like it? Yes? How many people said yes? So nobody goes there today. Okay. I think the problem with the salt and sugar is beyond the taste. It's behavioral, it's integrated. Huh? In India, we right from मीठी मीठी चाशनी to समंदर में नहा के और भी नमकीन हो गए. I think we use salt, sugar, चीनी कम in almost everything. We call our loved ones honey, and I think that expression is far beyond. And when you look at the tongue, there is 2 inches of muscle which rule the world. One by the way we eat, and the way we speak. And I think both salt and sugar are very predominant flavors. Now, talking about sugar, we've seen a huge trend in, sorry, can I make this bigger? We've seen the entire trends of sugar consumption changing drastically. Earlier, जब हम छोटे थे, वीक में एक बार मीठा मिलता था. Today, somewhere we see there are so many sweet meats, so many bakeries, so many smaller kiosks which have opened, and the consumption of sugar is actually rampant. Now let's look at what is the recommended sugar amount. Okay, so the AHA and the WHO actually recommend not more than 10% of total sugar to be added, and this should not increase more than 200 calories in the day for an average adult. The other thing is that sugar free. Okay, here this should not make up to more than 5% of the total day's requirement and should not exceed more than 30 grams. So a simple cup of chai, how much sugar would one add? Begins from one small teaspoon of 5 grams. कुछ लोगों को ज़्यादा मीठा लगता है तो 10 grams. And they'll have this chai or coffee at least twice a day. So उतना तो added sugar वहीं पर आ गया. Right? Plus you would have the biscuits what Cheryl has mentioned and a whole lot of other foods. So I think the amount of added sugar is much higher. Now when we look at added sugar, first of all, is honey sugar? Is jaggery sugar? So all of this, it's not only sugar, but honey, jaggery, all of it is still sugar. So many a times patients say that, अरे मैम ये तो हमने ना गुड़ में बनाया था, हम अब नॉर्मल चीनी वाली चाय नहीं पीते, गुड़ की चाय पीते हैं. But it is still sugar. It is still added sugar. So that concept needs to be very, very clear. Okay. Besides that, we have sugars which are present in the naturally occurring form. So these could be your fruits. If you're further having fruit juices, the fructose content also drastically increases. Just in case if you're having a commercial juice, there will be added sugars to it as well. So sugar, all in forms of sucrose, fructose, all of it is still sugar. Now, when you look at this, there has been some amount of work around the sugar reduction. However, I think people are generally getting addicted to sugar. And when you look at the effect of sugar replacement with stevia-based tablespoon sweeteners, there have been favorable studies. However, many a times when we tell people sugar free bana ke khao, so they think it's a free food. So either they will add more oil, more ghee, more salt, or they will think that sugar free hai to iska quantity zyada kha lo. So all of it still becomes more a problem, because somewhere the portion control is also skewed. So even though you can have stevia based foods, the quantity still needs to be maintained. Now, sugar sweetened beverages, this seems to be a big problem, and there seems to be a growing trend in a lot of young population and a lot of young Gen Z population. So right from the aerated waters to protein waters to a lot of juices, all of them are sugar. And we know that today the cardiometabolic outcomes are very high. Even incidences of dental caries is high. And overall, we see that there is increased amount of mortality and frailty in adults. We all know of the Framingham study. This was one of the largest cohort studies. Here, what they realized was that the more frequent consumption of sugar sweetened beverages significantly increase the liver fat and dysbiosis. Just as people love sugar, so do the gut bacteria also love sugar, and the more you see an entire anti-inflammatory response to more sugar, and a complete dysbiosis then happens. Also, the HDL level drastically starts dropping down, and there is an increased triglyceride level. Today, when you look at sugar, it also impacts the telomere health. And this was a study which was done in very young school, 61 preschool children. And what they realized was that the moment the sugar content was increased, this was straight away correlated with decrease of telomere health. So we're not even talking about an aging population. We're talking about very, very young kids here. And that itself is also, uh, kind of drastically affecting on the cellular age. Okay, so sugar again has a tremendous impact on the hypothalamic pituitary and leads to a lot of inflammation. And we see that overall, there is a altered gut microbiota, and excess consumption today also affects mental health. It may lead to more depression, and the stress response is very high. Also, there are various studies correlated with sugar and depression, and there seems to be a direct impact on the neurotransmitter production function. Diabetes of the skin, consuming sugary foods definitely would see a spike in sugar and in the insulin. It also increases the androgen secretion, and thereby leading to a lot of acne development. So one thing you got to understand, that if a patient continuously says that मीठा खाने का मन हो रहा है, These could directly be correlated with insufficient proteins in the food. So the moment you spike up your protein content, these sugar cravings will automatically start dropping off. The next problem is the salt. Okay, we know salt is important. If you see the traditional Ayurvedic uh, plate, the banana leaf meal, what is the first thing they put on the left hand side? Salt. थोड़ा सा salt. खाना खाते हैं पहले salt चखते हैं, right? थोड़ा सा अचार, थोड़ा सा मीठा हमेशा होता है. But if you see, they were put on the left hand side of the kele ka pata, which means that you're supposed to eat little. So you enjoy all the flavors, but eat it little. But now what happens is that portion slowly shifting on the right, and the fruits and vegetables are actually shifting on the left. So we're reducing the fruit consumption and increasing the sweet and the salt consumption. And that is how the traditional diet has changed. So when you're looking at salt, okay, salt, sodium chloride, the WHO obviously has given very, very strict instructions, around 5 grams of total salt per day. Besides that, salt also appears as food additives, preservatives. It's used in food preservation of food quality, improved color and texture, flavor, and extended shelf life. Yeah. So 1 teaspoon, which is equal to close to around 2,300 milligrams of sodium, that is the entire day's requirement. But how much salt can somebody guess an average Indian eats? 12 to 15, even 20 or 25. So अगर खाने में अचार नहीं है, people crib. पापड़ चाहिए, कुरकुरी चाहिए, हाँ, सुबह को फाफड़ा चाहिए. So all of these are very, very hidden sources of salt and which drastically increase. So when you talk about 1 teaspoon of salt, and this is an experiment I would like all of you all to do in your clinics, is 1 teaspoon means level teaspoon. Chota chammach leveled. If you look at a heaped teaspoon, it's almost 7 to 8 grams, and a tablespoon is 15 to 18 grams. So it's very important to tell the homemaker that this 1 teaspoon is the entire day's requirement for breakfast, lunch, dinner, evening, and that doesn't mean you can bring samosa, farsan, and chips from outside. So it's an inclusion of all of that. We know that high salt is directly related to inflammation. There are plenty of studies here, and if you see that if the salt content, these were two very interesting studies. Here, when the patients consumed around 12 grams, there were higher number of immune monocytes compared to while they were on a lower salt diet. The moment they switched over to the lower salt diet, they realized that there was a reduction in the monocytes. It reduced the pro-inflammatory cytokines, especially the IL-6 and IL-23, and enhanced production of anti-inflammatory IL-10 was there. So even you can correct it. The message here is you can correct it now. You don't have to wait for a very long time. अगर एक हफ्ते में अगर आपने salt कम कर दिया and you maintain it, you automatically see the changes immediately. Okay. Today, salt also has a direct impact on RA, and patients with rheumatoid arthritis have seen, you see a total amount of salt excretion is very high. So again, dietary restriction of sodium intake will greatly help. Okay. Also, a lot of connection with asthma and salt, and low dietary salt intake was associated with decreased airway hyper responsive in asthmatic patients. So overall, reducing salt helps. It also helps in conditions of multiple sclerosis, and patients with high or medium salt here again had very high lesions. The moment they started cutting down, the number of lesions also greatly reduced. Excess salt can also increase the risk of dementia, especially in older adults. And in older adults, this is more of a problem because they're losing the sensation in the mouth. And so always they want to eat a little more
saltier food than normal. But then again, the chances of dementia, there are a lot of evidence which is directly related. Hypertension and blood pressure both are major risk factors for dementia, and hence cutting of salt is a very important thing. Salt and gut microbiome, just if you go back, just a simple way to explain to patients that if you were to preserve any pickle, what would you add in the pickle? Salt, because it would reduce the bacterial growth. Likewise, in the gut, if there is more salt, the good bacteria, the probiotic bacteria actually reduce, and that completely offsets the gut and leads to a lot of dysbiosis. And a lot of animal studies as well as human studies completely correlate on that. Today, a lot of inflammatory bowel disorders are seen. We see a lot of patients with Crohn's, with celiac, with IBD. IBD is multifactorial, but salt definitely is one of the leading, excess salt is one of the leading causes why IBD can be further triggered. High salt intake and nitric oxide production in IBD patients. The moment the salt increases, we see that there is a limited increase in the arginase level in the chronically inflamed gut microvascular and endothelial cells, especially in the IBD patients, and directly the blood pressure is increased. All the other ultra processed foods, so whilst Neeti and Cheryl both spoke about the ultra processed foods, it is very important to see that either be it a high sugar sweetened beverage or a snack, something like a chip, like the ad says, no one can just eat one, because when the salt hits your palate, you're tempted to eat much more than your normal quantity. All of these further kind of are extremely high in salt and sugar both. Uh, Salt in packaged foods is high. Today, we all look at convenience foods, so please look at the labels for salt, right from your sauces, breakfast cereals, bakery items, cakes and cookies. Almost all of them will have sodium in different formats, and one should be careful. Even a lot of processed meats have tremendous amount of sodium, and you have to kind of educate your patients that at least if they have to use meat, use the leaner varieties of meat, and do not take too much of processed meats.
Ma'am, we're running out of time.
Yes, I am just winding up. Okay, so I think the take home message is, whether it is kala namak, shenda namak, and any of the salt, salt is salt. A restriction is required. Don't keep a salt shaker on your table. Look, don't add chaat masala on the bhajiyas and the kebabs to top up everything. Whether it is black salt or any other salt, it's all in the family. So go slow and with it, and be mindful of what you're eating. And sugar and salt, more than taste, are behavioral changes. And I think a lot of public campaigns need to be done, because it's changing mindset. So to change that acquired taste is a very difficult thing, and we really will have to work a lot with our patients to educate them on that. Thank you so much.
Thank you, ma'am. It's my pleasure to introduce Neha Pandit, ma'am, a respected expert in the field of nutrition. Today, she'll be speaking on snack right in diabetes, offering practical tips to help manage blood sugar while making smart snack choices. Please join me in welcoming Neha, ma'am. Neha, ma'am, is a founder and nutritionist at Snack Right, a super healthy dry snack delivery service. She has been awarded Nutripreneur of the Year by Indian Dietetic Association. She has received gold medal by the MS University, Vadodara. Let's hear it from Neha Pandit, ma'am.
Tilly's setting up.
Thank you so much for being here. And I think after all the important diet related topics like fats and millets, sugars, and sodium, I am going to talk about something which is really ignored or not discussed a lot when we talk about diets. But I hope that after today's session, you change your mindset about snacks. So let me start the presentation. Okay, so because I'm a dietitian, but I also belong to the food industry, so I am going to throw off some numbers to you. The Indian packaged food industry right now is valued at a huge 4.2 lakh crore. And let me tell you, that's a really big number. And surprisingly, from that, the contribution of just snack foods is 40%. So, and the growth, year on year growth in this packed food industry is really starking, which somehow tells us that even though we always keep saying that Indians like to prepare their own foods, we still make food at home, we make food from scratch, but the demand for the packed foods is also increasing a lot. So we need to accept that somewhere and accordingly make our recommendations also. But when we say snack, I'm sorry I'm going to torture you just before lunch with some amazing pictures, but hold on for a very short time. So when we say snack, we really don't have a definition. We know what a meal is supposed to be, but snack, right from peanuts to chana to bhujia to dokla to even a idli or dosa, everything categorizes as a snack food. So that is a big confusion that what can be called as a snack. And secondly, especially in today's times, the lines are really blurring between a snack and a meal. And this blurring lines is what this like we like to make up new terms. So today the new term which is coming up is snackification. So it is called as snackification because lot of people nowadays prefer to have snacks instead of meals. Okay, so rather than having the traditional square meals of roti, sabzi, dal, chawal, people prefer having snacks. And that tradition change is something which we all have accepted, okay? And can some of you think of examples like wherein you yourself or your patients are having snacks instead of meals? Pani puri for dinner, yes. Sunday brunches, yes, we call it a Sunday brunch. We go to eat at 11 o'clock and then 3 o'clock people will come back and say, okay, abhi kya khana hai ghar pe? So there is confusion. Other than that, we have so many families having misal pav or sev puri, pani puri, like she said, or pasta or pizza as main dinners. And we are really happy about it. We say that हमारे घर पे पूरा खाना नहीं बनता है, हमें one pot, one snack meal अच्छा लगता है. So we really don't know what is a snack and what is a meal. And apart from that, there is every year we have snacking reports also. So 88% of people still say that they have to have a daily snack. And even though concepts of fasting and one meal a day is coming up, still 60% of people, they say that they prefer small frequent meals rather than having large meals. Now, we are really ready to eat all the ready to eats. What I mean is the acceptability for ready to eat foods is also increasing a lot. Now, this includes everything: the bakery, dairy, canned food, frozen food, the ready to eat gravies, snacks, processed meats are also coming up big way. And about 80% of urban population, they say that they are okay to have ready to eat foods in their meals. Now, the reason for this can be several. Our lifestyle, we are very happy to always say, abhi lifestyle hi aisi ho chuki hai that, it's a part of our lives. So lifestyle, long work hours, or increasing disposable incomes, or the nuclear family style. Accessibility is something which really we need to be aware of. And even though this report is for urban population, the accessibility through Zomato, Swiggy, and all these services, even in tier 2, tier 3 cities, the snack food and fast food is easily available across the nation. So that is something which we need to be aware of. And on one side, we say that people are, conscious about eating healthy or making healthier choices, but still 75% of people across generations, they say that taste is the most important factor for them. So even though I give them the best of the healthiest snack, until and unless it is tasty, they are not going to choose it as a everyday thing. And why this is important? Because that is why all the healthy snacks also come with the addition of salt, sugar, and all. Nazneen ma'am just explained how salt and sugar can get us into addiction. So those two are biggest part of our snacks. And while mindful eating is rising, we still see that the most popularly consumed snacks are still basic chips and varieties, nachos coming up second, and biscuits, cookies, followed by our traditional Indian snacks like murukku, bhujia, and matri, namkeen. Nothing is still matching to that level. So make how many ever energy bars and roasted chips, but it is not catching up to this category up till now. So why do we need to focus on snacking in diabetics? Of course, I told you the reasons above that snack is no more just a evening thing or small part of the meal. And also, we all know the latest numbers of diabetes. We have the ICMR India study, which has shown us that we were underestimating the numbers. The numbers are a lot higher in our country. And when we concentrate on, focusing on better planned snacks, it gives us an opportunity to look at, monitoring or regulating the blood glucose levels better, preventing the hypoglycemia episodes, plus also adding in the missing nutrients in our diet. Snacks can become an excellent opportunity to add on those missing nutrients and minerals. Also, good way to spread out the carbs. Sometimes lunch and dinner is difficult to manage the carb balance through the day, so snack can help us. And I personally feel that customizing snacks is easier rather than making them change the entire lunch and dinner, which they are typically used to and they don't want to modify that. So then what kind of snacks do we choose and what do we avoid, right? That is the question which I hope to answer through this session ultimately. Some very, very obvious things we all know that we need to keep away from and steer clear. That is the high sugar and processed foods, which are obvious. We know biscuits, cakes, cookies, flavored yogurts. Uh, Naked refined carbohydrates we need to be aware of. Then liquid calorie bombs. Sometimes some trends catch up so much, people feel that if they're having a smoothie, it's like a super healthy thing. But again, we don't have any definition of smoothie. It can be a calorie bomb, a sugar bomb. So liquid calories, definitely people with diabetes need to stay away from. Deep fried foods, obviously, and high sodium foods, as covered by all my previous speakers, that it is something a big concern. High sodium foods and deep fried foods, especially in the snacking part, we need to really be aware of. So all the instant foods nowadays, like even if it is oats, the instant masala oats, instant soups, the ads also promote it in such an amazing way. The soup packet, 10 rupee packet, you're hungry, and beach ki bhook ke liye soup is super healthy, but definitely not the instant 2-minute soup and pastas and noodles. So definitely all those need to go out from our kitchen cabinets. What are the concerns? So before I give you the snacks, I would like to discuss a few concerns in case of snacking, because we talk so much about lunch, dinner, and breakfast that snacking, like I told you, is like ignored a lot. So overeating of healthy snacks is a trend which is very, very common today, and it leads to unnecessary calorie gains and blood sugar fluctuations. So how do we handle that? Educating the patients about portion control is very important, and suggesting them to pre-portion their snacks. Ordering large family size packs, or eating directly from the dabba is definitely not a good choice, because like ma'am said, no one can eat just one. We tell ourselves that I'm going to have a small portion, but if you have the dabba and some web series going on, forget it, the entire dabba is over before you realize it. So portioning out is extremely important. Nowadays we do have brands which are encouraging small portion packs. So you could consider that if you don't have self control. Mindless snacking, out of stress, out of boredom, out of social media cues. Even all these food delivery apps, they have such smart advertising algorithms that exactly at 5 o'clock I start getting those notifications that order this food, you have a deal on this and that. So these social cues also unnecessary tell us to order foods. Firstly, we need to disable those notifications. And second, another concern, I am a diabetic and I need to eat every 2 hours. This other recommendations, I don't know how much they will listen, but this recommendation, they will always listen that I need to eat every 2 hours. So this also many a times leads to unnecessary snacking and extra calorie and carbohydrate intake, and gets difficult to manage our insulin responses also. So solution, of course, we encourage mindful eating. We explain to them why it is important to plan out the entire days routine, the meal plan, not just lunch and dinner, but also snacks need to be planned with the diabetes patient, so that the spontaneous consumption is not happening. Hidden sugars and sodium, we got very good examples from the previous talks, and it's a big problem, especially in health foods. It's very easy to say that patients need to do this, need to do that, but we understand that taking care of all the aspects sometimes can become very difficult for them also. So we need to help them to make better choices. So teach patients to read food labels. That is going to be very, very important. Another big concern in snacking is that once a particular thing they understand that it's healthy, they just constantly want to eat that. First, it is some, sing chana, some dietitian tells have sing chana, some dietitians tells, okay, yogurt is the healthiest food. Then we have a trend of makhanas, and then day in and day out, they keep having the same food. So this lack of nutrient variety is also a big concern. Even in snacks, we need to get in more variety, more food groups, and balanced nutrition for more diet diversity. So then, basic bottom line of all this is we need to handle two things. One, patient education and planning out all their meals along with them. And this is where diabetes educators or dietitians come in and play a very big role, because they can actually spend time with the patient in planning out all these things. So what makes a good snack? A few basic things which will always work. Talk about portions, glycemic index, and this one term I came across last year on Instagram. It says, dress up the naked carbs. Okay, what is a naked carb? Something, a plain carb, like just a white bread or just a potato. When I say dress up, it means you dress it up with a protein or a fiber or a fat. So when you dress up your carbs, the rise in blood sugar is going to be much lower. It's not going to shoot up. So rather than, sometimes you're traveling and you don't have anything, you just have a white bread. So rather than having a plain toast, it's better if you could have a peanut butter with the toast, or just have nuts on the side, or some fiber rich food, or even a vegetable sandwich for that matter would be better than choosing a plain white bread. So that is how you dress up. And one very, very important thing, I think one previous question also was asked, were that what should be recommended for diabetes patients? Extremely important to take care of individual responses. So, for example, something super healthy and super amazing like a ragi idli might raise the blood glucose levels a lot compared to a dosa made with butter also. We feel that dosa has oil and it has butter, so better you have a steamed idli which is made with millets. But that's not always the case. You need to see how that particular patient is responding to that particular snack. Similarly, fruit, which is considered like one of the best snacks, but not the case always. Sometimes a plain fruit might not be good. Instead, maybe a small batata vada might have a better response in your patient. So such stereotypes we need to stay away from and make in choices based on the individual responses. So here are some examples. Now, when we are at home, we have the liberty to make better snack choices, make fresh food. So something like a sprout chart, vegetables and fruits with nut butters, hummus or curd dips, cutlets. Often we would have extra chapatis or extra rice at home. Make some snack out of it like a wrap or a frankie. Dry snacks options are there. Our traditional chiodas and murmuras can be modified with addition of nuts and soy nuts. Even date-based laddus or energy bars, if made correctly, can be a good filling, satiety-inducing snack for diabetics. If they are buying the baked ones and healthy ones, then they should definitely first read the label and ask the dietitian if it is really a good snack. When you are traveling, that is the biggest concern. People feel they justify that because I'm outside, I can, eat unhealthy snacks. Give me just 1 minute more. So even when traveling, if you are planning, it is possible to eat healthy. Firstly, I feel carrying a dabba from home needs to be a new normal. Even in formal places like a conference or a meeting or some big seminar, I think you should show off your dabba that I care for my health and I'm carrying a snack dabba. That needs to be normalized, and it need not be something fancy. It can be just simple nuts and seeds and chana or whatever you like. And even when traveling today, a lot of hotels are happy to customize for you. So telling simple things like don't add butter or no cheese, no mayo, no ghee, all these customizations are possible if we know what is the right snack for us. And especially in India, I think we have a lot of options to choose from. Once you know what is right for you, that is very, very important. Plus, we do have many genuine brands of healthy snacks also coming up, so you could explore that. Cost factor needs to be taken care of. A lot of even health professionals would recommend protein bars, energy bars, granola, makhana, which are super expensive to have healthy every day for a common man. So you need to look out for local substitutes and local options, and it is possible. Believe me, it's not that you have to spend extra on health. So what I would say is, the survey says that for more than 70% people, tea time is something they love to enjoy. So let us, as health professionals, help them to enjoy this time and not make them sacrifice their favorite time of the day, that is tea time. And it is possible through assessment of individual preferences, take into mind their health goals, monitor the responses, planning out, there is no substitute for planning your meals, provide variety to avoid the monotony. Nutrition literacy needs to be our focus now, especially if we have patients with diabetes. And lastly, not everyone needs to snack. It is not a compulsion that just because you are having diabetes, you need to snack. So we need to get that out and customize all kinds of all the diet, whether it's breakfast, lunch, snack, or dinner for our patients, so that they have better blood sugar control and we can help have a better change in this snackification trend. Thank you so much. I hope I would have some time for questions, if any.
Ma'am, we can take 1 to 2 questions.
I don't think so. Snacks people would have a lot of questions, but we can connect later if anything. Thank you so much.
Thank you, ma'am. It takes immense pleasure for me thanking all our dear dietitians for sharing your expertise with us today. Your insights on oils, healthy snackings, reading labels, um, salt, sugar, millets have empowered us to make informed choices. Your passion and dedication have inspired us to take control on our well being. We are grateful for your contribution to our journey towards healthier living. Thank you all again. I would request you all to come on the stage for a photo.
Good afternoon, respected dignitaries and my dear friends. Welcome to the DRS WCPD Diabetes Educators Award of Excellence ceremony. I am Cheryl Salis. I'm sure you all have met me this morning while I spoke on food labels, but I have the honor and pleasure of being the master of ceremony, thanks to Dr. Purvi and Dr. Manoj for this much awaited event. I'm sure it's one of the most awaited events for all our students and all the people who are receiving awards. A little bit about NDP. It is the National Diabetes Educators Program, and it is supported by USC. I think this is very important because there's a lot of support, there's a lot of work that is being done in the background by USV, which is one of the leading companies which is supporting a lot of these conferences, supporting a lot of educators. It is the first and unique National Diabetes Educator Program in India. And like I was telling you, it is even recognized in other countries, even in the US. So you can imagine it really holds a lot of value. It is now in its 14th year, and now going back, I can think of I think the first or the second batch. Okay, so it's in the 14th year, and it has certified more than 24,000 educators in the country. So a big round of applause and a big thank you to USC. We have Shashikala here. I have to mention Farida ma'am and everybody else from the team. And it is under the guidance of our very own respected and renowned Dr. Mohan sir and Dr. Shashank Joshi sir. In this Diabetes Educator Excellence Award ceremony, we are going to be recognizing our past NDP students. I think this is again very interesting. You know, we keep doing good work, but it's very important. I think we all need that recognition because that motivates us to continue doing good work going forward. And this is recognizing all the diabetes educators, not only in the city of Mumbai, but even the outskirts of Mumbai. And it is my honor and pleasure to invite our respected dignitaries on the dais. Let's all rise. Good to stand and welcome with a big round of applause. We have Dr. Mohan sir and Dr. Shashank Joshi sir who will be coming in. So we'll wait for them to come in. But at the beginning, let us invite the president of IDF, Dr. Peter Schwartz. He's joining. Yes, right in time. Sir, up here. Our very own Dr. Bansi Sabu, Chair-elect IDF. So I'd request you to come on the dais. And our organizing chairpersons, Dr. Manoj Chavla and Dr. Purvi Chavla. A big round of applause. Not enough, louder. Remember, even y'all will have this, y'all will need this, right? Okay, I now call upon the awardees of the Diabetes Educators Award of Excellence. And let's have the first awardee. Can we have their names displayed? Okay, it's a very proud moment for me. My very own student, Miss Arshri Shah. Congratulations. Let's clap for each of them. They're doing extraordinary work in the field of diabetes education. Miss Arshri Shah. Clap. Miss Akshita Patel. Can we have a big round of applause for Miss Akshita Patel? Is she here? Okay. So Akshita is not here. Miss Dishani Mehta. Is she here? Not here. Hetal Parekh. Is Hetal here? Miss Kamna Desai. Can we have a big round of applause for Kamna Desai? Khushi is there? Khushi Chhabra is here? Miss Khushi Chhabra? She's not here. Miss Miloni Jayesh Nandu? Can we have a big round of applause for Miloni? Heartiest congratulations, Meloni, Kamna, Akshita, Ashvi. Miss Muskan Agarwal, can we have a big round of applause? Keep clapping. It improves cardiovascular health. Is Parindi Shah? Is Parindi here? Yes. Heartiest congratulations, Parindi. Clap harder. Poonam Pawar. Heartiest congratulations, Poonam. Roma Gupta. Heartiest congratulations, Roma. Big round of applause, please. Keep clapping. Sakshi Matre. Congratulations, Sakshi. Sakshi Satish Gupta. Is Sakshi here? She's here. Sandhya Balram Mandipal. Congratulations. How sweet is that? Big, big round of applause. That's so sweet. Shilpa Shettigar. Is Shilpa here? Shravani Bandwalkar. Oh wow, congratulations. Smriti Tapan, congratulations, Smriti. here. Urvi, yeah, Soma is here. Congratulations, Soma. And Vaishali is very lucky. She also has Dr. Mohan. Welcome, sir. Can we have all of you rise and give a big round of applause? It's truly an honor to be amongst all these dignitaries and to receive it from them. We will definitely have a photo session for all the others who missed it together. And last but not the least, Vidya Gala Shah. Can we have a big round of applause for Vidya? Big round of applause. Heartiest congratulations to all the awardees and hope this recognition motivates you to continue doing the great work you're doing. Can we have all the awardees on stage for a photograph? I've called all the awardees on stage, whoever. I'm feeling bad now that we didn't have this hard time. FOMO. So now let's move on to the convocation ceremony. And at that said, we would like to extend our heartiest congratulations to all of them who are going to be now officially NDP certified diabetes educators. You have a huge role to play in making India the diabetes care capital of the world. So that's a pledge we will all take and make sure that we all contribute in our own way. So can we have Asia Khan? Asia is here. Aditi Teravkar. Is Aditi here? Yeah, come running. Fast. Heartiest congratulations, Aditi. Can we clap? Anamta Najirali Kazi. Anamta is here. Faria Sheikh. Congratulations, Faria, for being the NDP certified diabetes educator. Godsi Zavedi Shah. Godsi is here. Kanchan Rai. Congratulations, Kanchan. Mantasha Inamdar. Is Mantasha here? Muskan Shah. Muskan. Saima Sheikh. Sarita Singh. And last but not the least, Shaheen Sheikh. Is Shaheen here? I think they're all. But heartiest congratulations to each one of them for being now a part of this big army of diabetes educators and hopefully doing our work in making India the diabetes care capital of the world. So thank you so much, respected dignitaries, and to all of you for being there. And you can now go and have your lunch. Okay.
Right. Thank you, Cheryl, for conducting this awards and so gracefully inviting everyone. Thank you so much again for being a part of DRS WCPD this year. Well, gives me great pleasure to invite Dr. Mohan to speak about the NDEP program and the significance and the journey till here. Thank you, sir. Please.
Thank you, Manoj, and thank you, Purvi, Banshi, Peter, and of course, Cheryl. Beautiful event. I'm happy to be here. My flight was delayed, and so they got slightly delayed. My thoughts go back to about 15 years ago when we were attending one of the APICON conferences. And we were just going around the stalls with Farida from USV. And then the thought came at that time, hey, we don't have a single diabetes educator trained in India. And so we should start a course. So Dr. Shashank Joshi was there, Shilpa was there at the time. And so we started along with our education academy, the first National Diabetes Educators Program, NDEP. It was easy for us because we had already started the doctors program one year before that, the certificate course for diabetes, for diabetologists, CCEBDM. So we said on the same model, we'll train educators. What started then has now gone on continuously for 14 years, and 24,000 diabetes educators have been trained all over the country. It was just a passing thought, a passing remark, and that has created 24,000 diabetes educators. Hardly enough. When we're considering we have 101 million people with diabetes, we probably need 3 times or 4 times this number, but it's a good start to have from 0 to go to 24,000. And I think a large part of it is due to the faculty. We have faculty in some 100 centers in India across the country who have been doing it year after year after year. I understand that the last few students who came are Dr. Puri Chawla's students, and I know Cheryl is involved in it, Banshi is involved in it, and all of you, Manoj is involved in it, and Amit is involved. All of you are involved in it. Big thanks to Dr. Shashank Joshi and Shilpa, because it was they who started. We had the Indian Diabetes Educators Association idea, and through that we started it along with the Dr. Mohan's Education Academy. And so I think we have come a long way. And by the way, this is the only course where we have had an evaluation. Even CCBDM has not done that. I remember that because once when Dr. Shaukat Sarikot was there, we had invited him and he made a remark saying, what's the point in doing all this unless you know the impact, unless you evaluate this program? You're just training so many people. What did they do? So this is one of the few programs which has articles written on it in scientific journals as to what they did after they finished their course. How many patients? So imagine 24,000 diet educators. Let's say 100 of them, each one would have trained. I'm putting a very small number, maybe 1,000. So you multiply 24,000 into 100 or 1,000 and you do the maths as to how many lives have been touched. So we also saw improvement in A1C. We saw that in places where no eye examination was done, it's being done. We saw that insulin was being started at the right time. CGMS was being started. CGM was being started and SMBG was being done. So all this came as a result of diabetes educators. Diabetes today cannot be treated by a physician alone. We just don't have the time. And it's due to the educators. If you want to improve the level of the ABC, the A1C, the blood pressure, cholesterol, and the discipline, the ABCD of diabetes, we cannot do it without educators. I think this is single-handedly perhaps one of the largest diabetes educators course outside the US and a few other recognized places where they've been doing it for years. Probably in developing countries, it's probably the largest course. And I wish you continued success. As I always say at the end of my speech, the best is yet to come. Thank you.
Well, we have the pleasure of having the IDF president, Dr. Peter Schwartz, with us. It gives me immense pleasure in welcoming him to speak about the IDF's mission and what IDF is propagating as in the field of diabetes education and for educators. So you
wanted to make a remark. It was one of the earlier IDF presidents who actually inaugurated this program 14 years ago. And so history is now coming back with you coming in to say a few words to us. Thank you.
So thank you very much. I don't want to highlight what is the IDF strategy on a global scale. I want to say one thing, and I'm totally proud of you. And Dr. Mohan just has highlighted there are 24,000 diabetes educators from the last 14 years trained here in India. And this is globally the biggest achievement in diabetes education ever. If you go to Saudi Arabia, there are about less than 10 diabetes educators. Here is a country where the most important point in diabetes education, diabetes care is already fulfilled. And I would like to highlight two words from Dr. Mohan. He said, diabetes cannot treat it by the doctor alone. I would say the most important part in diabetes education and diabetes care is you, because you are talking to the patient. You are, and this is again a word from Dr. Mohan, you are touching the life of the patient. We as physicians, we're touching the diabetes of the patient. We're touching maybe the medication, the therapy of the patient, but you are touching the life of the patient. And this is important, this is more important, and this is the most important thing in diabetes education. That's why it's a very emotional moment for me if you come up here and to hand over the certificate to you, because I'm totally proud of you that you're doing such an excellent work. Thank you very much.
Well, let's have the final word from the man responsible for motivation to many and being the catalyst for many such meetings, Dr. Banshi Sabu.
Thank you, Manoj. First of all, respected Dr. Peter and respected Dr. Mohan. We all are very happy that, we have a National Diabetic Educator Program. Before 14 years, as he thought of that, we should have a National Diabetic Educator Program. We don't have so many diabetes educators. And in diabetes meeting also, we don't find many educator and nutritionists. So my wish is, being a Southeast Asia chair elect for International Diabetic Federation, we should have many more diabetic educator and nutritionists who should actively part in all diabetes meeting, and they should learn more and more about diabetes. As Peter was rightly saying, the diabetologists are taking care of diabetes, but the lives of people with diabetes are touched by diabetes nutritionist and by diabetes educator. With these words, I once again thank Manoj, Purvi for a wonderful program, because every year not only they do the program of this, felicitating all those who have completed their course, but also installing the new members also. We are also doing in Ahmedabad 3-4 centers, in Gujarat, but we would like to have the Dr. Mohan, we would like to have now it in Bangladesh, in Nepal, in other countries of Southeast Asia, the similar national educator program, and which will be endorsed by International Diabetes Federation also. Thank you very much.
Thank you, dignitaries on the stage, and all of you for staying back. We start all our halls exactly at 2 p.m., so you have 5 minutes to finish your lunch and get back. Okay, thank you. Those who planning to get their lunch later, already had lunch, please stay back. We will now move to starting all the three halls and the Kolkata hall at sharp 2 p.m. Enjoy the rest of the meeting, and let me invite all of you to stay back this evening for the inauguration ceremony at 7:30 p.m. Thank you. Thank you, all of you.
Dr. Mikil Kothari. I would like you all to introduce our first speaker for the afternoon, Dr. Ashna Patil on the Hope Symposium. Dr. Ashna Patil.
Good afternoon, everyone. I hope all of you had a very nice lunch, and it's very interesting topic that hypoglycemia, what we're going to discuss now. Little paradoxical, isn't it? After having lunch, we are discussing about hypoglycemia, but I think the loudspeaker that side mics are gone in hypoglycemia; they are not working on that side. So let's start with the hypoglycemia, such a wonderful topic. And we have a first speaker, that's Dr. Ashna Patil. She's going to talk about hypoglycemia causes and its concerns. So Dr. Ashna is basically, she's practicing consultant physician and diabetologist at Arpan Polyclinic and affiliated with Tunga Hospital at Mira Road, member of Indian Medical Association, Indian Podiatry Association, my God, so many associations. United, no, it's okay, madam. We get to know for the first time at least. United Diabetic Forum and Diabetic and Research Foundation, where we are the main part of it now, and Research Society for Studies of Diabetes in India. Actively involved in organizing and participating in initiatives and conferences of DRS and other things. Review of International Journal of Diabetes in developing countries, and contributed many chapters in national and international levels. So let's welcome Dr. Ashna Patil to talk about hypoglycemia. Dr. Ashna.
Thank you so much, sir, for the kind introduction. And a very good afternoon to everyone present here. At the outset, I would like to thank Dr. Manoj Chawla, sir, and Dr. Purvi, ma'am, for giving me the opportunity to be a part of this wonderful scientific symposium. Thank you so much, sir and ma'am. I will be talking on hypoglycemia and causes and concerns. So by definition, any abnormally low plasma glucose concentration that exposes the subject to potential harm with a proposed threshold plasma glucose value of less than 70 milligram per dl or less than 3.9 millimoles per liter is defined as hypoglycemia. Now, why this blood glucose value of less than 70 milligram per dl is used? It is because this approximates the lower limit of the normal post-absorptive plasma glucose concentration. It is the threshold at which the counter-regulatory mechanisms come in activation in those without diabetes. It is higher than the threshold of 55 milligram per dl, for which the symptoms of hypoglycemia usually occur in a person without diabetes or one with well-controlled diabetes. So this gives us time to prevent a clinical hypoglycemic episodes. It gives a safety margin. Now, let me just show you a short video. Yeah, so can anyone tell me what has happened over here? It is basically a Whipple's triad, which is characteristically used to define hypoglycemia to describe it. So there is symptoms of hypoglycemia followed by a determination of blood glucose value less than 70 milligrams and followed by relief of the symptoms on correction of the low blood glucose value. So we all know that controlling and keeping our patients in the glycemic target is like walking on a tightrope where we have to prevent the patient from falling into hyperglycemia on one side and hypoglycemia on the other side. Why does hypoglycemia matter so much? Because it is the most common and serious complication, specifically of insulin therapy. For many patients and their families, hypoglycemia is a very feared and dreaded aspect of diabetes treatment because once they land up with a hypo, they experience those symptoms, they are very afraid and do not want to experience it again. The fear of hypoglycemia also compromises a good diabetes control, and there is lack of communication by both the healthcare professionals as well as the patients. So, a better understanding can increase and improve patient outcomes and quality of life. Burden of hypoglycemia, we know the number of patients of diabetes is increasing exponentially over the years with 480 million diabetics as of now and projected to be 628 million by the year 2045. Diabetes is among the top 10 causes of deaths globally, and cardiovascular disease is the leading cause of death among people with diabetes. So, the risk of death from cardiovascular disease is 2 to 4 times more in a person who is having diabetes as compared to the general population. Every 2 out of 3 people with diabetes can have cardiovascular disease as a cause of death. And just like hyperglycemia predisposes, increases the risk, so also hypoglycemia increases the risk of cardiovascular disease, which I will be showing you. Hypoglycemia is a major barrier to improving the glucose control because, as I told, once the patients experience a hypo, they modify the doses of insulin on their own. They tend to reduce the dose or even stop insulin. Even the physicians who are treating them are afraid of because of the fear of hypoglycemia, they do not treat the patients aggressively. So hypoglycemia is definitely a very serious and costly affair, isn't it? We can see the number of hospitalizations with hypoglycemia in type 1 and type 2. More commonly, type 1 diabetics are predisposed. However, if type 2 diabetic patient who is on insulin for more than 5 years, the incidence of hypoglycemia is similar and comparable as of type 1 diabetic. So hypoglycemia is classified into severe, symptomatic, asymptomatic, probable symptomatic, and pseudo-hypoglycemia. Severe is when the symptoms are requiring assistance of another person to treat it. It is independent of blood glucose. Symptomatic is when the symptoms of hypoglycemia are present along with a measured plasma low blood glucose value of less than 70 milligram per dl. In this scenario, the patient is able to treat himself. Asymptomatic is when there are no typical symptoms, but a measured low plasma glucose of less than 70 milligram per dl is there. Probably symptomatic is when the typical symptoms of hypoglycemia are there, but they are not accompanied by a measured blood glucose value of less than 70. And pseudo hypoglycemia is when the typical symptoms of hypoglycemia are present even with a blood sugar above 70 milligram per dl. So the three levels of hypoglycemia is level 1, which is a 70 milligrams per dl. This is the alert value for patients as well as the clinician. At this stage, patient may not be symptomatic, but we require to check it and detect this and alter the dose of the insulin and whatever medication they are on. The next level is between 70 to 55 milligram per dl, where this is a clinically significant hypoglycemia, which is usually symptomatic, and repeated episodes can also reduce awareness and predict severe episodes. There is an increased incidence of cardiac arrhythmias and mortality. And finally, we have the level 3, which is the less than 55 milligram per dl, which is a very severe hypoglycemia at which there is severe cognitive impairment requiring external assistance, and there can be coma, seizures, and death if untreated. So who are the people who are at risk of hypoglycemia? They are definitely the older age group, elderly, people who are living alone, do not have assistance, their appetite is reduced, people with multiple comorbidities, including the hepatic and the renal dysfunction, people who are prone for having hypoglycemia unawareness and repeated episodes of hypoglycemia, specifically those who are on insulin and sulfonylurea therapy, also people with dementia, depression, heart failure. So the symptoms of hypoglycemia are autonomic and neuroglycopenic. Just we have seen in the video, shaking, trembling, tremors, anxiety, palpitations, headache. Sometimes the patient can get up with an early morning headache if he has had a hypoglycemia over the night in the sleep. The patient can also give a history of his bed sheets and pillows being wet because of sweating in the night due to an overnight hypoglycemia. Causes of hypoglycemia, I will be discussing the diabetic causes. It is mainly iatrogenic, related to the insulin and sulfonylurea therapy. So if the dosage of insulin or oral hypoglycemic agents are in excess, or they are ill-timed, if the patient has taken the dose and not eaten the meal, or he has skipped the meal, or he has delayed the meal, even in patients who are fasting and they have taken the full dose in the morning, these patients are more prone for getting hypoglycemia. Physical activity can also predispose to hypoglycemia because glucose utilization is increased and sensitivity to insulin is also increased during exercise. Comorbid conditions like renal failure can cause a reduction in the insulin clearance. So for a longer period of time, the drug remains in the systemic circulation and predisposes the patient to hypoglycemia. Alcohol intake can also predispose to hypoglycemia. So mainly insulin is a concern because we as physicians also are very worried and fear the hypoglycemia side effects when we want to initiate the patient with insulin. It is life-saving, no doubt, but it does not come without a risk. So it's very important for us to counsel our patients, and there that is where the importance of diabetes educators come into play. We have just felicitated them. So it's very important for us to counsel each and every patient for hypoglycemia. In this busy slide, just let me tell you what it happens is that when your arterial blood glucose level drops after a certain level, the counter regulatory mechanisms come into action and there is reduction in the secretion of insulin and increase in the secretion of glucagon. This is the first line defense mechanism, which causes endogenous production of glucose through gluconeogenesis by the liver and the kidneys. If at this stage the person does not recover from hypoglycemia, the second and the third line defense mechanisms come into action and the neuroglycopenic, the brain is involved. So it increases the release of epinephrine, norepinephrine, acetylcholine, and cortisol, which in turn all together they come and they trigger the glucose production, thereby increasing the arterial glucose. So consequences of hypoglycemia, we know first and foremost is the fear. Then there can be accidents if the patient is at work or driving or any time, so he can land up with accidents. The cognitive function reduces, there can be seizures, quality of life is impaired, and definitely the risk for cardiovascular disease increases. The consequences of hypoglycemia last longer than often believed. So the endothelial dysfunction happens, there is reduction in vasodilatation, there is increase in inflammation through the inflammatory markers like CRP, VEGF, interleukin 6, and increase in epinephrine causes rhythm abnormalities and hemodynamic changes in the heart. There is blood coagulation abnormalities through the activation of platelet activation, neutrophil activation, and increase in factor 8. So these changes last from 48 hours up to 7 days after an episode of hypoglycemia. Hypoglycemia associated with ECG changes as shown. Due to the release of catecholamines, there is hypokalemia, which causes abnormalities in the atrioventricular conduction, ventricular repolarization. There is R wave amplification, T wave flattening, and ST segment depression. Also, prolongation of the QT interval is seen, and the risk for cardiac arrhythmias increases. Hypoglycemia prolongates QT interval in adults with type 1 as well as type 2 diabetes. Complications and sequel, there is an increased risk of cardiac arrhythmias. There is abnormally prolonged cardiac repolarization in QTC and QTD. So there is a risk of sudden cardiac death. In neuroglycopenia, there can be reduced attention span, inability to focus, personality changes, confusion, seizures, coma, and even brain death in severe cases. So management is very simple. First of all, we need to detect it. If the patient is conscious and able to eat, follow the rule of 15. That is, give him 15 grams of fast-acting carbs, which could be glucose, water, candies. Avoid pastries, chocolates, ice creams. Okay, and wait for 15 minutes and recheck the sugar. So you can keep on repeating this 15 grams of carbs, short-acting carbs, till the sugar comes up above 100 milligram per DL. If the patient is not able to eat, then he should be immediately taken to the hospital setup, and intravenous infusion should be given to him. In the interim, the relatives can make a paste of glucose powder and coat it around his tongue or keep it under his tongue so that there is systemic absorption till the time the patient is reaching the hospital. Once in the hospital, patient should be administered a bolus of D25 or D50, and then an IV infusion should be set up and given till the time the sugar comes above 100 milligram per DL. Once the sugar comes up, we should evaluate the cause of hypoglycemia and adjust the doses of the patient accordingly. So just to give you a case study, it's a 65-year-old female who had come to the casualty with her son, and he was giving the history of the mother having recurrent vomiting and loose motions since last few days. He reported that although she was perfectly fine, only she was feeling little bit of fatigue and lethargy since the afternoon. He gave the history that the patient has consumed outside food, after which these episodes started, and her appetite is reduced a bit, and she is still taking the normal dose of her insulin and medication as advised. So she is actually a type 2 diabetic with RA and had undergone a CABG already. Um, on general examination, it was apparently everything was normal except a slight tachycardia, and a little bit of pallor was seen. Systemic examination was normal. CNS, there were no changes. There were no neurological deficits. On a review of medicines, we saw that she was in very high doses, almost full doses of glimepiride, 4 milligrams twice a day, metformin 1000 milligrams twice, vildagliptin and voglibose, and also Lantus 30 units. Her labs showed a random blood glucose level of 51 milligram per DL, and this is falling under the serious level 3 category, at which she should ideally should have had symptoms, but she was not so symptomatic. And her hemoglobin was 9.5 and HbA1c was 6.1, which also shows that she might be having recurrent episodes of hypoglycemia in the past, because of which she has hypoglycemia unawareness in this episode, even when her sugars were drastically low. So we diagnosed her as hypoglycemia unawareness with acute gastroenteritis with iron deficiency anemia. And we gave her intravenous glucose, dextrose, 25% till her sugars came up. Once her sugars were up, she was discharged on very small doses. Sulfonylureas were not initiated. She was asked to follow up, and on follow up, we had adjusted her doses. So in summary, I must say that hypoglycemia is often a very neglected complication of diabetes therapy, impacting the patient clinically, economically, and socially. So many times, almost 60% of the patients do not give the history of hypoglycemia by themselves. Even doctors do not ask the patient whether they are experiencing any symptoms after starting the medication. So this must be looked after. Mild the quality of life, while severe hypoglycemia is life-threatening and can have major CV events. So effective patient education is very necessary to reduce the risk and consequences of hypoglycemia. Patient-physician collaboration is vital to develop and modify a treatment plan that caters to the patient needs, empowering the patients with tools to monitor hypoglycemia, making them aware of the risk of hypoglycemia and the available preventive strategies, what they can do immediately after they have an episode of hypoglycemia. That should be worked out, and together with an individualized plan of treatment, we can reduce the frequency and severity of hypoglycemia. So let us all come together and take this initiative to create more and more awareness on hypoglycemia ahead of World Hypoglycemia Day, which is celebrated on the 20th of November, which is the birthday of Dr. James Collip, who first observed and described hypoglycemia. Thank you.
Thank you, Dr. Ashna, for nice deliberation. So we'll take question answer at the end of session. So next talk will be my friend Dr. Ami Sanghvi, who is a consultant diabetologist at Sanghvi Eye and Diabetes Care Center at Dahisar, Mumbai. She will be talking on hypoglycemia through time below range. What should we know? So over to Dr. Ami.
So very good afternoon to everyone present here. And at the outset, thank you, Dr. Manoj Chawla and Dr. Purvi Chawla, for making me a part of this wonderful conference and a part of the symposium on hypoglycemia. Next slide. So I'll be taking ahead from where Dr. Ashna has left. I'll be talking about hypoglycemia with time below range, talking about CGM and time below range. I'm going to be discussing about hypoglycemia through time below range and what is exactly what we need to know. So this is going to be the flow of my talk, starting with introduction, the tools for capturing hypoglycemia. We talk a couple of slides about continuous glucose monitoring and time in ranges. We look at the evidences of correlation between hypoglycemia and time below range, and then finally prevention, treatment, and conclude. So this is what Dr. Ashna has already discussed about the definition of hypoglycemia, that ADA says that any abnormally low blood glucose levels that exposes a subject to potential harm with a proposed threshold being less than 70. The slide has already been covered, so I'll be skipping the slide. So hypoglycemia is an important complication of glucose lowering therapy in our patients with diabetes. We have seen in various studies also that any attempt of an intensive glycemic control invariably increases the risk of hypoglycemia. It has been seen that there is a six-fold increase in death due to diabetes, which is attributed to patients experiencing severe hypoglycemia as compared to a patient who would not have a experience of a severe hypoglycemia. But what we need to note here is the glycemic thresholds for symptoms of hypoglycemia and for the glucose counter-regulatory responses to hypoglycemia are not fixed. They vary with the insulin given to the patient, the sulfonylurea prescribed, whether they are on meglitinide, what doses of medications they are on. Even with, we have seen that higher concentrations in those with poor glycemic control, even if their sugars come marginally down, they may have symptoms of hypoglycemia. And at lower glucose concentrations, where we are looking at a tighter glycemic control, or as a function of their A1C levels and the hypoglycemic experience. So it is not appropriate to cite a specific glucose concentration that would define hypoglycemia in our patients with diabetes. Now, if we look at the various glucose monitoring tools which are available for capturing hypoglycemia, we have the time-old self-monitoring of blood glucose, that is SMBG. We look at the real-time CGM or the flash glucose monitoring. And even the ADS has updated in its living standards of medical care in diabetes to incorporate consensus on TIR. So what they say is the abundance of data which is provided by a continuous glucose monitoring would offer us opportunities to analyze a patient data more granularly than was previously possible, which would provide us additional information in achieving a good glycemic target. And for that, a variety of metrics have been proposed. Now, a couple of slides to understand about the glycemic control in view of the glycemic variability and time in range. So what is glycemic variability? Basically is assessing the amplitude of glycemic excursions in the patient through the day, intraday or interday, which relies either on self-monitoring of blood glucose or on data given by continuous glucose monitoring. Coming on time and range, so it is defined as the time spent by an individual in the target blood glucose range. So it would give us the idea about the quality of blood glucose, and this time in range they have seen as strongly correlated with HbA1c. So any 5 to 10% increase or decrease in time in range would correlate to a 0.5 to 0.8% increase or decrease in the A1c. It has been linked to the risk of developing micro and macrovascular complications, and any incremental 5% improvement in time in range is associated with a clinically significant benefit because it reduces the complication. So it can be used as a endpoint in clinical research and measure of glycemic control. And I will tell you why did I put the last line. So time in range, basically we are looking at the target individual control between 70 to 180 in patients, and anything above that, above 180 is called time above range, and below 70 is called time below range. Even the international consensus for CGM data interpretation has given the time in ranges for various population, be it type 1 diabetic, type 2 diabetic. Then they have given relaxed time in range ranges for patients who are older, elderly age group or high-risk patients, in patients with pregnancy and type 1 diabetes, and in pregnancy and type 2 diabetes or GDM, the ranges are different. So every incremental 5% increase in time in range is associated with significant benefits for our patients with type 1 and type 2 diabetes. So this is just a recommendation to achieve time in range in different population. So in type 1 and type 2, we generally try to achieve a good time in range, and time below range should be as minimal as possible. In older population, maybe you have to have more relaxed ranges. In pregnancy, maybe the time in range has to be more stringent for better outcomes, because in pregnancy, any 5% decrease in time in range increases the risk of complications in patients who are pregnant. Coming to continuous glucose monitoring, just a slide about that. It includes real time, that is real time continuous glucose monitoring, or intermittently viewed continuous glucose monitoring, which helps to track the blood sugars in the body's interstitial fluid. And it helps us to detect the time and target glucose ranges, the glycemic excursions in the population, the daily profiles, the glucose variability, and the patterns of hypo and hyperglycemia. Now coming to time below range, which is the focus we are talking about in a hypoglycemia patients, the extent of the problem. So what do the international consensus reports say? That there is currently insufficient evidence to justify separate targets for individuals with type 1 and type 2 diabetes, but for most patients, they ask for a time in range at around 70%, time below range below 3.9 millimoles, that is below 70, to be around below 4%, and someone having low sugars less than 54 should be less than 1% of the as are recommended as targets. But the consensus stresses, however, the target should be individualized and emphasize that each 5% increase in TIR is going to be beneficial to the patient. And for elderly individuals, what they say is time below range should be less than 1%. The targets are still relaxed, because there is a higher risk of hypoglycemia, and we have seen in the previous talk the risk of hypoglycemia increases cardiovascular mortality, increase in risk of stroke too. So when we talk about hypoglycemia and time in range, the ADA says that glycemic control is best evaluated by a combination of A1C and time in range, and time in range may provide a more accurate assessment of glycemic stability and hypoglycemia. So for individuals experiencing high risk of hypoglycemia, a real-time CGM resulted in significantly clinically meaningful reductions in the risk of hypoglycemia by 33 to 50%, which is significant. And one of the most important application of CGM is for management of patients who have more frequent severe hypoglycemia, which is associated with hypoglycemic unawareness. So when we talk about CGM, we are already worried about the cost. But when we talk about hypoglycemia, then the cost factor is still higher, because the recurrent visits to the hospital, the economic, psychological, and loss of productivity would outweigh the cost of using a CGM. So CGM would be definitely advisable in patients who have frequent hypoglycemic episodes. Even in our type 1 diabetic patients, where we are more worried about hypoglycemia, if we look at through TBR, that is time below range, preventing severe hypoglycemia may benefit from greater focus on minimizing the time below range. If the CGM TBR may enable rapid identification of patients at highest risk for severe hypoglycemia in the clinical setting, and this would help the physician to decide about the dose adjustment, access to glucagon, and lifestyle intervention. Now, this was a very elegant study which was done by Dr. Manoj Chawla and Dr. Purvi Chawla, which was published in 2022 about time below range, which was a retrospective continuous glucose monitoring analysis to detect hypoglycemia and routine clinical practice. So here they had involved around 227 adult participants, and they had categorized them according to the A1C levels. Their 24-hour blood glucose was monitored, measured through CGM with a flash glucose monitoring device, and what they saw was that patients had A1C levels within the around 77% of the patient had A1C levels between 7 to 8, 33% had between 8 to 9, and the remaining had higher A1C. But what they saw was that participants with poor glycemic control spent the minimum time below range, which is expected. Those having A1C levels within the range of 7 to 8 nearly spent 10% of their sugars in time below range, indicating that they too had episodes of hypoglycemia. And no statistical differences were seen in the time spent below range between male and female population or the treatment prescribed to them. So be it they were on OHAs, on insulin, or a combination, no much statistical difference was seen. But see the number of patients who spend more than 5% in time below range. 77.5 having A1C less than 7 had time below range, which is expected because you're looking at stringent diabetes control. 54% of patients between 7 to 9% of A1C spend their glucose in time below range. But 40.6% of the patients with A1C above 9 also had episodes of hypoglycemia. So concluding that it was found that individuals with A1C below 7 were at maximum risk of hypoglycemia, that spending more than 5% of their time below range. But patients with higher A1C also had risk of hypoglycemia. So all patients with diabetes are at an increased risk of hypoglycemia, regardless of their levels of glycemic control or the treatment regimen prescribed. Now, there are various evidences of correlation between hypoglycemia and time below range. Just brief about them. What they saw was that continuous glucose monitoring in time below range predicts the impaired epinephrine response to hypoglycemia, especially in patients with type 1 diabetes. The study had pointed out that the possibility that recurrent hypoglycemia may blunt a protective epinephrine response, increases the norepinephrine activity and the cardiovascular complications. Also, in elderly population with type 2 diabetes, they had seen that coefficient of variation reflected time below range of more than 1%, which was more appropriate amongst the GB indices which were used to examine the patients. And looking at the intermittent scanning continuous glucose monitoring device with a structured education program significantly reduced the time in range in patients with type 1 diabetes. So this definitely is more beneficial for our patients with type 1 diabetes. But when we talk about any parameter, it does come with some limitations. So there was this paper by Dr. Viral Shah which looked at the limitations of reporting time below range as a percentage. Till now, we were talking about TBR as a percentage. So it comes with its own limitations because it does not account for the frequency or the duration of the hypoglycemic episodes. It kind of weighs all the hypoglycemic episodes on a similar level. So be it 54, be it 70. So you are not able to justify giving a particular treatment for the patient. So because you're giving as a percentage, rounding methods can be misleading. And we all understand that TBR below 54 has to be more emphasized than a time below range of less than 70. So maybe we have to look at more action, more nuanced and precise reporting methods that can enhance diabetes care and prevent complications. Now, just a couple of slides to be beware of the pitfalls of time below range. We have to look at time in range effectively. We have to look at what the percentage of the day the patient is spending in good range, below range, and after range. Look at the patterns of hypoglycemia. Look at the patterns of hyperglycemia and the time in range. And why is that important? I'll explain you in this one slide. Look at this. The patient had an average sugar of 180 milligram per deciliter. But when you look at the individual graphs, there are so many hypoglycemic episodes which you may miss because you are getting a range of 180. So what we need to understand here in this case is that importance of reviewing the daily graph and addressing these behaviors as a review of time below range alone would underestimate the person's risk of developing severe hypoglycemia. Look at every range, look at every day's graph, try to understand what level of exercise, what diet was he on, and then decide the line of management. This has already been covered about assessment, prevention, and treatment. So the strategies to improve treatment and manage hypoglycemia is patient education, diet and exercise planning, individualizing A1C targets, improving the pharmacological treatment, understanding the patient psychology, glucose and medication monitoring, and technological strategies have to be involved to give patient a better quality of life. Summarizing, use of time in range has enabled diabetologists, endocrinologists, and diabetes educators to analyze more than one component of glycemic control. One of the possibilities for the future is a combination of various metrics trying to better define the glycemic control. Gather more than one metric is a very good idea to analyze a good diabetes control and can be used frequently over the coming years. Different targets are to be considered for special population. For each patient, maybe you have to set up individualistic targets. In clinical practice, TBR can be a key indicator for assessing the hypoglycemia exposure and burden, and it is important to understand both its utility as well as limitations, as those with similar time below range can have widely different frequencies and patterns of hypoglycemia, which in turn is associated with differing levels of clinical risk and consequences. This has already been mentioned by Dr. Ashna about 20th November being the World Hypoglycemia Awareness Day. Thank you all for your patient hearing.
Thank you. Next, we have Dr. Abhijit Jadhav, Director of Aditya Care Hospitals, speaking about the vulnerable groups for hypoglycemia.
Good evening, everyone. First of all, let me thank you, dear Manoj and Purvi, for inviting us, and we are welcoming your DRS family as well here. I'll start where Dr. Sangvi just left the talk here. Begin. Um, any specific vulnerable groups are here? Not at all. Every diabetic patient who is on insulin, he's prone for hypoglycemia, or a person who is on secretagogue, sulfonylurea, he's prone. So we'll not speak about any specific group here. Every diabetic individual who is on intensive therapy with insulinization or secretagogue like sulfonylurea, he is prone for hypoglycemia. And that's what we want to talk about here. Going back to the epidemiology here, we all know it is most commonest thing in type 1 diabetic. It is 3 times more common than type 2 diabetes. But over a period of time, what you see, the average 2 episodes of happening per week. So that's a frequency of hypo in type 1 patients, for children. And over a period of time, they get thousands of such episodes, and one episode which is very detrimental to the life, which happens in a year. So this is the severity of hypoglycemia in type 1 patient. And this is what the intensification arm from the disease series they have shown, almost 3.14% of intensity of the hypoglycemia per year. But again, our type 2 also not less than that. Why so? Because you see, the overall type 2 diabetes patient also, 38% patient, they will suffer hypoglycemia if they're on insulin or secretagogues. Same time, over a period of time, they become insulin deficient. They are as same as a type 1 for a frequency of hypoglycemia, and moment they are on insulin multiple dosages or basal bolus therapy, they are same as type 1 for frequency of hypoglycemia. So that's how equal contribution come from the type 2 diabetes patient once they depend on insulin. Again, we all know the risk factor. Dr. Ashna spoke about detail about it. But first of all, you must understand all the risk factors are there already present in your patient. The patient who are taking insulin, the patient who are taking secretagogues, the patient who lacks the food, particularly exogenous glucose entry is not there post-exercise, post-party, or gastroparesis, celiac disease. Again, patient not able to utilize it properly, particularly if they are going for a weight loss program, reversal of diabetes, we often such are the patients which are prone for hypoglycemia if they are on secretagogue or insulin. Same time, alcohol ingestion and definitely CKDs and liver failure, we all know the known cases. But again, often we see long-standing patient is classical diabetic autonomic neuropathy cases. Now going back to this, particularly the risk factors, which is very, very important, because what decides this degree of severe or absolute endogenous insulin deficiency, because patient is dependent on insulin for sugar control. And that's That's where the patient will have hypoglycemia. And moment patient has a hypoglycemia, severe hypoglycemia, he will ultimately going to have second episode, third episode that going to create a hypoglycemia unawareness. And that is an incidental hypoglycemia, and which happens during exercise, during sleep also, where patient is not aware as well. And again, as Amish talk about the aggressive therapy here, moment you try to lower the HbA1c, moment you reach TBR, patient will have hypoglycemia. These are the patient where intensification will give you hypoglycemia. But again, she also said about same thing. Even if higher the HbA1c, you will have hypoglycemia. That doesn't mean that if your patient is HbA1c control only. No, not necessary. Your higher HbA1c patient walk in your cabin and you write secretagogue or insulin to them, they will have hypoglycemia eventually. So these are also vulnerable group. Same time you see the the patient of type 2 diabetes patient who can get rid of hypoglycemia, particularly those molecules which are prescribed in last 2 decades, like SGLT2 inhibitors, D4 inhibitor, GLP analog, alpha glucosidase inhibitors. These are the molecules, they will not give you hypoglycemia, but ultimately patient he's on polytherapy, patient is already on insulin, and we are writing this molecule. Because of their co-prescription, patient will have hypoglycemia. So we get to see that co-prescription which are given to the type 2 diabetes patient. Again, the commonest thing we see in special group, alcohol, too much of alcohol, again, sepsis in ICU patient particularly, and CKD, which is known thing in OPD as well as IPD, we see CKD patient going for a dialysis and they ultimately have hypoglycemia once a week, twice a week, dialysis happens, and they definitely have hypoglycemia during the dialysis. So this is what another commonest thing we see is severe liver failure, severe cardiac failure, malnourishment, particularly patient going for a or religious fasting or long-standing fasting or weight loss program where they definitely have. Another thing we see patient with adrenal insufficiency, particularly adrenal cox and growth hormone deficiency in hypothyroidism. This is rare cases, but again, not so uncommon as well. Now, who should be evaluated? Obviously, Dr. Ashna spoke about the people's triad, who should be evaluated very well. But I'm going to talk about very structured thing here because every vulnerable group to be address with this, because what we need to acknowledge the problem, because we are not talking to the patient in a length. Same time, talk about conventional risk factor which are already there in the patient. And this particular terminology called as HAF, where patient is not aware. And same time, the fourth one, the application of the technology, the what we are using CGMS. Obviously, SMBG is very, very handy. Even SMBG can reveal many things about patient hypos and hyper, but newer technology can be adapted definitely to avoid this kind of a strategy. So acknowledging the problem is the first thing, because issue of hypoglycemia in every visit you must ask a question about the hypoglycemia to rule out any hypoglycemia unawareness. And same time, every secretagogue patient or sulfonylurea patient will end up having hypoglycemia without his knowledge. So you must address and have a contact with him. Same time, make a habit of reviewing SMBG records. Ask your patient to carry their glucometer records every time they come to, whether it is a type 1 or a type 2. CGMS is obviously a very handy, which is at your desktop only, you're able to see time below the range. And this concern to be discussed, if there's a hypoglycemia which is persistent, try to adjust the dosages over a period of time. Again, considering the conventional risk factor of hypoglycemia, always remember when patient has a relative or absolute insulin deficiency and you're going to start patient on insulin, he's going to have hypoglycemia. This is very, very important. Time of the dosage, timing, the food, the type of insulin, the premix particularly, the basal bolus therapy, longer acting insulin, shorter acting insulin, co-prescription with SUs, short acting SUs will definitely define this risk factor for hypoglycemia management. Same time, you must know this risk factor indicative of HAF, which includes a degree of absolute insulin deficiency. And particularly with severe hypoglycemia, there's an impaired awareness which happens over a period of time. And this is a indirect correlation with the patient end up in ICU for hypoglycemia management. Now, the principles remains the same, where you will see that whether intensification is worth or not. That is the first thing. Second thing, what you need to have, drug selection, the right kind of molecule to be chosen for right age. Same time, application of these technologies along with these sensors, with SMBG records, you must be prescribing always, every secretagogue patient, you are writing sulfonylurea, you must prescribe a glucometer to your patient. That has to be mandatory, isn't it? And obviously CGMS will come with the costing and the affordability, the knowledge, everything. And Amit talk about the individualizing goal. That's a key factor here, individualizing goal. And you need to have structured patient education, first of all. And you have to have short circumstance avoidance of hypoglycemia if you follow so. And going back to this, particularly drug selection, be aware of SUs, what kind of SUs you're using. Clinides also as well, more physiological insulin, longer acting insulin, shorter acting insulin, premix insulin. Same time, patients, type 2 diabetes patient, they have polytherapy, co-prescriptions are given, so be careful. And particularly if you are combining longer acting insulin with basal insulin along with GLP analogs, you will minimize the hypoglycemia. Believe me. So if you're combining incretin-based therapy with insulin, your chances of hypos are very less. So this has to be, patient selection is very, very important. Another thing is the technology which comes in now, very important to avoid hypoglycemia is your CSI, that's continuous insulin infusion, which combined with CGMS will give you a kind of a closed loop situation where you will able to avoid hypoglycemia and you will able to give tailor-made insulin dosages to all your type 1 patient as well as type 2 patient who requires insulin. Now, individualizing glycemic goal. These goals are very much crucial here. We always follow a non-diabetic goal when patient is diagnosed first time, isn't it? We offer them lifestyle modification. So there is okay. You follow non-diabetic goal for newly diagnosed patient with lifestyle changes. But patient who are non-pregnant adults where we give long expectancy like he's in 30s and 40s, will give him HbA1c below 6.5. Those patients having again longer life expectancy without any comorbidities will give them the same 6.5. Particularly children, when a growing pivotal age group, hormonal changes, try to keep between 7.5 to 7. And obviously, try to be strict as well. And at the same time, whenever you see the comorbidities, the cardiovascular events, microangiopathies are there, retinopathies are there, try to be little less stringent, 7.5. And moment you see the expectancy is not great, above 80 years of age, 90 years of age, try to be very, very lenient, 8% HbA1c, that is what. Now about the structure patient education, which is very crucial. You need to have, study was shown in particularly type 1 patient who are on insulin. So when they were given this kind of a structure, flexibility about insulin, the hypo management, SMBG record, the 40% less reduction in severe hypoglycemia in 1 year period. So that's how the education works. In your existing patient, if you give time, sit with them, talk to them, you can avoid those severe hypos and ICU visits, isn't it? So what patient education basically covers a broad range of information. It's a skill training. You acquire them a skill as well as make them aware about the technology as well. So this structure thing is, so in summarizing what we see here, every type 2 patient, he is prone for hypoglycemia if he's on insulin or he's on secretagogue like SUs, definitely. So make sure the kind of molecule you offer to them will not give them hypoglycemia or weight gain, isn't it? Type 1 diabetic patient, obviously it's a big, huge Herculean task on you when you sit with the child, the parents need to educate the child as well as the parent as he's growing. Use of technologies which is very, very handy to avoid hypoglycemia, and you're able to reach targeted HbA1c only through the technology, not only to the molecules, believe me. So what happens here is tailor-made prescription generated by you when you use technology, and tailor-made diet also if patient follows your technology as well. So use this kind of a technology where you will avoid this number below 70 milligram is the right mark where you avoid that on SMBG as well as on CGMS data. And this technology to be used to avoid hypoglycemia, particularly in your prescription as well. Thank you. I have spared 5 minutes for my dear friend. Thank you.
That's really nice because our audience will get 5 minutes more to ask the questions. We have last talk, and that's which is till date we have heard of hypoglycemia when patient is on anti-diabetic agents or insulin. But sir is going to talk on non-diabetic hypoglycemia. Dr. Chandrasekhar Astekar from Latur. I think Dr. Chawla has selected speakers from east, west, north, and south. So he represents the Latur where a previous Chief Minister, Dr. Vilasrao Deshmukh, was from there, and he could be the next candidate there from there. So Dr. Astekar, stage is yours.
Thank you so much, sir, for your kind introduction. Good afternoon, friends. It's my honor to be part of WCPD DRS meeting. At the outset, let me thank Dr. Manoj, Dr. Purvi, and entire team of DRS for inviting me. I'll be talking about, because in this hypoglycemia symposium, the previous speakers, they have talked about hypoglycemia and diabetes particularly. And I'm going to talk about non-diabetic hypoglycemia. So as a diabetologist, we mostly deal with diabetes, hypoglycemia, hyperglycemia, and all those things. And I correlate myself with a cricketer who now been asked to play baseball instead of cricket in the form of non-diabetic segment. Both these games, they have bat and ball, but certainly these two games are totally different. So hypoglycemia in diabetes segment and hypoglycemia in non-diabetic patients is totally a different ball game. So I will try my level best to give justice to this topic. So non-diabetes hypoglycemia is relatively uncommon when we are compared with the patients with diabetes. And it is certainly a diagnostic challenge for clinicians. So large retrospective data of more than 38,000 patients were admitted with a non-critical illness. They had a frequency of 36 admissions per 10,000 admissions. So like this is the prevalence of non-diabetes hypoglycemia. And it has been noted that the age above 65 years on admissions were 50% more likely to have an episode of hypoglycemia. So let's understand, bit of physiology of endocrine regulations. So nature is very kind to us. Nature wants all of our individuals to be in normal glycemic range. So we have a hormone like insulin, which will lower the blood sugar. But to counteract, nature has given 4 counter-regulatory hormones in the form of glucagon, epinephrine, cortisol, and growth hormone. And again, you see the beauty of our hormonal regulation. Insulin shuts its secretion at around 80 milligram, with a maximum decrease of insulin secretion at around 50 milligram per dl. So my dear friends, any detectable insulin during hypoglycemia is hyperinsulinemia. So this is the point number 1 which we need to take home. Any detectable insulin during hypoglycemia is hyperinsulinemia. So now we know these stalwarts, those two social activists, Anna Hazare and Jarange Patil, who fasted for more than 14 days. So this is all because of the harmony of endocrine regulation, which able to make them survive for more than 14 days without any kind of food. So that because thanks to the ketones probably as a fuel, which these activists lasted their fasting for more than 14 days without any food. Hypoglycemic disorders are broadly classified into fasting hypoglycemia, postprandial hypoglycemia. As far as clinical appearance is concerned, whether the patient is clinically healthy or sick, hyperinsulinemic or hypoinsulinemic. Assessment of hypoglycemia is basically with 2 parameters, the careful history and lab workup. As far as history is concerned, so when patient is entering in a chamber, if he's, or in the hospital, if it is ill appearing individual, then we need to ask the history about relationship with the meals, his nutritional status, what are the current medication he is using, and then other multi-system involvement. In the patient who is looking very healthy, healthy appearing individual, then the timing relation to the food ingestion, physical activities, whether hypoglycemia is in the day or nocturnal, how severe the hypoglycemia, and then time of onset of hypoglycemia. This is the main crux. The history is very, very important when we are dealing with non-diabetic hypoglycemia. The lab workup is another very, very important aspect, what we call as a critical sample. When patient presenting with the features of Whipple's triad, which already been discussed, they require the further evaluation to understand what is the cause of hypoglycemia. The initial investigations are first random blood sugar level, because the glucometers are not that reliable in the hypoglycemic range. So like we want a venous plasma sample here. Then blood ketones. This is the most important investigation, beta hydroxybutyrate. The third and fourth are like insulin, C-peptide, proinsulin, and growth hormone cortisol. Once patient is admitted with the hypoglycemia, suppose the blood sugars are low, then secure the IV line first, and then immediately, simultaneously, ask your another assistant to take critical sample, because this sample at that point is very, very important. Unnecessarily, you should not start immediately the IV fluids, but simultaneously ask your assistant, one more person, to take this critical sample right at that point. Another workup investigations are urea electrolytes, liver function test, sulfuriluria and meglitine screen, IGF levels, insulin and receptor antibodies if the elevated insulin levels and partially suppress C-peptide. Urine ketones are not that reliable, but still they could be present positive even after correction of hypoglycemia. We need to remember that urine ketones also may have some kind of role over there. Most important thing is, you should ask your lab if the blood sugar is below 50, then straight away the proceed two samples like insulin, C-peptide and growth hormone cortisol. So this is very important. If the blood sugar is down below 50, then straight away ask your pathologist to process these two samples also. Now, this is like symptomatic hypoglycemia confirmed with Whipple's triad. We have excluded the drug causes. We have measured insulin, C-peptide, proinsulin, and beta-hydroxybutyrate. We found beta-hydroxybutyrate on the lower side. So this is the two parts where you find ketones negative, ketones positive, simple way. Now, let's analyze one by one. When you have a high insulin, high C-peptide, low ketones, there are the four differential diagnoses. First, insulinoma. Second is autoimmune syndrome. Third is factitious hypoglycemia because of exogenous insulin or secretagogues, and hypoglycemia induced by non-diabetic medications. Now let's see first, insulinoma, which is a rare neurokine insulin-producing tumor. So clinical features of insulinoma are these patients are obese with the features of insulin resistance. They primarily manifest in the 5th decade. It is more common in females. And most of the times, this 72 hours fasting test helps to capture this insulinoma. How do we do the 72 hours fasting? We admit the patients to the in the hospital, and we ask the patient for 72-hour fasting. Every 4 to 6 hours, we measure 4 samples. Again, C-peptide, insulin, beta-hydroxybutyrate, and once the patient's blood sugars goes below 60, 65, we test more often, like every hourly, every half an hourly, and then when critically sample goes below 45, the same sample is very, very helpful about serum insulin, C-peptide, beta-hydroxybutyrate. So most of the times, this 72 hours fasting test is going to capture insulinoma, and which will be confirmed by CT MRI. MRI has a sensitivity of 85%, and it will be confirmed with F-DOPA PET scan. Another high insulin, high C-peptide, low ketones, the autoimmune syndrome, where there is the highest concentration of insulin antibodies. It is the third leading cause of hypoglycemia in Japan. So it is basically caused by binding and release of insulin from antigen-antibody complex independently changes in glucose concentrations. The factitious hypoglycemia is very, very important in our clinical practice because it almost accounts for 16% of hypoglycemic admissions. They are more common in individuals working in healthcare systems, having relatives with diabetes in same household, and those are having some kind of underlying mental illness. Even there are many herbal preparations are contaminated with sulfonylureas. I have seen one patient who was non-diabetic, and I used to purchase glibenclamide down at that time, and he used to mix it with churnas and give it to the other patients. So like there are some these kind of persons who are there who are treating diabetes with such funny ideas. Even one report was there 2008 outbreak of severe drug-induced hypoglycemia in Singapore, which affected 150 non-diabetic patients due to the 4 brands of sexual enhancement drugs were contaminated by glyburide. This paper, not way back, just 2008 in Singapore. Another is like, factitious hypoglycemia due to exogenous insulin characterized by low C-peptide, high insulin, and low ketones. On the contrary, the factitious hypoglycemia because of secretagogue will have elevated C-peptide, high insulin, and low ketones. This is a case where 21 years old healthy female what wants to be an actress, but parents' pressure forced her to join pharmacy and came with a severe hypoglycemia. This is another typical case of factitious hypoglycemia. When you have other options like what are the drugs which can have hypoglycemia, the non-diabetic medications, quinine, pentamidine, indomethacin are noted with a moderate kind of evidence, but most commonly drugs what we are using currently still have hypoglycemia, like quinolones, NSAIDs, antipsychotic drugs, and alpha and beta blockers. Here in all diabetic patients, or alpha, beta blockers, they have also masking the effect. So hypoglycemic awareness also is important as far as beta blockers are concerned. So what we need to use more cardio selective beta blockers. So another thing, the second arm of the picture is like if the ketones are more. High ketones, low insulins, low C-peptide, we have four differential diagnoses: ketotic hypoglycemia, hypoglycemia after prolonged exercise, alcohol-induced or glycogen storage disorders. Ketotic hypoglycemia, that way is relatively rare. It occurs during the extended periods of carbohydrate deprivation, such as fasting or starvation. And those patients who are adhered to the ketogenic diet for prolonged period. Another thing is with prolonged exercise, they can have a fasting glucose decline in the hypoglycemic range 30 to 40% of healthy subjects. Alcohol induced, yes, it is because of inhibition of gluconeogenesis and blunting of growth hormone response. The high and the glycogen storage disorders, these are the rare genetic disorders that impair the breakdown of glycogen, and it is commonly seen in infancy. Now, the second hypoglycemia is a postprandial hypoglycemia. The hypoglycemia which occurred within the 5 hours from the last meal, we have with the bariatric surgery, nasodioblastosis, or hereditary fructose intolerance. Bariatric surgery hypoglycemia, it is there where it is a typical of postprandial hypoglycemia. It is most probably because of increased glucose delivery from the stomach to the gut after bariatric surgery, which is associated with hyperinsulinemia. Mr. Gadkari had a couple of times hypoglycemia. Hypoglycemia is mostly likely due to the altered rate of digestion and secretion of insulin. Hypoglycemia associated with other disorders like critical illness, liver cell failure, CCF, sepsis, renal failure are there. Even malnutrition, adrenal insufficiency, and non-islet cell tumors are there with hypoglycemia. Now, in common practice, where we should not forget this artifactual hypoglycemia, means hypoglycemia without any symptoms. This is a very common practice. If the sample is taken without anti-glycotic agents like fluoride in the blood collection tubes and with a delayed processing. One case happened a few months back where my hospital staff run, doctor, ye blood sugar बहुत कम हुआ है, it was 39. How is the patient? The patient अच्छा है, लेकिन 39 हुआ है. So this is because that day the sample was taken early morning and the process in the late evening. So that was a common situation. So like message is you should not treat the patient, not the numbers. Just looking at the 39, don't treat aggressively. The history is also very important. Reticulocytosis, where the polycythemia, sickle cell anemia, leukocytosis, thrombocytopenia, the other causes of artificial hypoglycemia without any symptoms. Treatment, basically, the hypoglycemia can be managed in non-diabetic patients by eating smaller meals more regularly with 1 or 2 snacks. Patients should avoid foods rich in sugar. They should avoid alcohol and caffeine. Basically, treatment of non-diabetic hypoglycemia depends on causative factors. Suppose in case of insulinoma, the surgical option could be the best option. Whichever drugs they are causing hypoglycemia needs to be discontinued. So the careful history is very, very important. Whosoever patients who are reactive hypoglycemia, post-gastric bypass are mostly controlled with dietary modifications, with low glycemic index diet, and even acarbose, an alpha glucosidase inhibitor, found to have a beneficial effect in controlling reactive hypoglycemia. But still then, even if the post-dietary, post-pharmacologic therapy post-reactive hypoglycemia is not controlled, then restoration of gastric constriction or subtotal pancreatopathy is recommended. In conclusion, The non-diabetic hypoglycemia, that is really relatively rare phenomena, since in healthy individuals, we have good counter-regulatory mechanisms that prevent and correct hypoglycemia by reducing glucose uptake and by enhancing glucose production. So mechanisms are pretty clear in fasting hypoglycemia, not so that clear in the postprandial. Hypoglycemia only occurs when the impaired physiological responses offset the balance between glucose utilization and production. So evaluation of hypoglycemia basically starts with a detailed history, comprehensive review of medications, clinical presentation, and thorough physical examination. That will guide us a diagnostic approach in patients with documented hypoglycemia based on Whipple's diet. So we should not go very fancy about all sorts of investigation. The first look in detailed history, review of medication, clinical presentation, and physical examination. So that is the key to identify the cause of hypoglycemia, especially in the non-diabetic individuals. So hypoglycemia basically is a silent, invisible attacker that can undermine every aspect of physical and emotional well-being. So we want all our patients to should not have any kind of hypoglycemia. Thank you so much for your kind attention.
That's really a wonderful talk. And in the opening statement, I had said all of us are post lunch here, so we'll have hyperglycemia. But that's proved wrong now, because in the postprandial there can be hypoglycemia. So that's a wonderful message. So the floor is open for questions. And yeah, but where will this? So we'll start question answer sessions, and all the speakers, I mean, they are there, I suppose. So is there any questions to be asked to Dr. Astekar? Then we can go from sir and other speakers. Good afternoon, everyone. कोई तो है कुछ? Okay. So basically, sir, I had a question for you. First of all, you said this Ayurvedic compounds. So some of the people who are claiming that we can cure this diabetes by giving this compound, are they aware that it contains something like this, or it is by accidentally you have detected that it contains the sulfonuric agents?
No, no, it's like one patient was there, relative of mine who was, taking some kind of churnas, and these people, they were mixing glibenclamide, downhill, that the powder form in the churnas.
So purposely they were doing?
Yeah, yeah, it's like,
oh,
yeah, purposely they used to do it. They were not aware.
Okay, okay. But it's really very, very important talk, and it's a very eye-opener, something like insulinema.
Yeah, it's like, whatever, the Indian mentality is, any churna, कडू जे आहे ते खूप चांगलं आहे. So that kind of mentality is there. कडू खाल्लं की बरं होतं, मग चूर्ण घेतलं की बरं होतं. Yes, that kind of mentality is there with a lot of Indians. And then to just crush the powder of glibenclamide and put it there in churna, it is like, अरे कितना sugar कमा देखो. So that kind is,
करेला देश ना का करेला है, जामुन है, तो उससे तो होता है, and there are some people are having roaring business out of it.
Yes, 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 sir.
Any? Yes, sir. Please, please use the mic. Use the mic. There's a mic there.
Abhijit, Ami.
Dr. Ashna. Be on stage.
Yes, please, Ashna.
Sir, my mic is not. Hello. Hello. Sir, when fasting sugars are high and postprandial sugars are less in a patient who is on tablets and not on insulin.
So we have to rule out Dawn's phenomena there. First, try to check the 3M sugars if you're not using a CGM. Check the 3M sugars. If the sugars are dropping, maybe you have to reduce the night dose of whatever OHs you're prescribing. So that can be one reason why you're fasting there is fasting hyperglycemia and postprandial hypoglycemia.
And in many times, actually, what happen actually, those patients who are duration of diabetes is more than 10 years, 15 years, and patient are taking high doses of sulfonylurea, but they actually require insulin to prevent that nighttime glucose surge because of endogenous endogenous glucose production by liver, hepatic neoglucogenesis. So those patients sometimes have fasting high and postprandial low. So sometimes those patients we need to reduce the doses of sulfonylurea agent and we need to add them insulin. So that is right choice many times.
Also, resistance at the hepatic level, so that is another cause of fasting hyperglycemia.
So Abhijit, one question for you. So yeah, please, please.
Can I ask a question?
Yeah, please, please.
Hello. Is it heard? Yeah, okay. So my question to all four of you speakers, we've been looking at 70 as hypoglycemia, right? Does that continue to still be the number? Today, as most of us are doing CGM in patients with normal non-diabetic population, with a lot of continuous monitoring happening, people are seeing that 70 is not a definite figure anymore. When it comes to CGMs, probably today we are looking at 54 as genuine levels for hypoglycemia. 54 to 70 may remain a gray zone. And I need your thoughts from all of you, because as people today are doing more and more CGMs in the general population, they're all realizing that, and all of us here will end up doing CGMs for us. If you do not have diabetes and a company here is offering selectively, you'll realize that you will see all of yourselves who are non-diabetic touching between 60 and 70 at times. So your thoughts, any of you wants to take that? You think this number needs to change? What is the message to clinicians today for them to understand when a patient calls them, or a general family member would say, I have 65 that I'm seeing, why am I going into hypoglycemia?
First of all, start explaining reports to your patient. If it is a lab report done by the glucose estimation, many times these people, laboratory people, they keep the samples on the table for 4 hours, 6 hours. You must see the reporting time. And every hour there's a glucose oxidation. Patient bang on your say my sugars are 90 and you're not reducing my insulin and not hypoglycemia. So 90 by the lab estimation may not be the right one. And same time, calibrate the glucometer as well. Whenever you start using glucometer, explain your patient how to calibrate the glucometer. About the CGM, obviously, Dr. Sangvi will explain in detail, but again, CGM is the interstitial fluid glucose, which is not actually related to your capillary glucose or venous glucose, which is always slightly lower, 4 to 8 milligrams blood deciliter lesser. So whenever you see CGMS showing a red mark, it is not necessarily hypo. You have to confirm with the glucometer or by lab estimation, and then you can predict about the hypoglycemia. You and more?
Also basically this is an alert value. That is what we see, that at 70 if they check, they know the sugars at 70, they are more alerted, they have to monitor more frequently and then prevent a major hypo episode in future.
So I would just say one thing that, as I mentioned in my talk also, we'll put individual targets. Everyone's threshold may be different. So maybe special population, the targets may be a little more relaxed. For pregnant ladies, it may be more stringent. So according to what patient is sitting in front of you, maybe you can put the targets for hypoglycemia. At what level is he getting symptoms? Is it correlating with the CGM readings or his SMBG readings? And then accordingly train the patient accordingly.
I think many times after seeing blood glucose value of 60, 65, patients himself feel hypoglycemic. So maybe it's anxiety or psychological. But really speaking, the newer medications like SGLT2 inhibitor, DPP4 inhibitor, which are being used in non-diabetic patient also. So I think that you rightly said that gray zone between 54 to 70. It's actually not a hypoglycemia, but it's patient perception that when he's on taking anti-diabetic medication, or I'm not saying oral OHA. I'm not talking oral hypoglycemic, older medication, that's sulfonylurea, but newer medication like SGLT2 inhibitors and metformin or GLP-1 analog. And if its sugars are say 66, then I may not call it as a hypoglycemia, but it's psychological hypoglycemia that should be there. Keep in mind.
With the same point, Manoj, I feel like, interstitial glucose guidelines should be different. Like the CGM values with interstitial glucose need to be calibrated venous plasma. So what we are currently with the hypoglycemia
hypoglycemia with venous sample 72 could be more ideal. But with interstitial glucose playing in, then probably 54, I don't know, it's like need to be worked
But
on.
only there is a delay.
Yeah, it's like
10 minutes.
but still
10-minute delay.
if we have a report of CGM with patients and patient is asymptomatic all the time and values are in the range
This
of 50
capillary blood
60,
glucose is also 64.
Actually, Dr. Manoj, you had a paper on the same thing. Yeah. So you had a paper on the same thing which I quoted in my talk. So would you like to help us that how do we, because there would be patients who had 54 also and there would be patients who had 70 also at the same time.
Right. So I think that's a fair point that Chandrasekhar made, that you'll have to consider hypoglycemia based on how you're checking. So your capillary blood glucose values today may differ from when you're looking at interstitial fluid glucose, and all CGM as of now looks at interstitial fluid glucose. If you see the recommendations, that's why it would say that between 54 and 70, less than 5% is the target. So your patient spending 2%, 4% time between 54 to 70 is not genuine hypoglycemia. The other recommendation which is coming up is the time. So when you see the range below 70, what is considered as clinically significant is at least 15 minutes there. So if you're seeing somebody drop for 5-7 minutes and come up, that is not even significant hypoglycemia. So on the CGM, 15 minutes of PBR is what is considered as hypo, and which is where the definition of level 1 and level 2. Having said that, we don't have the final word here. It's still an emerging technology with certain limitations, but the idea is to sensitize at least clinicians to understand that everything between 54 and 70 on a CGM may not always be hypoglycemia.
So here, is the full crowd is diabetologist, or there are people who are non-diabetologists in the crowd?
So gynecologist also is there.
So there are a lot of people who are please raise your hands. I am the gynecologist. It's really too much of knowledge for me. So what I feel personally is not to go by one level, blood level. We need to sensitize our own doctor community to find out how, what was the time lapse between the examination of two samples. Third thing, as Dr. Astekar said very well, that is consider patient symptomatology also and not go only by this thing, because all of us are putting level at 70, but everybody's body is different, everybody's level might be different, everybody's tolerance might be different, and that's why we could have some range. And as sir just now said, 54 to 70 or something like that, I think that's really very nice. With this, I think we'll go to the next one, and that is Ashna
Dr.
Patil.
Savant, Dr. Savant, one more
Where is
question,
it?
if you don't mind.
Sorry. Yeah.
See, you said rightly, and all of present here are probably diabetologists. I am a general practitioner. So I would like to know what message should be given to a general practitioner, because he is the first point of contact. The patient will be visiting the diabetologist later on. So I think any message regarding the interpretation of this particular thing and how he should approach, or whether he should inform the lab people to give the time lapse between the sample collection and the processing done. Thank you.
So, sir, I do understand, we do understand that anytime the general physician would be the first point of contact. So, yes, as sir also mentioned, Dr. Ashtekar also mentioned that as the symptoms, what the patient had exactly at that point of time, did he monitor or see it at home or by SMBG, whether the sugars were really falling? Maybe look at his prescription, what treatment is he on, ask other causes. Was he exercising more? Did he eat less? Did sometimes we all understand our patients have a habit of taking more tablets or insulin because they have eaten some sweets or something. Rule out that cause of hypoglycemia. And then too, if you see that there is hypoglycemia, rule of 15 was discussed during the first talk. Maybe you can advise them, ask them to eat on time. No, but patients may go into defensive snacking, which needs to be avoided. And then finally, maybe they have to get in touch with their treating physician to reduce the dosages. Just a word of caution here is what I have seen, that sometimes the general physicians tell them 2-3 दिन के लिए सब दवाई बंद कर दो और फिर देखो. Sir, I would advise don't do that. maybe you reduce the dosages, reduce the insulin dosages, sulfonylurea, maybe ask them to get in touch with the treating endocrinologist or diabetologist, and maybe then take it ahead from there. And more structured SMBG or CGM would be advisable for those patients.
So, madam, as a family physician, how should we taper down the dose in a case of hypoglycemia? Because generally you said that you have to stop that medicine, but if we want to now advise them, how much percentage of the
So
medication
maybe
should be?
reduce it to half the dose, sir, to
Okay.
begin with. Maybe if he's taking a full dose of sulfonylurea, maybe that day he may, reduce the dose of half. Monitor the sugars. Is he getting recurrent hypoglycemia? So that was only for that particular day. Because sometimes when we probe into the history, they say, "Mahine mein ek bar hota hai." So then what would be the cause of that hypoglycemia? So, sir, we need to take many factors into consideration when we're talking about hypoglycemia there.
Yeah, thank you very much. And that's one more question from my side is this is for Dr. Ashna Patil. It's very important talk in the sense hypoglycemia is not temporary for that one particular episode, but effect lasts for a week and couple of days, as you said very nicely.
Yes,
And treatment is something, but you said very specifically chocolate, not to give chocolates.
So chocolates, pastries, ice creams, they are also
Yeah,
having
you said
fats
no.
in it. So they are not simple carbs. They don't get digested quickly and don't rise the sugars immediately.
Okay,
A
so that
glucose
is a
powder or
yeah,
a
go ahead.
glucon D solution
So
mixed
that's
in
very
water
important
will
message
raise the
because
sugars quickly.
yes, that's why I ask you, because some of the patients they carry chocolates in the pocket as and when they feel something like doing this, they'll gulp it. So it's being a complex carbohydrate as you said, and takes little longer time. So it is better to even
One more, sir, with the
Glucon D
same line,
tablets,
one
which
more
are
addition, in common practice where, honey also can be used very well. So when the patient
otherwise
is not
that
that
Glucon D tablets.
conscious, just, a pinch of honey, put it in mouth because the sublingual absorption of honey is also good. So honey also can be used.
Or we can ask our patient to have that Glucon D tablets, that Glucovita Volt
Yes,
tablet.
tablets are
So
also
it
available.
it costs just 10
Many
rupees,
times they don't
and
have
it's
it.
waterproof
They can carry
watertight bottle,
glucose water.
and just costing 10 rupees. So many times actually whenever patient visit our clinic, so first day we in our
My patients are from villages, so it will be like honey kind of thing will be more ideal than, hypotabs.
What is easily available is Sprite bottles in every corner of the city and villages. So you can advise them to carry a 100 ml Sprite bottle where if you are traveling or you are going to the office, Sprite, that makes a sense, easy to.
And then you said
Juices,
repeated hypoglycemia. How to identify that? Can you just few tips to us? Somebody is prone to develop repeated hypoglycemias.
Repeated hypoglycemia.
Repeated hypoglycemia.
So, sir, again, history is very important. Take the history. Are they and what kind of medications they are on? Also, evaluate basically if they're going into nighttime hypoglycemia at 3 a.m. Ask them to monitor the sugar at 3 a.m. once at least and see whether they're going in or not. And if a person whose HbA1c is very good, like well controlled, you need to keep an eye and see whether this person is actually going into hypo or not anytime. Patients who are doing very good also sometimes land in hypo because sometimes the creatinine clearance is reduced. So renal patients, you should check the creatinine, GFR and all that to know whether they'll be going in hypoglycemia or not.
But coming to this HbA1c, in fact, I think Dr. Sanghvi said about that. Even HbA1c is not the point to diagnose whether A will develop hypo or 9 will develop hypo. Hypo can be developed in HbA1c, those who are less as well as those who are more, isn't it? So that's
Because it gives you an average value of the last 90 to 100 days. So, but if the patients have had more glycemic excursions in terms of having hyper and hypoglycemia, only an HbA1c may not be able to detect the same. And sir, for that, maybe as you mentioned about recurrent hypoglycemias, and then too we see a good A1c of 7, we are happy that a patient is doing well. Maybe a CGM reading will help us to understand that there have been episodes of more glycemic excursions.
and I think we need to train cardiologists also because post hypoglycemia, there are a lot of changes in ECG which they should not misinterpret about.
True, sir.
So I think thank you very
Alright.
much, and we will
Yes.
wind up. This is
Thank you
absolutely
so
to the
much.
time. Thank you
Yes.
very much for those wonderful interactions, and I thank my chairpersons to uh, give a company to us.
Thank
Thank
you,
you.
speakers and the chairperson. I would like to call you all for the group photo.
Okay, moving to our next session, rather a debate, forward to the use of CGM in diabetes care. I would like to call our chairperson, Dr. Abhijit Jadhav and Dr. Imran.
So our next topic is kind of a debate topic. Do we need continuous glucose monitoring for a type 2 diabetic patient? And we have two speakers, one of them who is in favor of CGM and one who will be speaking against CGM in a type 2 diabetic patient.
Speaker who will speak for CGM, Dr. Akash Evkare. He is MBBS MD and Director of Lifeline Madhumit Diabetes Hospital from Raipur. He is the President of Global Diabetes Forum. And he has many past accolades as well. He has affiliation with MCI, IMA, API, RSSDI, DIPSI, IS, and IPN ED as well. So welcome Dr. Akash Evkare to DRS family. Next speaker will be introduced later.
I will be talking in favor of SMBG.
Sorry.
So probably what we were stucking in last debate, last talk, everybody was talking. Probably I will going to give the answers for that. And it would be a very interesting, thought-provoking thing that in the era of technology, we are talking about a very, very simple thing that is SMBG. SMBG stands better than CGM in type 2 diabetes who don't require insulin. And with the end of 15 minutes, I'll make you that I am in the point which is very, very suitable to Indians like us. Despite increasing number of new diabetes medications and technology, achievement of individualized targets declined from 69.8% to 63.8%. Why? We are in a nation which we are daily doing great inventions. We are advising CGM to every of our patients, type 2 patients, type 1 patients, and many more, whether we are correct or not, and whether the simple tool of SMBG stands better or not. So, friends, despite increasing these things, still we are above that global target of more than 7%. We are not able to target that less than 7% of HbA1c in spite of all kind of treatment, and greater than 9% of HbA1c in India and in context of globe, they have increased from 12.6% to 15.5%. Why? Utilization of technology for individuals they are used to lessen disease burden. And first point is self-monitoring of blood sugar. If you're not monitoring by sugar, by your own methods, taking care of just labs, getting reports and in the evening from labs and having such kind of glitches that it has been taken in fluoride tube, kept for many more hours, you are getting factious reading, then it's all because that you are not promoting your patients to take SMBG by your own. And you don't need to know all of the options, but the familiar enough with one have a better resource for all. So let's take deep dive in simplest tool, which is SMBG. Although I am doing CGMS, but still when I took deep dive again in this era and this topic, I also get facilitated by this kind of slides and all and scientific data. So giving people with diabetes and their family the ability to make appropriate day-to-day treatment choices in diet, physical activity, as well as insulin, improving patients' recognition of hypoglycemia, because a hypoglycemia can't be known without doing SMBG. We were talking about reports, patient coming to us, talking about the reports sent at morning and that lab reports given to them at evening, and patient is coming talking to you, then it's not a question of hypoglycemia. You just check one SMBG and get the data. So is SMBG helpful in patients with type 2 diabetes in non-insulin treatment diabetes? Skeptics of the benefits, my opponent will say with some small studies that there is no demonstration of any benefit with SMBG, and they say that CGMS stands to be better. But this perspective often overlooks the fact that many type 2 diabetes patients are not adequately trained to interpret and respond to their test results. So does SMBG facilitate improve an HbA1c? Because our main target to say whether this tool is good or not, we have to have that kind of data that HbA1c is going to reduce by using fancy things. No, let's see the clinical evidence. Is a huge data from 1966 to 2004 in type 2 diabetic patients, and anti-diabetic therapies that included blood glucose self-monitoring as a part of multi-component management strategy, where they are using every drug. A mean additional HbA1c reduction was 0.39% from present HbA1c by using SMPG, and this multi-component diabetes management program with self-monitoring of blood glucose results in better glycemic control rather than, and it's a huge data, 1966 to 2004. So self-monitoring overall reduces HbA1c to 0.4% in HbA1c reduction, because a patient is aware of eating, a patient is known about what the emotion is going on, a patient is known about the hormonal milieu of his mindset, and that's why doing a motivational SMVG, if you are able to motivate your patient to go for a rapid sugar test by pricking a pin, so that's the only thing which is demotivating is the prick. Otherwise, the all fancy things with CGMS, which they say that it's a painless system which requires nothing, you just have to wear 114-day sensor and you will get a very good result about your own self. So self-monitoring of blood glucose in type 2 had a long-term outcome in epidemiological studies, and they have shown that it's a cost-effective method, and which significantly shows that there is simply non-fatal and fatal incidents which can be recovered from doing SMBG by these kind of simplest tools. So SMBG versus CGMS, the real task. If you talk about 7-point monitoring, which we used to say 3 times before meal, 3 times after meal, and 1 at 3 a.m. meal, that is 7-point monitoring. This is the poor man's CGMS, which we can say that is a holter of sugar report, you can say, and this is the way where we have gone to the invention of CGMS. And if a person is doing 7-point monitoring, although it's very difficult for everybody to do that, but in hospital settings we used to do, and if the patient is able to do these things in the home once in a week also, then calculation of LBGI and high blood glucose indices based on CGMS or 7-point SMBG profiles yielded a nearly identical risk category assessment. So there is nothing like that CGMS is superior than SMPG. Pros and cons, we all know here what are the pros and cons. There are flash glucose monitors, there are CGM monitors. Time-tested SMBG is a cheaper, less than 10 rupees is the cost of doing a prick and getting the results. No devices attached. Patient, whatever the patient, if you advise for CGM also, if they suffer from hypoglycemia, what we were discussing in last talk, they have to have checked their sugar with a simple glucometer, because there is a 15 minutes or 20 minutes time which is a lagging because they take with interstitial interstitial area, and this is not taking from ISF. This is taking just from the capillary blood. So this lag time is definitely a big time when we talk about a patient who is coming with an apprehension that I am suffering from hypoglycemia, although not look like clinical hypoglycemia. What do the guidelines say on SMVG and type 2 diabetes? every guidelines, whether ADA, IDF, National Institute of Health Care Excellence, everybody, they say, and this is the consensus. See, the patient, because the talk is that the patients who are not on insulin, I am not talking the patient which are on insulin, patients who are not on insulin, whether should be recommended for CGMS or not. So here are the recommendation. A patient who are not on insulin, then see once daily, weekly, short monthly, smoothly, or any way, whatever way you can go for simple monitoring of blood sugar. But the patient is type 1 diabetic and patient is already on insulin, basal bolus therapy, then definitely there are chances that you need to go for such technology. These are the different multifactorial interventions in major trials, clinical trials, UK PDS, VADT, and they all validated SMBG because at that time CGMS was not available, and they have Gatha, Gita, and Mahabharata of diabetes has been written on the basis of these SMBG protocols. So structure SMBG, there is a new evidence of efficacy. What are structure SMBG, where we design doing SMBG in a different pattern way, and these are the structure and unstructured. 7-point glucose profiling is a structured SMBG where we take pre-meal, post-meal, pre-meal, post-meal, post-dinner, and then bedtime. And that will give you a very good profile of that patient, what the patient is going through in the body regarding eating and all. So recent structure SMBG studies have validated that the results are quite fantastic, and they have shown that SMBG has a good grade point in non-insulin dependent type 2 diabetic patient. Limitations of CGM is that they used to take interstitial fluid glucose level via subcutaneous sensor attached to their extensor transmitter located at the upper arm or abdomen. So compared with finger stick monitoring, continuous glucose monitoring has not been shown to improve HbA1c level after 6 months in patients receiving multiple daily insulin injections, that is 7.7% versus 8%. The drop in CGMS lags behind the drop in blood glucose during prolonged aerobic exercise, or if patient is having any kind of emotional stress. At that time your CGM can't be reliable. That's why many patients come with CGM report. They are faulty reports. They are just bothered about the red signals coming in that reports, and that's why they say that mera to sir hamesha low hi rehta hai, how to increase my dose, but the patient is never suffering from that kind. And there are many more things because of that's a technical instrument. There are many persons to need to that advise that patient. Patients are unable to interpret the data. Continuous glucose
Raka, sir.
monitoring is a tool, not a reward.
Time is up, sir.
Sir, 1 minute more. Unjustified insurance coverage criteria limited. CGM eligibility criteria is not supported in large clinical trials. CGM devices are cumbersome, although in type 2 diabetes patients, economic things are great concern in conditions like India. So SMBG is an outcome measurement component of monitoring. Following a healthy eating plan or reducing the risk is an integrated component of effective therapy. Just drawbacks of CGMS: glucose in interstitial medium, analysis and interpretation, sensor wear time varies. A person on CGMS have to have require SMBG program because it can't be weared for every time. So core benefits of SMBG is like that. It improves postprandial and associated all kind of queries regarding sugar control. The summary and conclusion: it provides a real-time feedback. Abnormal glycemic profiles are better and correctly judged. And that's why if you are talking about CGMS, then if you can enjoy a real image, why you are worried about these AI-based simple images?
Thank you, Raka, sir. That's really beautiful, lady.
So हदों को तोड़कर आसान है बेहद होना, हदों को तोड़कर आसान है बेहद होना है, कठिन है पर हदों में रहकर बेहद हो जाना. इसलिए it's time to have stick in your own things.
So Dr. Raka has put up his point. Now to counteract the claim, I will invite Dr. Ritu Johri. So being a good friend and colleague, Dr. Ritu is a practicing diabetologist in Malad, Mumbai. And Ritu, over to you.
Thank you so much, Imran. for that warm invitation. And thank you so much, my opponent, Dr. Raka, for setting up this stage so well for me. So while the slides are getting up here, I would just like to mention that, of course, yes, गाथा है, गाथा बहुत सारी है, but I'm not sure कितने लोग गाथा को really पढ़ रहे हैं. तो शुरुआत वहाँ से है कि शायद हम उस जमाने में हैं कि where we really need to have the information right there at the hands or fingertips of the patients. So let me start my talk with that. Can I have my slides? Okay, great. So quickly, we all know that we are staying in a country where already global burden is increasing, and India is ranking almost first today in terms of the number of people living with diabetes. Of course, we know that there is a lot of underutilization of SMBG. So even though there are patients who are diabetic, most of them are unaware that they have diabetes. And then, of course, those who know are not even monitoring themselves enough. So what is it that we're talking about? We're talking about the era of SMBG. Yes, there is HbA1c. There are these tools that are available and very well explored by my colleague. But then if we look at it, there is very well proven data that SMBG can still have lots of misses because the patient, even if he's doing 7 times or 10 times, there can still be times when he or she is having hypoglycemia unawareness or unawareness about hyperglycemia, and therefore they are not able to pick up the times that are actually highs and lows, which are then picked up by CGM. And as rightly pointed out by him, this is how CGM actually came up into existence as well. Also looking at A1C, if we look at it, the same A1C can have two different glycemic profiles. So I'm sure you have seen this as well at a lot of conferences. Then comes into the picture, of course, the fact that why are we doing CGM? We are trying to get CGM so that we get enough information about this patient 24/7. And here, there is, of course, a correlation between CGM, TIR, and the HbA1c. So we are not definitely going away and defining or redefining another new metric. It's more about linking up the entire learning into CGM. So the A1C and the CGM TIR are kind of linked. So definitely time and range is going to give us not only information what A1C is giving or SMBG is giving, but beyond that as well. Then of course, again, bringing up the data, it says that we have TIR has shown that 10% reduction in the time spent in range is going to increase the microvascular complications, both retinopathy as well as nephropathy, by 64 and 40% respectively. Also, there is data where it has been shown even on macrovascular complications when they saw the CIMT, which is the carotid intermedia thickness, by 10% increase in the time spent in range, patient was actually able to have a 6.4% lower risk of carotid intermedia thickness. I'll be going a little slow in the interest of time. So here came in 2019 consensus guidelines, from the ATTD, which is the Makkah Medina for technology, and where they said that, when you're using CGM, you actually need to look at these targets. And mind you, these targets are not only for type 1s, but also for type 2 diabetes patients. Very clearly, they laid down that there have to be different targets for patients who have type 1 or type 2, different for those who are older patients, and different, of course, for the special category, which is pregnancy. There are more evidences as well. So like my colleague has spoken about Gatha of evidences, I will be also showing some evidences out here. So you can see that there are various evidences that have come up. Specifically, Replace study and Lung et al. Have shown that not only in type 1, but basically type 2 as well, CGM and TIR have been able to show not only that they are improving the glycemic control and time spent in glycemic control, but additionally also helping patients not to spend time in hypoglycemia or avoid hypoglycemia. some more evidences here. So you can see Asia Pacific consensus. When we say global, now I'm coming down to Asia Pacific, kind of narrowing down the picture for you. So here we have our own Dr. V. Mohan as well. And you can see that they have mentioned that this paper talks about CGM and its usage in persons with type 2 diabetes. And especially they say that continual intermittent CGM should be used in individuals with type 2 diabetes, either with insulin or without insulin as well. Moving forward, we also talk about Indian guidelines because I'm sure you will say that, why Asia Pacific? Let's get narrower. So here is our own, statement, consensus statement from India. Dr. Manoj is also a part of this one, where again they bring into the picture that yes, for type 2 as well, we should be looking at CGM. Of course, when they say that there are glucose lowering drugs, then it is strongly recommended, especially in terms of insulin and sulfonylureas, because hypoglycemia is precedented, and you'd definitely get the benefit of avoiding the hypoglycemia. And on the other hand, if you look at type 2 with low risk of hypoglycemia, here they have left a little window for the physician's discretion of how you would want or not want that patient to go through with CGM. Similarly, another paper from India, this is from Dr. Sanjay Kalra and team. You can see that here also they are saying that adults type 1 as well as type 2. So both of them have been taken into consideration. This is the paper that I'm referring to, a multi-authored paper. And you can see that they have age-wise given categorization of how should we look at goals for TIR, TAR, and TBR, which is the time and range matrix for the different adult populations for type 1 as well as type 2. Then, of course, if we are looking at another paper, this talks about, again, consensus guidelines, specifically talking of Dr. Anjana's paper, where Indians have a very Asian Indian phenotype, which we've all heard. But specifically, there is something called as differential clusters that have now been identified. And out of these clusters, there are two specific clusters that are unique to Indians. And that is why it is very important that we use CGM for this cluster of patients or Indian patients to be able to give them the best individualized treatment. That is the mantra of diabetes treatment or ADA as well. And finally, bringing you the evidence from the tech king of India, which is Dr. Jyoti Dev, where, he's also studied along with other authors, esteemed authors and mentors. They're talking about frequency of CGM usage in type 2 diabetic patients. So again, like I said, I do understand we are a poor man's country, but then what is important is, are we really doing justice in offering everything that is available under the sun to our patients? Let them take that decision whether they want to use CGM or not. And here you can see that basis the A1C, basis the TIR, which is if the patient is not at goal TIR, if he has TIR, which is, less than 50%, you can actually repeat CGM in 2 months. If if the TIR is little better at 70%, then you can try doing it in maybe 3 to 4 months. And then if it is reached over 80 and 90%, you can think of doing it maybe once in 4 to 6 months. And of course, if you're feeling, apart from this, there is any other indication, there is hypoglycemia, then of course, you can go ahead and change the recommendation and use it as per your discretion. So there are a lot of clinical benefits of time and range. You have the A1C, which is going down. You have the glycemic control, which is improving. There's also shown that, it is going to reduce the hypoglycemia overall and improve the quality of life of patients. And of course, indications are multiple. You can optimize diet and lifestyle. You can actually reach the right dose of insulin. You can also titrate the doses of glucose lowering agents that you are using, especially with the SUs, because you don't want to, increase the load on the pancreas. And with the SGLT2s and DPP4s, you don't want to overdo the SUs or underdo the SUs as well. So coming to the softer part of my rebuttal to my colleague, we are a country, of course, we are still called a poor country, but we've moved far away from that though. And we are a country where there are millions of people, not the updated statistics though. But then yes, there are still undiagnosed people, and the major problem still remains cost. So yes, I am talking about cost of expenditure for a patient with diabetes. If we look at it, only 2% people are covered under health insurance, and 85% actually spend out of pocket. This was 2013 data. This is again, the red shows how they are paying out of their pockets. This is the insurance, which you can see that people are increasingly utilizing their insurances because they understand now the importance of having a coverage, especially when they have diabetes. So my quick question to you, we all have heard when you get hurt, you apply some turmeric, hum haldi lagate hain. So my question to you is that if in case this kind of a situation happens to you, and in the scenario where you have an access to a hospital, would you still apply the turmeric which is readily available at home, or would you go to the medical fraternity which is just, available at the corner? And then, of course, we are talking about development. Today, we are talking of the AI. So I will stay away from AI. I'm still not gone there. But for me, important is why is it that we are restricting CGMS only to this class of professionals or businessmen, when our smartphones also have penetrated the villages and the common man? Similarly, if you look at the laptops or the internet, the villages are equally using, especially digi apps. Digi agriculture is now a lot of trend. Internet using, of course, the data says it all, that almost more than 200 million people are using internet globally in India. Looking at digital payment, I think this is another point which was put up forth very proudly for India, that our digital payment has really gone from, a very high level to where we are today.
Ritu.
So India continues to top the digital payment charts. You can see here various different countries, and India is topping the chart. So, for me, it's very important that if this is a boon, if CGM is a boon, which is helping us to visualize the patient's glucose 24 by 7, and not only
Ritu,
helping the
time's up.
doctor to understand how the glucose profile is, but also help the patients to gain more confidence of what foods they can choose, what kind of activities they can do, what kind of medicines are really good for them or not good for them, and how they can build trust and rapport with their doctor in this discussion. We should not restrict the CGMS only to type 1s, but also increase it to the paradigm of type 2s so that they can benefit from the same. With that, definitely I would urge everyone to adopt new technology and move further.
So that was put forward by Dr. Ritu. Yeah, Dr. Raka, you have 2 minutes to counteract the claim.
नाजिश अजीब है मगर वाकया तो है, नाजिश अजीब है मगर वाकया तो है, दिल्ली पहुंचकर लोग वतन से बिछड़ गए। जब लोग पहुंचते हैं संसद में तो ग्रास रूट लेवल से दूर हो जाते हैं। मैं इस शेर के साथ ये कहना चाहता हूं कि वक्त के साथ हमें बदलना होगा। टॉपिक यहाँ पे है नॉन एसेंशियल। इट्स नॉट दैट कि टॉपिक ये है कि हमें यूज ही नहीं करना है। यस, वेरी ऑफन आपको जब चोट लगती है तो आप हल्दी मत लगाइए, लेकिन हॉस्पिटल में जाके बेवजह सर्जरी मत कराइए। आप एक मलहम लगा के बिटाडीन से भी ठीक हो सकते हैं जहाँ पे, ये आपका कॉन्शियस है। और रही बात, हम यहाँ सारे दोस्त हैं। लेट मी टेल यू हाउ मेनी पीपल, we are more educated, we are learned, we are doctors. How many people in your home for type 2 diabetic patients in your family are using CGMS for them? See, the topic is not that. Topic is that whether we are trained to do SMBG or not. Even we are not doing SMBG properly. Take a deep dive in a simple tool and take the best benefit. If you have not done any 7-point measurement in your own family member for any time, then it's no right that you can push your patient as a guinea pig to go for a CGMS. Yes, I do recommend CGMS. Dr. Chawla called me for this topic and he asked me whether you are using CGMS. Yes, I said that I am using CGMS best in Chhattisgarh state. Most of the patients are on CGMS, but there should be a selection criteria which patient should be given that kind of importance, because your own line that our patients are not quoted by insurance, and these CGMS sensors, they are not quoted under insurance. If you have to pay by your own pocket 11,000 rupees, why you will go for that? Yes, companies are coming with a non-expensive CGMS. There is one stall here also which will be giving a non-expensive CGMS. Then probably we will be able to, yes, time in range and time in range is a criteria from that tool. अब आप बोलेंगे कि मैं साइकिल चलाने वाले और स्कूटर चलाने वाले को बोलूं कि आप माइलेज और टॉर्क कैपेसिटी बताएं कार का, उसे यूज ही नहीं करनी है कार, तो क्यों करेगा वो, बताएगा। ठीक है, थैंक यू मैम।
थैंक यू सो मच डॉक्टर आका। आई थिंक आपकी शेरो शायरी में तो मैं डेफिनेटली कुछ जवाब नहीं दे पाऊंगी, बट मैं इतना ज़रूर कहूंगी कि हाँ, मलहम लगाने में आप बीटाडीन ज़रूर लगा सकते हैं, बट मैं सर्जरी की बात कर ही नहीं रही थी मेरे दोस्त। So मेरे काबिल दोस्त, मेरा simple सा suggestion यही है कि I am not saying do CGMS for every person. We are not saying do it a blanket cover. I will still stick to my topic. The topic is, do we not need CGM for type 2 DM? So it's not like that. Even in type 2 DM, बहुत सारे patients ऐसे आते हैं. There are a lot of patients where using CGM will give you a lot of information. And मैं ये नहीं कह रही हूँ कि SMBG नहीं करना है. But the point is, अगर आपके पास availability है, access है, और मेरे पास ऐसे patients आते हैं sir, जो बोलते हैं कि man, we never heard about this technology. So I think somewhere it is medical inertia that we are not offering these to our patients. और अगर हमें cost की बात करनी है, जो sir आप बोल रहे थे कि मैंने दिखाया कि 80% of patients poor, लेकिन ये cost वहाँ जा रही है admissions में. I have not shown the cost which the people are actually spending in hospitalization due to hypoglycemia. My other presentation talks about hypoglycemia related falls, related MIs, related fractures and surgeries. तब तो sir SMBG करके surgery हो ही जाएगी. So therefore, I would suggest that yes, it is very important to ensure that what kind of patients you are screening for CGM, but do not have this dictum कि नहीं मैं तो SMBG ही करूंगा because मैंने assume किया है कि ये patient afford नहीं कर सकता. Because इसी patient के पास कल hospitalization के पैसे नहीं होंगे और आज 5,500 में केवल only 5,500 if their phone supports NFC, CGM is possible. It's not 11,000 also. So with that, I think a simple 5,500 is definitely much lesser than a hospitalization.
Thank you, thank you. That was really splendid.
Yes.
Take a audience voting on you. The previous beauty was shown by Raka was beautiful, or you gorgeous being beautiful here?
Sorry?
Take a voting out of you.
Oh, voting.
View.
Sure.
Acha, simple question to you. Most of you are a physician and general practitioner as well. How often you recommend SMBG to your patient? Please raise your hand. I'm not talking about CGMS. I'm just asking SMBG, how often for a diabetic patient you recommend for type 2 diabetes patient to buy a glucometer? So I would say 60 to 70% people are here. And how often you prescribe a CGMS? Okay, including me myself as well. Chota wala, sing. Yeah, please.
Yes, it's only 5,000. Totally agree, ma'am. No, in the topic, there is no exclusivity that we have been talking about.
Nothing to be sorry.
Absolutely agree. Yes, so that's what we said. Wherever it is indicated, I just mentioned that there is no blanket cover that you need to use.
Madam, we'll wind up here. We can have a personal interaction definitely with the speaker as well.
So match is tied.
The match is tied, definitely tied.
Thank you.
Thank you, speakers and the chairperson. I would like to call you for the group photo.
For our next session, I would like to call Dr. Akhil Contractor from Mumbai and Devyani Sankpal from Mumbai for chairing this session. Our next topic is also a debate. Triple FDC of SU or MATE or SGLT2, a rational combination for India.
Good afternoon, and now we start with a very practical debate. Uh, triple use, triple drug use, SU, MET, and SGLT2. So we have Dr. Abhishek Srivastav from Jabalpur. I welcome, sir. And he will be saying in favor. So over to you, Abhishek. So he's a consultant endocrinologist from Jabalpur, community board member, American Association of Clinical Endocrinology, first Indian to receive prestigious Eugene D. Davidson Public Service Reward Award, and president of Asia Pacific Society of Endocrine Research. Welcome, sir.
Thank you. So, thanks, Dr. Manoj Chawla, sir, Purvi Chawla, ma'am, for inviting me. And I'll be talking in favor of triple fixed dose combination of sulfonylurea, metformin, and SGLT2 inhibitors. 15 minutes, hai na? 15 minutes, right? So, to start with, we all know the growing prevalence of diabetes. We would be the diabetic capital of the world in the next 10, 15 years. And along with diabetes, the comorbid complications do also have very high prevalence, and it would almost double in the next 10 to 15 years. No need to discuss all these things. And what's the problem is, see, we know that type 2 diabetes is characterized by the progressive beta cell failure, even when a patient is at a pre-diabetes phase. And what do we actually do is, हम लोग conventional therapy की तरफ जाते हैं. We result in a sequential adding of different oral and injectable medications to achieve optimal glycemic control. And this necessitates administration of multiple tablets or pills to achieve good glycemic controls as the disease progresses, because there is a gradual decline in beta cell. And in addition, subjects with type 2 diabetes may have other comorbid conditions such as dyslipidemia, hypertension, cardiovascular disease, which further increase the burden of medications. And that results in polypharmacy. And polypharmacy with increased pill burden and dosing frequency is identified as one of the factors, most important factors, responsible for poor adherence to oral hypoglycemic therapy. And even in countries like the Europe or US with high access to healthcare, the data showed that only 39% of the patients reported good medication adherence. So what's the solution? Yes, is there a solution? There is. And one method to improve drug adherence is to use the fixed dose combinations. Even the US FDA defines FDC fixed dose combination as 2 or more drugs that may be combined in a single dosage form when each component makes a contribution to the claimed effects, and the doses of each component is such that the combination is safe and effective for a significant patient population requiring such concurrent therapy as defined in the labeling of the drug. So, abhi jo which we are discussing, the combination therapy of sulfonylurea, metformin, and SGLT2 inhibitors, it actually has all these properties. The drugs in the combination should act by different mechanisms. Yes, it acts. The pharmacokinetics must not be widely different, surely. And the combination should not have supra-additive toxicity to the ingredient. And this combination therapy has all the things. To be more precise, agar hum bahut jaldi jayenge, to be more precise, 2 recent studies, the Verify and the GRADE, having nearly similar follow-ups, have more clearly suggested that the conventional approach of sequential addition of drugs in the treatment of type 2 diabetes is an inferior strategy. Additionally, the Verify study showed initial combination therapy is superior to sequential addition therapy. And intuitively, combination therapies that have different mechanisms of action and addresses various metabolic defects concerning with the pathophysiology of type 2 diabetes, having complementary or synergistic actions, having the potential for a larger reduction of glycated hemoglobins without potentiating hypoglycemia, and can counter undesirable effects produced by the individual agent. Possessing cardiorenal protection, yes, having good tolerability without any additional adverse effects, and can reduce pill burden as a fixed dose combination, allowing better compliance and administered to the oral dose, are most likely to be a preferred modality for treatment of type 2 diabetes. And to end this, the triple drug combination of metformin, oh, the first one was SGLT2. I'm sorry about that. The triple drug combination of DP4 inhibitors, sodium glucose transport inhibitors appear with metformin appear most promising. Indeed, combination therapy of metformin, DP4, and SGLT2 has the potential to correct 7 pathophysiological defects of well-defined amino octet without provoking significant hypoglycemia. I'm really sorry about the previous slide. I was discussing the fixed dose combination of DP4 inhibitors, SGLT2, and metformin. So this triple combination significantly is the best fixed dose combination when you talk about the reduction in pill burden and the treatment of type 2 diabetes. Now, what's the rationale? Certainly, this triple dose combination addresses almost 7 out of 8 pathological pathways of the amino octet. Yes, it takes it corrects the defects of insulin secretion. Yes, incretin effects, decrease hepatic glucose production, decrease lipolysis, increase glucose uptake, then decrease the glucagon secretion, certainly, and then decrease the reabsorption of the glucose. So almost 7 pathophysiological conditions are being taken care by these 3 drugs addressing the as a triple dose combination. So what it happens? Reduces the risk of non-adherence, increased number of patients achieving glycemic targets, lower long-term risk of complications of type 2 diabetes, including micro as well as macrovascular complications. Certainly, they all possess the synergistic effect of SGLT2 inhibitors, DP4, and metformin. Certainly, I've already discussed it. Most importantly, it decreases glucotoxicity, thereby decreasing inflammation. Has pleiotropic benefits like weight loss, decrease in systolic blood pressure, although very mild, but yes, there is a decrease in systolic blood pressure. Certainly, decrease hyperglycemia. Then metformin is actually considered as an insulin sensitizer, so that also is taken care by metformin. So SGLT2 inhibitors, DP4, and metformin takes all these synergistic effects taking ahead in the treatment of type 2 diabetes. So, and more importantly, India paves the way for improved patient care. इंडिया ने पायोग्लिडोजोन, मेटफॉर्मिन और सल्फोनिलयूरा का भी ट्रिपल डोज कॉम्बिनेशन दिया, and it has worked very well. And the same way, this triple dose combination of DP4, SGLT2 inhibitors, and metformin would possess a very good, bright future if you talk about in the treatment of type 2 diabetes along with the comorbid conditions. Now, some Indian evidences quickly. There are majorly 3 trials: MEDISA, UD-TRI FDC, and the triple FDC. Yes, the fixed dose, what the MESIRA trial says, fixed dose combination of DAPA, CETA, and metformin. The primary objective was to see the change in HbA1c levels from baseline to week 16. The secondary endpoint was change in body weight from baseline, change in fasting plasma glucose, change in postprandial glucose, and to evaluate safety and tolerability of investigational products. And what was the result? The result was the fixed dose combination of these 3 drugs have shown superiority versus the dual fixed dose combination in the management of type 2 diabetes who were uncontrolled either on metformin monotherapy or even the fixed dose dual combination. This then again, this triple FDC trial, which was done by R.K. Sahai sir, and it also has shown that the fixed dose combination of DAPA, CETA, and metformin in patients with type 2 diabetes poorly controlled with metformin, what it did was a good once daily triple combination of DAPA, CETA, and metformin was significantly better in achieving glycemic control versus a dual combination in patients with type 2 diabetes poorly controlled with metformin without any significant safety concerns. So that becomes much more important. Even with, see, monotherapy, higher HbA1c level bhul jaiye. But even if you are on a dual dose combination therapy, then also triple dose fixed dose combination has proven to be a bit superior as compared to the active comparators such as the dual dose combination. And at week 16, the mean change Significantly greater reduction in HbA1c was seen. Significant reduction in fasting plasma glucose was seen. Significant reduction in body weight. Yes, around 7 to 8% was seen with this triple dose combination, and patient achieved almost and desirable HbA1c levels of 7% or 7.5%. Almost 38.5% patient achieved the desirable HbA1c level with this fixed dose combination. Now quickly we move on to UD trio fixed dose combination. This was also the clinical study to evaluate the efficacy and safety of the fixed dose combination of dapacetin and metformin ER tablets in patients with type 2 diabetes, inadequately controlled on metformin monotherapy or fixed dose combination dual therapy.
Time up, sir.
Just very quickly, I'll find it out. What was the primary endpoint? Mean HbA1c reduction was far more better as compared to dual fixed dose combination. And if you look at the secondary endpoint, the mean reduction in fasting as well as plasma glucose levels from baseline was much more higher in the triple fixed dose combination as compared to the double dose. So triple dose combination found to be superior as compared to the dual fixed dose combination. And these are the few trials. We can clearly see that the statistical outcome of 90, as we say about all the trials about the fixed dose combination, triple or dual therapy, the most important thing is it improves the adherence of the patient. And once the adherence is improved, we have all seen in numerous studies that even a 10% improvement in adherence almost improves the HbA1c level almost by 0.9 to 1%. So that is the main point which I want to point out to. And even the legacy effect of these are very quickly. I'll not talk about the use of SGLT2 inhibitors. We all know have certain pleiotropic benefits of SGLT2 inhibitors in micro as well as macrovascular complications. Efficacy of dapagliflozin was much more superior as compared to sitagliptin. But yes, they synergize each other's effect when we combine all these three drugs. So dapa, sita, and metformin achieved a higher reduction in HbA1c as compared to the dual combination therapy. Yes, had achieved a good pleiotropic benefits also in terms of weight reduction, in terms of systolic blood pressure reduction, and even in terms of the improvement in adherence. I'll not, and the recent guidelines in management of type 2 diabetes recommends in patients with type 2 diabetes and CVD with high CV risk to reduce CVD events, the combination therapy, the triple combination therapy or the dual combination therapy proved to be better when we talk about the levels of HbA1c, achieving the desired level of HbA1c level. So early combination therapy can be considered in adults, but yes, combining the three drugs as compared to a dual therapy improved the HbA1c level much more as compared to the dual therapy. Thank you.
To counteract the claim, I would like to invite Dr. H.N. Chakravarti from Calcutta. Dr. H.N. Chakravarti is he's working in Super Specialty Hospital, Havra, Narayan Super Specialty Hospital, Rabindranath Tagore International Institute of Cardiac Science, Amru. Yeah. Yes.
It's not coming there.
Ex-consultant media super specialty hospital, ex-associate professor Department of Medicine, Calcutta Medical College, gold medal in biochemistry, pharmacology, obstetric gynec, and silver medal in pathology, pharmacology, ENT medicine, gynec, and many others. Gold medal in MD medicine, even in final exam. Regular speaker at APICON, RSSPI, Diabetes India, EasyCon, and IdeaCon. Please, sir.
Okay, thank you. Thank you for those kind words of introduction. But I think the debate has ended even before it could begin, because my opponent talked on DPP4, SGLT2, and metformin. The topic was sulfonylurea, metformin, and anything. Anyways. So I'll just anyways, I'll do a course correction and give you some insights on whatever I can tell. Okay, so just look at the color coding, triple, then FDC, and a rational. So we'll talk on these points actually. So
Anyways, he talked on 3 FDCs, though one component was mistaken. But the way he was talking about good points about this point, I was just thinking that he would ring up the water supply department of Mumbai and saying to mix with tap water to reach every home. Anyways, thank God he didn't say that. Okay, so I try to shift from a soundbite to science. When you have all these in your therapeutic armamentarium, I have written the drug names superiorly. Do you really go for a Munger made in Bihar? Munger is known for making all these. So do you really go for all these molecules at all? So it's time to change. So you must think about it whether you will at all use sulfonylurea. Why you should not? I will be talking about it. Talking about individual patient needs, obviously every flower is different. Every diabetic individual is also different. So every diabetic individual will have some unique properties, and we know that there are some clusters of patients who respond well to one group of medications while some respond to some other group of medications. And we need to understand they may be young, old, CKD, non-CKD, heart failure, non-heart failure, multiple comorbidities, different drug effects and adverse effects. So a blanket statement of FDC will not actually serve any purpose. So given triple drug is akin to taking all these animals to a one-size-fits-all store. It's not possible. So we have to break it up. So let us dissect and go into individual components. I'm a very good fan of Flozins, no doubt. Just like the mid-cap and small-cap market is just booming in the last 2 years, maybe Flozin has boomed in the last 10 years. So that part is well acknowledged. I just hope they do not collapse again, just like share market. Now, do all patients lose weight similarly with Flozins? You ask yourself, maybe not. Some people just don't lose weight with them. Some people say, डॉक्टर साहब आपको दिखाने के बाद इतना मेरा वेट लॉस हुआ है सब लोग बोल रहे हैं कि हम ज़्यादा बीमार हो गए so this also we face in our practice and some other people need additional weight loss measures we often give Rybelsus for them and other things for weight loss so they will not behave similarly I am very much fan of them because all these trials that are now in the market, be it with DAPA, even with CANA, I'm not mentioning here, IMPA, all are good molecules because they have established their position in the market. Talking of metformin, it is just like Pitamaha Bhishma, it is tested on time. And if you go through these good, I just picked out from Nature Reviews Endocrinology, the past, present, and future. It's a very good article published just in 2024. But sulfonylurea, no, this is what I'm not going to acknowledge and give any ground to it. So journey of sulfonylureas have been bad from the very beginning. So it has been a bumpy ride, be it the university group diabetes program, be it the DIGAMI trial where more deaths were reported. So ultimately you come to a point where you are having newer generation sulfonylureas, where you talk about durability, but you see that the secondary beta cell failure with time. After say 10 years or 20 years, how many of your patients will respond to sulfonylurea? So there will be failure. I recall this study from 2013 by Ralph DiFronzo who had written that we doctors do not treat to succeed, we treat to fail. We give a drug, the HbA1c comes down, again it creeps up, we add another drug, it comes down, again it crawls up, again we give another drug. So we go on adding. So this is basically a treat to fail approach. And no mention about weight gain and hypoglycemia. Obviously this class of drugs can cause them. We are all knowing about it. Now, many people claim that glimepiride is a new generation sulfonylurea, so it doesn't cause much hypoglycemia. But actually, we cannot bail him out as well. Because we know that if the patient has some cardiac risk, the necrotic tissue versus the normal tissue, that junction can be potentially arrhythmogenic. So these can lead to problems as well. So we should be avoiding such molecules where we are wanting to have safer molecules on the anvil. So weight gain is not the patient's gain at all with sulfonylureas. A narrow window of use. Suppose this is the garden variety of diabetic patients who comes to you, newly diagnosed, uncontrolled, overweight, with CVD, with heart failure, with CKD. How many of them will you treat with sulfonylurea? Only these two. So all others are actually going out of the spectrum. So in this narrow spectrum, using sulfonylurea and putting in an FDC is actually not serving any good purpose. Now coming to the Carolina, my opponent did not mention it, but Carolina study was done to just market the drug that glimepiride is equally good to linagliptin. But I will just point out 2 or 3 important things. It is not a CVOT at all. Whenever any representative comes to you and say that we have Carolina study to say glimepiride is same, just blast them off with the logics that I'm providing today. If you look at the rosiglitazone saga, which happened in 2008, it was said that you have to compare any product that you want to market against a placebo. But what was done in this Carolina? It was compared against glimepiride. So it was an active comparator study. It should not have been done. So FDA did not allow the study to continue. Then they did what? Carmelina was born. But by that time, Carolina had recruited their subjects. So what they said, कि दोनों साथ में चलने देते हैं. Carolina and Carmelina went on together. That's why the results came back to back. But why did they do so? The people were very cunning. They thought if glimepiride can be shown to be bad, then obviously difference between Lina and glimepiride will come to be very good. So I will just tom-tom my product and say, see, glimepiride, see, linagliptin is very good comparison to glimepiride. But man proposes and God disposes. So what happened? The top line results showed that Lina was non-inferior to glimepiride. So almost grudgingly, the innovator company of linagliptin had to co-share the trophy with glimepiride. And that is the problem. So you wanted to show it as a superiority study. Ultimately, you ended up sharing the trophy like this. So who would be wanting to share this? You would not want to do that. Now, there was another scam in Carolina. Interestingly, the study was designed to include patients at lower CV risk so that the results could be extrapolated to more patients in clinical practice. Just see this pyramid. You should actually design a study in the red zone of the pyramid. Those are actually high risk patients. And then you show that I am not causing any further harm or I am showing benefit, any. But what the innovators did, they actually designed a study in the blue zone and in the green zone. That is taking more patients who are having less duration of diabetes. Why did they do so? Obvious to sell their product more. So it was more commerce than science. This we have to understand. If you compare empagliflozin, artogliflozin, no, there almost all patients had established CVD. Whereas in the Carolina, where they say that our product is so good, only 37% had the product. So it was not a study designed at all to prove what you are trying to establish. And no end to scams. There is a third one. What did they do? They changed the 4-point MACE to 3-point MACE. They just removed the hospitalization due to unstable angina. Why? This is very bad because what may happen is you design with 4, you remove 1, then what happens? That one of the individual endpoints accrues disproportionately more than the other endpoints. To make it easy, I'll just give an example. This father has 3 sons. He said, when you grow up, you will bring me $3,000 per month, 1,000 each. What happened? One boy was very good. He brought 2.5 thousand per month, whereas the other 2 children brought only $500. That means you are disproportionately skewing the result in favor of one, whereas the others are not performing. So this trial is not good at all. This is to be explained why the 4th point was dropped. It was so bad that Julio Rosenstock, when this study was published, he said that Carolina supports the use of a DPP4 inhibitor before a sulfonylurea. And what did the incoming ADA president say? There is only one reason I would use a sulfonylurea, that is cost. Maybe India, we are a third world country, so still it is lingering and languishing. Otherwise, it would have gone out of the guidelines. And coming to FDC, my learned friend, opponent has said so many points. I would just say that it is like an inflexible regimen. If you give 3 drugs together, you don't know how to escalate, you don't know which side effect would happen, you have to cancel all the drugs. And cost, don't even mention that. Anybody who takes books, reads books from Amazon, read this book, The Truth Pill. And there was a publication in the editorial in the Hindu by these 2 writers who said that so many FDCs are brought only to bypass the cost issues. What they do, suppose metformin is supposed to cost 1 rupees, sulfonylurea 2 rupees, and DPP4 5 rupees. It should come within 8 rupees, but they bypass this essential drug clause by making an FDC and make it 15 rupees, 16 rupees. So do not think that FDC sulfonylurea is there, so it will cost less. So you have to remember, I'm just skipping the slides. We have to keep all these things. Evidences are based actually on guidelines are incorporated, and no guideline actually says of triple FDC. Only solace my opponent may find is in the AC guideline, only one line is mentioned. If HbA1c is more than 9 or 1.5 above goal, more than 2 anti-hyperglycemic agents may be used. But I have some counter arguments. Which 3? It's not mentioned. What is the upper limit? If HbA1c is 15, will you give 3 FDCs? No, we will give insulin. Along with that, you may give oral agents. And FDC is nowhere mentioned. So you need a binocular to find where he is actually talking of FDC. And patients also feel an inflated feeling of disease severity. I have a very bad handwriting. I wrote this to one of my patients. He Googled and sent me, Dr. Saab, आपने 3 ड्रग दे दिया, मेरा सिर्फ HbA1c 8.9 था. So this gives a perception that the disease is very much advanced. So we should take into consideration all these things also. Lastly, I'm ending by saying that guidelines will treat diseases, but we as doctors will treat patients. So before you decide, every day brings new choices, and you have 2 choices available. Either it is my way or this is the FDC way, which my friend has shown. So ultimately, the line should be like this, 3 drugs separately, not SU, DPP4, which by mistake he has mentioned throughout the presentation, can be a rational combination in selected patients. I end with this. When I go to buy this product, Kama Ayurveda, I'm not advertising for it, just saying from Amazon, my wife and I sit down. Whenever I go to the payment page, then this comes frequently brought together. So when my wife is buying, she will buy all the three. But when I buy, I will buy only the thing which is necessary for me. So it is your call to decide what you will do at the end of the program.
Dr. Srivastav, your rebuttal.
Very good. So my friend has uh, very brightly elaborated, and he actually told everything about sulfonylurea, the backlogs of sulfonylurea, DP for everything else. But my point is, does fixed dose combination works or not? My only point is whether we should use the fixed dose combination or not. That's the only point for me. There's no debate saying yes, who was the active competitor, which study should have done, which study should have not done. But my point is, should fixed dose combination, fixed drug combination should be used in the treatment of diabetes mellitus just to reduce the pill burden? My answer is yes, it should be used. But again, I would say it should be used judiciously. Yes, I'm not going to say the combination of sulfonylurea with metformin and SGLT inhibitors are the best combination therapies. But as far as I know, dual therapy, fixed dose combination, even triple therapy, I am using it. They are giving the exceptional results. Not in terms of, of say what he elaborated the things, but I mean to say the proper adherence does improves with fixed dose combination. Use karna chahiye, nahi karna chahiye, that depends on you. It's you who has to make the decision, not me. अगर आप सल्फोनिलुरिया अलग से दोगे, आपने वन प्रिस्क्रिप्शन जिसमें 14 गोलियां हैं, 14-15 गोलियां हैं, वो पेशेंट वैसे ही भाग जाएगा आपको देख के.
Thank you so much.
That's the thing.
So let me present a unified view before I end. So we are all Indians. We should not go back home today with a fractured mandate. So we are running a coalition government. So here also I need to have peace with him at the end. So what I need to say is that I am also writing FDC, but there is a but. Where is that? So first, when you are treating a diabetic individual, give the individual components separately. Titrate the dose for each of them. See whether side effect is happening for any of them, and then you combine to produce an FDC, say after 1 month, say after 3 months. So initially you are bombarding, you cannot start your car in the third gear initially. You have to go from first to second to third. So you just put them on 3 drugs, I have no problem with that. But then ultimately you combine them to reduce the polypharmacy and the pill burden, and if possible, the cost. Thank you.
So I won. I'm the one.
That was a very interesting debate. Actually, it was a debate between the original Don or Sahansha versus new Bajigar in the field of medicine. So who wins? Let the audience decide. And I would like to ask you people to ask any question regarding the same, any case scenario would like to present in front of them, how to treat or manage the diabetes in those patients. One interesting case from my side, very simple. Suppose there is a 68-year-old female comes to you with a history of 11 years of diabetes, and she's just on dietary management and average HbA1c of 8.7. How do you start the treatment? Provided she has ASCVD risk in the form of hypertension as well as hyperlipidemia. Metformin, metformin dietary management only.
Yeah, please.
So 8.9 is a suboptimal management, number one. Number two, she is 68-year-old female, so postmenopausal. So I will be concerned a little bit about the urinary issues as well. And 8.9 HbA1c only on lifestyle and metformin is not enough. So maybe I will be wanting to add certain things. Now questions will arise as I was speaking just in the other hall there when I started as an opening batsman with sitagliptin. So you need to scratch your head and ask what are the things now. Suppose 10 years back, ADA used to publish guidelines where after LSM, metformin, you could have chosen any of the 6 classes of drugs without any bias or prejudice. So it may be SU, DPP4s, glitazones, GLP-1s or a basal insulin. But now things are changing. So now you need to ask whether the patient has ACVD, whether the patient has hospitalization for heart failure risk, whether the patient has propensity to hypoglycemia, whether the patient needs to lose weight, whether cost is an issue, whether CKD. So 6 questions are now in your mind. So according to that, the algorithm will progress. So the clinical scenario you have got given, there are incomplete information in that. Maybe what is the urine ACR? So maybe I'll want to know a little bit detailed study, just like CBI and ED questions the person accused. So I'll be asking more questions about it. But flatly, maybe here in this patient, I will be wanting to add a gliptin, not an SGLT2 with metformin. I will be wanting to take a gliptin with metformin because number one, as I said, postmenopausal urinary issues may be there and the patient may not be having good hydration, hygiene, etc. And also the tendency towards hypoglycemia may be more with sulfuriluria, so gliptin will be a better choice for me.
Thank you, chairpersons, and thank you, speakers. I would like to call them on stage for a group photo. Okay, for our next session, for chairing this session of newly diagnosed type 2 diabetes, I would like to call Dr. Arvind Argekar sir, Dr. Kulin Shah, and Dr. Sunita Jyoti Dev. I'm taking this opportunity to give this Certificate of Excellence Award as a diabetes educator to Dr. Shilpa Shettiga. Please, some claps for her. Dr. Arvind Argekar sir is giving her the medal.
Hello, good evening to all of you. So we start with the 4:30 session on newly diagnosed type 2 diabetes, a very common event in our practice. I now request Dr. Piyush Desai to come and present his talk on the approach based on subtype of type 2 diabetes mellitus.
Thank you, Chairperson, and thank you, Dr. Manoj Chawla and Purvi Chawla, for inviting me for this excellent conference, DRS with Prevention of Diabetes. And today I am going to talk on new onset diabetes, type 2 diabetes. But when we are approaching such type of patient, can we have subtype of that type 2 diabetes? Yes. For last 2.5 years, I will say, we have come across various type of different sub-classification of type 2 diabetes. As we all know, diabetes burden is increasing, and not only type 2, actually type 1 and LADA patients are also increasing. Insulin resistance is increasing, insulinopenia is also increasing. And that's why the typical type 1 diabetes, where there is only and only autoimmune loss of beta cell, and there is absolute insulin deficiency, which is now taking over. Even type 1 diabetic patients need metformin because of insulin resistance and severe weight insulin deficiency, which is now taking over. Even type 1 diabetic patients need metformin because of insulin resistance and severe weight gain, or type 1 diabetic patient developing PCOD. On the other side, type 2 diabetes, though they have relative insulin deficiency, but more and more younger patients are coming into this type 2 diabetic diagnosis over the period of time, sometimes 2 year, 5 year, 10 year, they need insulin therapy. So somewhere, somehow, in type 1 and type 2 diabetes, where we are talking about insulin deficiency and insulin resistance, actually, it's a gray zone. It is not a clear-cut demarcation that every time it is so. So yes, there is one type 1 diabetes, there is typical insulin-resistant type 2 diabetes, but type 2 diabetes is having many facets. At the same time, the Asian population are, even they are not obese, they have abdominal obesity, and they are lean insulin sensitive or obese insulin resistance patient. And that's why we have to see, go through the new type 2 diabetic patient as this symposia is made for. If patient is coming to you for the very first time, just don't assume that patient is having insulin resistance, and don't just assume to give metformin to all patients, because now even guidelines are changing that you have plethora of options available with that. So let's deep dive into sub classification of type 2 diabetes. And this is first sub-classification we came over, and we came to know by Scandinavian countries study, especially from Sweden and Danish study, where there were 5 clusters were defined below type 2 diabetes. So as a sub-classification, that is severe autoimmune diabetes, that is SAID, severe insulin deficient diabetes, that is SIDD, severe insulin resistant diabetes, that is SIRD, which is most commonly we are saying type 2 diabetes, and mild obesity related diabetes, MOD, again we consider as a type 2 diabetes, but usually they do good. And the fifth cluster, what they define from the registry, that mild age-related diabetes, that the onset is less. So SAID, severe autoimmune diabetes, it is definitely either type 1, or it can be LADA, it can be slowly progressive type 1 diabetes, and this type of patients are definitely insulinopenic. So here patients are not having insulin. They need insulin as a treatment, and what is specific things in this particular cluster, they have more hypoglycemia, they have more fluctuations, as we see in type 1 and LADA patient, they have more risk of ketoacidosis, and there is higher prevalence of diabetic retinopathy, as well as risk of fracture. There is another cluster, that is SIDD, severe insulin deficient diabetes. Now these patients are actually have insulin, but which is not zero like typical type 1 diabetes. They do have poor glycemic control. They do get ketoacidosis whenever there is stressors or aggravating situations. And these type of patients again have more risk of diabetic retinopathy and neuropathy, as well as fracture risk. And they need insulin therapy comparatively earlier in comparison to other clusters. What are the other clusters where insulin are not required early? That is SIRD, that is severe insulin resistant diabetes. Usually their glycemic control is relatively mild. Usually they get control with insulin sensitizer. They require lesser medicine, but because of hyperinsulinemia, they have higher chances of fatty liver and cardiovascular disease as well as diabetic nephropathy. And along with that, cancer risk, dementia risk, Alzheimer risk is also high in such type of patient. And this frequency cluster is different in Caucasian and Asian population. Cluster 4 is MOD, that is mild obesity related diabetes. Here obesity is the main thing. Glycemic control relatively good. Sometimes they do well only on diet exercise. Actually, the so-called diabetes reversal and remission is actually happening in such type of patient where their insulin reserve is good, but they are not exercising, their diet is bad, their family genetics was like that. They develop fatty liver, dyslipidemia, hypertension early because of overall metabolic problem due to obesity, not as a complications of diabetes. And the last cluster, that is MAD, that is mild age-related diabetes. Here, one thing is important, that patients are developing diabetes at later age. They have insulin secretory capacity which is reduced over the period of time, so as insulin sensitivity. Because age-related sarcopenia, age-related fat which is more than muscle is causing insulin resistance over the period of time, and they are having more like senile complaint, senile complications like frailty syndrome, mild cognitive impairment, osteoporosis, fracture, but do have ASCVD risk. So new classification subgroups are there. How to classify all this under type 2 diabetes? For that, we need age at diagnosis, we need body mass index, glutamate decarboxylase antibody, that is GAD antibody, positive or negative, C-peptide level, or if it is not available, then homeostasis model assessment estimation of beta cell, that is HOMA beta and HOMA IR index are used in this Sweden and Finland cohort. And they found that these 5 clusters are there, and accordingly they have subclassified this routine type 2 diabetic patient. So in that reproducibility was also there. So it is not like that only in Sweden these clusters were there. It was similarly found in Finland, and it was similarly reproduced in Denmark, German, Japanese and Chinese trial also. So these are the Danish study result, where they found actually 3 cluster instead of 5, where they put 3 things, that insulinopenic, hyperinsulinemic and classical type 2 diabetes. And accordingly, they have divided patient in 3 cluster, but actually, if you see, these all are overlapping. So what we should look for as in India, because Asian phenotype is different. We are having low birth weight, we are thin fat Indian, we have lower threshold of BMI for type 2 diabetes as well as diabetes, low serum insulin level and higher insulin resistance, and over and above higher inflammatory markers are there with sarcopenia, low muscle mass. We do have higher HSCRP level, we do have low vitamin B12 and vitamin D level, and we have more atherogenic dyslipidemia, that is lower HDL cholesterol and increased triglyceride level with small dense LDL in high proportion. So Dr. Mohan and his group has done similar study to identify Indian cohort, but we do have restriction. We cannot have all patients to go for GAD antibody. We do not have all patients to go for C-peptide level. So age, HOMA beta, HOMA IR and BMI are the only parameter on which we have to define. And they define 4 clusters, that is SIDD, IROD, CIRDD and MARD. So severe insulin deficient diabetes, which was 26%, 25% were having IROD, that is insulin resistance obese diabetes, 12% were having CIRD, means combined insulin deficiency as well as insulin resistance, and 35% were having mild age-related diabetes. So we have a large proportion on mild age-related diabetes also, but we do have 12% who is having combined thing. Now, when we are comparing complications, what I have elaborated before, which are the data from Sweden and Finland study, SIDD is having higher retinopathy incidence, but overall nephropathy incidence is almost same for all 4. Kidney disease and nephropathy is almost same, slightly more in obviously combined insulin deficiency and resistance disease. And along with that, if you see a CVD risk score, we cannot only contribute to type 2 diabetes or insulin deficiency. Actually, we have more inflammatory markers, it was high. So if you see the co-prevalence of disease in Indian cluster, type 2 diabetes and dyslipidemia is 84.7%, type 2 diabetes and hypertension 75%, type 2 diabetes and CKD 53%. Again, CVD risk with type 2 diabetes is 22%. So when we take type 2 diabetes and obesity, see, you can see type 2 diabetes, dyslipidemia and hypertension 64%. Type 2 diabetes, dyslipidemia, obesity 30%. And type 2 diabetes, CKD and dyslipidemia 29%. So these are the different clusters. So obviously this is not going to help us in our clinical practice. This is for research. Then how and why this clinical subclassification will be relevant to our clinical practice? Because it helps to accurately subclassify diabetes into different subtypes by which we can plan therapy based on pathophysiology, predict prognosis, as well as predict further complications. And this is first step. I will not say it's an absolute stage. It is very early. It is not even accepted by WHO or classification at present because it's a sub-classification, but it is a first step towards precision medicine or precision medicine in diabetes. So let's see how the therapeutic things will be different. We have to identify if patient is insulinopenic or patient is having insulin resistance as a primary source. If resistance is a problem, then you have to give metformin, you have to give glitazones. They do well on SGLT2, depends on the cardiac indication, because here patient is not having cardiac problem, his patient is just on new onset type 2 diabetic. But DPP4 inhibitor, alpha glucosidase inhibitor, and yes, most importantly GLP-1 can be helpful because of ectopic fat deposition is the major problem. If patient is having insulin deficiency, relative insulin deficiency, because I'm talking about type 2, I'm not talking about type 1, sulfonylurea, glenide, DPP4 and GLP-1 will be mainstay of therapy. And if patient is insulinopenic like LADA or type 1 or severe insulinopenic type 2 diabetes, then insulin therapy is must. Along with that, if patient is having fatty liver, if patient is having muscle fat or not, that all depends. So along with that, we have to see and look for dyslipidemia, hypertension and endothelial dysfunction, because this leads to multiple complications. So if patient is having SIRD, you can use biguanide, SGLT2, glitazone and GLP-1 and look for nephropathy, fatty liver and cardiovascular risk, especially heart failure risk. If patient is having mild obesity related diabetes, fatty liver is almost going to be there, and you have to treat obesity rather than diabetes actually. Cluster 5, that is MARD, mild age related. Here the safest drug to use is DPP4 inhibitor along with metformin, and look for fracture, look for nephrosclerosis, look for adult onset cardiovascular disease and atrial fibrillation, because this group are having more atrial fibrillation than failure. Cluster 2, that is SIDD, where insulin deficiency is there, definitely neuropathy, retinopathy is common, and here treatment is insulin. But yes, initially when you have misdiagnosed patient having type 2, typical type 2 diabetes and put HbA1 patient on oral drugs, later on within 6 months to 1 year, they require insulin therapy and actually they behave like LADA. And SAID, that is severe autoimmune deficiency, is nothing but type 1 or typical LADA patient where you need patient to be on basal bolus regimen. So just to conclude, compared to traditional classification of adult onset type 2 diabetes mellitus, we can go for cluster-based sub-classification reflecting pathophysiology, predicting the future risk of diabetes complications and comorbidities. And therefore, it may be suitable tool for optimizing personalized therapeutic strategy. All cause and cause-specific mortality as well as morbidity differs as per the subclassification, and this Again, I will say this is first step to precision medicine or personalized approach to treat type 2 diabetes. Thank you.
Thank you, Dr. Desai. Thank you for the nice presentation. A new outlook on first time seen patients of diabetes type 2. I'm sure you will stay here because we'll be asking the questions later on.
Yeah.
So moving ahead with the session, may I invite Dr. Alka Gandhi. So she's a diabetologist practicing in western suburb, Borivali, and my dear friend. So she'll be talking on the origin of diabetes, the gut feeling. Over to you, Alka.
Thank you very much. Thank you, chairpersons. Thank you, Manoj and Purvi, to invite. And sir, pleasure to talk in front of you. So today we have a new topic. The origin of gut in pathophysiology of diabetes. So we all know now that incidence of diabetes is increasing and we are becoming the world capital for diabetes. But what is the reason? Why is it that the incidence and prevalence is increasing? So yes, we all know because of the industrialization and Coca-Colization, there is lot of increase in the junk food, and we all believe that this definitely increases the incidence of diabetes. Now, the father of medicine, Hippocrates, have already said that all disease begins in the gut. So this highlights the crucial role of gut and diet in maintaining the body's vital functions. We all are aware of this pathophysiological cause of diabetes. So we started with triad and octet, and now this is egregious 11, where apart from this pancreas and incretin defect, alpha cell defect, again along with that there is a role of liver, muscle, adipose tissue, brain, but there is also a role of small intestine as well as colon. So this is what we are going to explore today. So we know that gut regulates the glucose and energy homeostasis, and there is increasing evidence that suggests that the gut may also play the role in pathogenesis of diabetes, because it is how it affects is by the microbiological profile and the pattern of gut hormones secretion. So the intestinal microbiota may be responsible for secretion of molecules that may impair the insulin secretion and action. Also, the intestinal milieu regulates the secretion of hormones like GLP, GIP, ghrelin, etc. And all of these are important in general and in particular glucose metabolism. Incretin effect, I don't think I need to discuss this in front of all of you because we are using these agents from quite some time. But incretins are, what is an incretin effect? It designates the amplification of insulin secretion following the oral glucose load. So when there is a comparison between IV glucose load and oral glucose load, we can see that those who has taken oral glucose, there is increased insulin secretion, and this is done with the help of incretins. What are incretins? They are the gut hormones that enhance glucose stimulated insulin secretion. So there are two incretin hormones, the GIP and the GLP. And so GIP is the glucose dependent insulinotropic polypeptide, and GLP-1 is glucagon-like peptide. And both these hormones have actions at various aspects. So on pancreas, it increases the insulin secretion, decreases glucagon, reduces the beta cell apoptosis, increases the beta cell proliferation. At brain level, it also reduces the food intake and increases the memory. GLP-1 also has a cardioprotection effect, increases the cardiac output. It reduces the gastric emptying time. So these are the various roles of GLP-1, and that hence gives us one more aspect of treating diabetes. Now, if we consider the normal glucose homeostasis, what happens is in response to meals, incretin hormones, that is GIP and GLP-1, are released from the small intestine, and then it affects on pancreas. What happens? It responds to the high level of incretins. Beta cell secretes insulin and therefore increases the peripheral glucose uptake. Similarly, alpha cell causes reduction in glucagon secretion, and there is suppression of hepatic glucose production, and thus the glucose homeostasis is maintained. But what happens in patients with diabetes? And the other important aspect is the incretins are degraded rapidly by DPP4 enzymes. Now, what happens in diabetes? There is a diminished incretin effect. So, incretins are released, but the incretin mediated effects are diminished. And what happens is there is decreased insulin secretion and there is increase in glucagon secretion. Therefore, there is increased hepatic glucose production, impaired glucose uptake in the periphery, and this leads to hyperglycemia. So it is again giving us a way of managing diabetes by using incretin mimetics. So we can use DPP4 inhibitors as well as GLP-1 receptor agonists, and that is how this acts, increases the incretin levels and helps us in managing the glucose homeostasis. The other important aspect is the gut microbiota. So the human gut hosts 100 trillion microorganisms. So there are thousands of species. It weighs around 1.5 kg. So that so many microorganisms are there. The weight is 1.5 kg. And it changes from infancy to childhood. There are three major groups, the Firmicutes, the Bacteroidetes, and the Actinobacteria. Now, this intestinal flora is becoming a hotspot in the field of diabetes in recent years. There are various papers published into it because it is giving us a new insight into role of microbiome in obesity as well as diabetes. Again, it also helps us to understand whether there is any benefit from the personalized nutrition by predicting the glycemic response of certain food and probiotics, etc. Now, we humans harbor 100 trillion bacteria in the gut alone, and this is 10 times the number of human cells that we have. So humans possess 23,000 genes, and the microbiome genome is almost 150 times larger than human genomes. So this is one more layer of complexity, that is metagenomics. Your diabetes fate is not only decided by your own genes, but also by the genes of the microbes that are present in your gut. So this is very important, and this microbiota changes according to the genetic background, the age, sex, the diet that the patient is taking, the non-digestible carbohydrates, fat, pre and probiotics, and the treatment. But so if some patients are on antibiotics, etc., it changes the gut microbiota. So now they have said that the health may not directly be related to how rich you are. We all know the finance is not that important to your health, but it is going to be related to how rich you are in your gut microbiota. So if you have a large number of symbiotic gut microbiota, it definitely helps you in preventing diseases like diabetes. So approximately 80 to 90% of gut microbiota belongs to firmicutes and bacteroidetes. The firmicutes dominate the gut microbiota composition of healthy individuals, and bacteroidetes favor inflammation. The actinobacteria contribute to the producing butyrate along with Faecalibacterium, Eubacterium, and it contributes to healthy gut microbiota. So maintaining the diversity in gut microbiota is also important to keep healthy. So as the GI represents the widest and the most dynamic interface between our immune system and microorganisms, both pathogenic and symbiotic. And they live in sophisticated equilibrium with the host, from which they get energy through the substrates provided by the food. So the diet, lifestyle, as well as drug and toxic exposure, collectively called as exposome, lead to inter-individual differences in responses to similar pathogenic stimuli, diet, medications, or disease. So we know that each patient may respond differently because of the difference in their microbiota. The main functions of gut microbiota include controlling of inflammation and immune responses, intestinal barrier integrity, vitamin and protein production, drug metabolism, and bile acid metabolisms. So this, if you see the gut microbial ecology, there are symbionts, which is promoting health, and pathobionts, which are causing pathology. So the pathobionts are the pro-inflammatory species and symbionts are anti-inflammatory species. I don't think we should discuss the names because it is going to be tongue twisters. So the ecology is maintained, but the dysbiosis happens if there is increase in the pathobionts or decrease in the symbionts. And it can happen if there is high fat, high sugar diet, stress, and antibiotics. Even the bacterial gene count, if it goes down, all this will cause us dysbiosis. And what happens because of dysbiosis is that there is increased gut permeability, endotoxemia, pro-inflammatory cytokines is increase in insulin resistance, adiposity, increase in obesity, and increase in the metabolic syndrome. So all this leads to development of metabolic diseases like type 2 diabetes, cardiovascular disease, as well as inflammatory bowel disease. So gut microbes, how do they help is they ferment the dietary fibers into the short chain fatty acids, which induce an array of G protein coupled with receptor mediated signaling pathways that are essentially implicated in host energy homeostasis in multiple tissues. So it can help, it acts on intestinal tract, increases the insulin sensitivity. It acts on adipose and tissue and decreases the adiposity, increases the leptin secretion. It helps, acts on pancreas and increases the insulin secretion. So overall, it acts on various organs. Again, the dysbiotic alteration in the gut microbiota leads to elevated circulating and tissue microbe associated molecular patterns such as LPS, that is lipopolysaccharides and peptidoglycans, and this increases the inflammation as well as insulin resistance. So the dysbiosis of human microbiota is responsible for various diseases. If it acts on heart, it causes atherosclerosis, thrombosis, heart failure. It acts on metabolic pathway and it affects the metabolism like obesity, causes obesity, type 2 diabetes, cancer, and again there are gut-brain axis involvement, gut-lung axis involvement. So all this predisposes to various diseases. But we are here discussing about diabetes, and the immune and metabolic disorders play important role in pathogenesis of diabetes. Studies have shown that microbiota dysbiosis is presented in both type 1 as well as type 2 diabetes patients. Basically, it may cause gut leakiness, and it also leads to external antigens uncontrollably entering the circulatory system. And these antigens could activate the islet autoimmunity and directly damage pancreatic beta cells, and gut microbiota metabolites may also cause hormonal effects leading to metabolic disorders. So this is the role of gut dysbiosis in development of type 1 diabetes. There is reduction in short chain fatty acid. There is again there is enhanced antigen presentation, and all this leads to increase in the activation of pro-inflammatory pathways, impairment of beta cell function, as well as spreading of effector cells and pro-inflammatory signals, and these finally leads to development of type 1 diabetes. Again, in type 2 diabetes also, there is an environmental factor along with the gut microbiota dysbiosis being one of it, and it decreases the butyrate production, increases the permeability, change in the bile acid metabolism, and this further leads to impairment of beta cell function, low-grade inflammation, and increase in insulin resistance, finally leading to development of type 2 diabetes. Along with the diabetes, there is also an increased risk of obesity and other metabolic diseases because it can contribute to increasing insulin resistance, low-grade inflammation, and fat deposition through range of molecular interaction. Again, these pathways are also linked to various metabolic and cardiovascular diseases. So as you can see in this, the gut microbiota interact through many pathways like TMA, TMAO, uremic toxins, bile acids, short chain fatty acids, as well as LPS, and thus affects causes atherosclerosis and causes severe cardiometabolic diseases. So how can we help these patients? There is an important role of probiotic as well as prebiotic. What are probiotics? They are live microorganisms which, when administered in adequate amount, or confer a health benefit on the host. So it is found in foods like yogurt and dairy products. Prebiotics are non-digestible substances that provide beneficial physiological effect for the host by selectively stimulating the favorable growth or activity of a limited number of indigenous bacteria, indigenous microbiotas, and it is found in whole grains, bananas, onion, garlic, honey, etc. So gut microbiota modulation can happen with probiotics. The probiotic strains like Lactobacillus acidophilus, Fermentum casei, as well as bifidum will help in formation of short chain fatty acid, which help in mucosal barrier, and therefore it causes reduction of inflammation. It helps in increasing the intestinal flora and helps in controlling blood glucose levels and reducing the HbA1c. Again, the exercise also impacts the gut microbiome. It stimulates the production of GLP-1, improves the microbiome diversity, and thus it increases in the production of bacteria that metabolize the lactate to short-chain fatty acids. We discussed this. Dietary fiber also has promotes the richness and diversity of bacteria, and therefore has a protective effect on glucose and lipid metabolism. So these are various anti-diabetic intervention targeting the gut microbiota. We all are aware of metabolic surgeries or bariatric surgeries, fecal microsomal microbiota transfer, diet, exercise, probiotic and prebiotics. So all this can help to reshape the gut microbiota and therefore treat the type 2 diabetes patient. If we consider role of gut as cure for diabetes, we have various molecules which are we are using now, and we have some which we can explore in future. So this could be the incretin therapy, the alpha glucosidase. So incretin therapy, we discussed in detail the role of incretins. Alpha glucosidase inhibitors, it prevents the rapid absorption of carbohydrates. The SGLT2 inhibitors, the metabolic surgery, the pro-prebiotic, and the fecal transplantation. These are the modes we can explore in treating type 2 diabetes patients. So to summarize, the gut's role in developing diabetes is multifaceted, involving interaction between gut microbiota, hormone secretion, inflammation, and nutrient metabolism. Understanding these mechanisms offer potential therapeutic avenues such as targeting gut health to prevent or managing diabetes through probiotic, prebiotic, dietary interventions, and medicines that influence gut hormones like GLP-1 agonist. We also have dual agonists like GIP, GLP-1 agonist, and these, along with controlling glycemia, helps us in reducing weight and managing obesity also. So this is a newer aspect which we are already exploring. Thank you.
Okay, thank you so much for an excellent presentation. I think the modern medicine has come of age, and we've always been stressing the importance of maintaining a gut health in our ancient scriptures. I mean to say, all the Hindu scriptures, ancient scriptures, they've always mentioned that maintaining the gut health is a priority for preventing any diseases. Now the modern medicine is recognizing this fact. So thank you so much, Alka, for giving an exhaustive information in a short span of time. Do we can take questions later on. We have a discussion session at the end of this lecture, so we can take questions later on.
Thank you very much, Alka. I now invite Dr. N.K. Singh to present his talk on enhancing longevity in diabetes. What are thoughts right from the beginning?
Good evening. Huge appreciation to Dr. Manoj and Purvi Chawla for this very unique conference. These days we have become some people like me. They are CME Banjaras. Every Saturday, Sunday we are out. So we are seeing what is the quality of conferences and other things. And I find this is one of the very innovative conferences Manoj has arranged. He has given me a topic. Enhancing the longevity in diabetes, a thought from the very beginning. I think it is very difficult to convince you that we can increase our age or our longevity, but let us see what science is telling us. And today we will talk something about the crosstalk, the oxidative stress, the mitochondrial induced endothelial cell dysfunction, and what interventions that Alka nicely told how you can improve your gut health and respecting the circadian rhythms and other things. Diabetes self-medical education and support says, this saying is very appropriate, that you can stay young as long as you learn. So you are in the process of learning today also. And this lady, Lucille Bell, tells The secret of staying young is to live honestly, eat slowly, very important, again, leading to the improvement or modification of the gut microbiome, and lie about your age, that I don't know. But my idea is to die young as late as possible. Uh, this was a gentleman, Phil Sutherland, I met in the 2014. He was told, being a type 1 diabetic, that he will not cross the age of 20. Today he is 53-year-old, and he has given some of the recommendations by establishing the team Novo Nordisk type 1, crossed so many 3,000 to 4,000 cycling, and many of the things which we know, we do or we tell to our type 1 diabetic patients about exercise comes from this gentleman. From 8 factors now today, we are talking about the 11 things. I'm not going detail, but remember, in diabetes, you will agree that beta cell is the final common denominator of the beta cell damage. Maybe, and most important, your insulin resistance comes from the liver, muscle, adipose. But today, definitely, everyone, you will agree that even the kidney, the brain, the colon, everything is implicated in the diabetes. And I'm not go about that. It's very important, very fundamental, that in your old diabetic patients, remember, even in the newly diagnosed type 2 diabetic patients, lots of cardiac risk factors have been found. The studies from the Indian studies are saying. So you must target the main risk factor, maybe that is you are well aware about the dyslipidemia, hypertension, smoking habits, and other things. And again, it is a fundamental that you maintain the HbA1c. Again, the things are changing from the cardiocentric to glucocentric. But remember, the fundamental thing is that the glucocentric concept is not bad. It is the fundamental thing. And also remember that females in general live 4 years longer than males, the study is saying. While racial ethnic differences and this recommended goal of biomarkers prolongs from the in females the life expectancy by 1.3 to 1.8 years when you compare with the current population average. With that, let us understand the science. Now everything in diabetes is revolving around two things. One is Dr. Alka told about the gut microbiome, and second thing is the mitochondrial induced endothelial cell dysfunction and diabetes progression. And mitochondria is a crosstalk. Everything is completing with the metabolic inflexibility, oxidative stress, inflammation, leading to insulin resistance. So can you modify your mitochondrial function? This is the most important. From this red signal to this green signal, this can be done. So the message number one is that you can modify your mitochondria, because now today we are well aware that there is a relationship between the mitochondrial dysfunction and the type 2 diabetes. And even the organ-specific pathway, they can distinguish the pre-diabetes, type 2 diabetes, and normal tissues. The new research is saying. So even in the pre-diabetic, that is a PD stage, you can modify your pancreatic islands, liver function, visceral adipose tissue, skeletal muscles, serums, and so many things. And nothing more you need to understand this science, that this is the metabolic undersupply and metabolic oversupply is the fundamental to prolong your age or your longevity. But I think, again, this is a saying which hardly we follow. At least in conferences, we are overeating, taking lots of fast food, we are letting lots of ice cream, sweets, and whatnot. So, but anyway, just for the sake of science, I am not going to tell you, because if you know the psyche of the patient, क्योंकि लोग बोलते हैं कि क्या करना है, जितना जब तक जियो खुश होके जियो पूरा जियो और कर्जा लेकर घी पियो. This is also concept by Charvak Rishi. It is well known in India, and today most of our we people follow this. But remember, again, the fundamental in science is the metabolic oversupply or metabolic undersupply. And you see from a normal mitochondria, it goes to fragmented morphology just by oversupply. If there is oversupply of nutrition, there is fragmented morphology, you can see in the upper part. And when there is undersupply, there is fusion. So in very simple way, this paper is showing you what is happening inside your body. So chronic episodes of metabolic oversupply may fragment the mitochondrial network. As a result, compromise this mitochondrial DNA function and predisposing to age-related diseases and premature functional decline. If you understand this, I think my function is over. So let us see how we can proceed with that. So in mitochondrial function in order to prevent or treat diabetes and keep them young is the fundamental thing, number 1 point. The second part of my talk is the journey of this science toward restoring the normality to mitochondrial endothelial function, how you are going to the therapeutic behaviors to do that. Number 1 is the physical activity and make your mitochondria green. A very recent paper has shown a sedentary person mitochondria looks like that. You can see here in the upper part. And if there is exercise trend, it becomes totally green. Green means all biochemicals are in very good direction. So the gradient difference in mitochondrial color and green, yellow to red represents healthy, stressed, and damaged or dysfunctional mitochondria. So very simple thing to tell you that it is very important that you stress your patients on every visit that physical activity is fundamental to keep yourself young, to prevent complications, and to improve your longevity. And in the ADA 2024, this also came in the Diabetologia, shorter sitting time and more time spent in the standing undergoing physical activity and sleeping are associated with preferable cardiometabolic health. कभी कभी ट्रेन में बस में मैं बोलता हूं कि तुमको अगर सीट न मिले बर्थ न मिले और तुमको खड़ा रहना पड़े किसी आदमी को तो थिंक दैट यू आर लकी कि आपका उस समय मेटाबॉलिक हेल्थ इंप्रूव कर रहा है. आई थिंक दिस इज ए वेरी वेरी इंपॉर्टेंट मैसेज कमिंग फ्रॉम दिस पेपर. नाउ इफ यू टुडे एक्सरसाइज, आपके 2 जनरेशन बाद वाले को भी फायदा होने जा रहा है. इन एडीए 1 पेपर इज शोइंग if your grandmother exercised during pregnancy, you are protected today. It's very amazing thing. Epigenetics. So this is all the papers are coming. I'm not going details, lot of things to tell you. So exercise for the prevention and management of in the breast cancer survivors also, it was shown that those breast cancer people, ladies who did exercise lived longer. So exercise has positive effects also on the sex drives of the men and women, and cardiovascular patients showed that exercise training improvement in symptoms of erectile dysfunction and endothelial dysfunction. So this is well known. And today it is said, a paper, a beautiful paper is there, that exercise is more than Viagra. Remember. And we are not telling, not a single, I have checked the sexologists are telling about doing the exercise. वो बोले तीसी खा लो, वो खा लो, ये लगा लो, वो लगा लो, but they are not taking a proper time to educate about the exercise. And yoga must be included, remember. And in yoga, the Surya Namaskar is emerging in science. Lots of papers will be coming 2 or 3 years from the USA, where they are doing an intense research on the Surya Namaskara, and it has shown so many things, so many things. Impact, positive impact on the autonomic function of the body, It regular practice of significantly decreases the oxidative stress of the body, which plays a key role in the insulin resistance. Even if you see that you should have a very important, living a long and healthy life requires the maintaining an optimal level of the AMPK. You know, this is a longevity enzyme, and this can improve, you can improve it by breathing exercise pranayam, including the kumbhaka. And the paper is there from the Frontiers in Psychiatry saying that this 4 weeks of pranayama on the reduce the anxiety and increase the positive effects. And these changes are associated with activity and connectivity of a brain network involved in emotional processes, leading to again an improvement in the metabolic health, mitochondrial health, and longevity. This has been being shown now. So diabetes, only thing to tell you that exercise is very, very important. Then I think all the things that our chairperson was quoting, that in our Vedic science, it was since 5,000 years ago or 10,000 years ago. But today, only in the last few decades, last decade, I think just I'm getting more and more papers, last 5 to 10 years, where the intermittent fasting is coming, gut microbiome is occurring, more stress on exercise is coming up. Initially, only drugs, when we were students, only few drugs were there, and these things were under the background. So calorie density, just see, if you are taking a 400 calories of oil here, beef here, and vegetables here, this gives you the stretch receptors are located throughout the stomach. When they are triggered by food, they send signals to your brain to tell you to stop eating. With high fiber, whole plant foods, you can eat the most quantity of the least amount of calories. And this gives you very beneficial effect like intermittent fasting. So when there will be intermittent fasting, एक कहावत है आयुर्वेद में कि बीमारी को भूखा मारो. जब फूड नहीं रहेगा तो बैक्टीरिया भी नहीं रहेगा. And then what happens now, we are showing that there is down regulation of the insulin like growth factor, signaling pathway, reduction in circulating amino acids, and inhibition of protein synthesis, and so more and more autophagy. तो शरीर का जितना खराब सेल है सब ऑटोफेजी से खत्म हो जाता है. तो अभी बोलते हैं कि अपने को ठीक रखना है तो रात का खाना बंद कर दो. And whenever my lipid profile goes bad, sometimes I had a 550 triglycerides. मैंने रात का खाना बंद किया, didn't take any medicine today, 2 hours का walking किया, now it is LDL, I am at 77. So this happens, but we are not telling to our patients. So during fasting, there are lots of signs. How this AMPK to ATP is increased, AMPK is activated, and all these things are happening. So intermittent fasting is very fundamental to improve the longevity even, and there are lots of science and papers are coming up about the autophagy in this way. And this was an old paper, 1997, when they told that reducing the food availability over a lifetime, that is caloric restriction, has remarkable effect on aging and the lifespan in animals. And this also happens in us. So time-restricted feeding and circadian autophagy for the long life is very important concept. Today we are proving it, but it is existing for long and long in India, in Bharat. And today, what is our food? You can see here. 20 years ago, what it was, and now what is that today? We have totally, the food pattern has changed. घर में मैं भले रात में खाना खाऊं, लेकिन मेरा बच्चे को कितना भी बताइए, वो रात में जोमेटो को फोन करता ही करता है. I cannot change that. 9 बजे रात में के पहले खाना बनता ही नहीं है, तो 6 बजे क्या खाएंगे हम? 6 बजे अगर मैं सोचूं कि ठीक है मैं 6 बजे के पहले खा के बंद कर दें, लेकिन खाना तो 9 बजे के पहले मिलता ही नहीं है कभी, अगर खाना हो तो. So fat quantity and quality is important. This is for again a very important slide always show from Dr. Lele. उन्होंने बोला था लगाओ देसी घी, that Dara Singh took 250 grams of cow's ghee per day and lived for 84 years. So very mysterious things are in the nutrition, and we are lacking that. The point is that omega fatty 3 acids should be taken, and remember that every single junk food meal damages your arteries, your beta cells. And today the use of refining oil is so important everywhere. उसी तेल को गर्म करते हैं, नेक्स्ट डे खिलाते हैं, very dangerous. So you tell about patients about the diabetic superfoods, soybean, tea, coffee, grapes, berries, whole grain, cinnamon, bitter melon, fenugreek. Very important, take every day. Even like junk food भी आप खाते हो और ये सब चीज लेते हो तो काउंटर बैलेंस करेगा. So this, I'm all talking about from the science. And then nuts is very, very important. They improve the insulin sensitivity and prevent diabetes. And remember, the nuts are as effective as increasing the physical activity and trimming calories to increase the HDL level. And nuts का बहुत फायदा है. Not going detail again. Dr. Alka told about the microbiota. This is again very important way how you can improve your gut microbiota and endocrine disruptors. In today's there is mysteries unfolding कि young age लोगों में क्यों ज़्यादा epidemics हो रही है diabetes की. The major reason is this endocrine disruptors which is you got every day eating in the all your food items. So it is a very difficult thing how to will control that. Although I wrote a chapter in this textbook of RSSDI, diabetes, pollution and diabetes, and we gave some suggestions how you can do that. And lastly, increase your telomerase length. That is a great secret. Again, the same things are there, how you can increase your telomerase. When you just exercise, there is factor known as nuclear respiratory factors that improves your everything. And from shortening of the telomerase becomes lengthening happens. And lastly, I will tell you, respect your circadian rhythm. Very, very important. Melatonin mediated everything is happening here. So, सूरज के साथ चलिए, सूरज के साथ चलिए. And this also improves your gut microbiome because they also do the diurnal fluctuation according to the sun circadian. So chrononutrition is coming up in the main way. How the meal timing and dietary components. So our concept or the components, this concept which the Jainism follows, 6 बजे के बाद कुछ मत खाइए. There is a great science in it. The chrononutrition, modifying the macronutrients composition, and you become an age management diabetologist by doing all the things. So I think these are few things. I will not go about the pharmacological things, the alpha-lipoic acids, and even today, how to include AMP by the drugs like metformin. And again, कुछ लोग बोलते हैं कि SGLT2 inhibitors इतना important है कि इसको पानी में आजकल मिला दीजिए. Just add in the पानी में, so that this becomes an elixir for staying young, at least in diabetes. So lots of things are coming up for that. You can even 15 साल if you are giving someone SGLT2 inhibitors, it will improve your life. Canvas study, some data showing up to 15 years. So I will final takeaways. Diabetes is an important cause of premature death and disability. The crosstalk, oxidative stress and inflammation in the progression of type 2 complications, we know the ways to halt it. The mitochondrial-induced endothelial cell dysfunction in diabetes progression can be tackled. And how we can do, I told you, altering the telomerase, know it, and respect your circadian rhythm and some drugs. But lastly, the last point, everything you do, unless and until you do your mind management, nothing is going to work. So mind management is the super key to stay young, क्योंकि जो अनंत है कभी नहीं मिटता वही तुम हो. Think about that. Thank you very much.
Thank you, Dr. Singh. It was a wonderful presentation, a great overview. So the simple thing is, eat to live, not live to eat.
Thank you, sir. Greatly, sir. So you summarized, sir.
We'll have the questions
Thank you.
afterwards.
We have one more lecture, I think so. That is a video presentation by Dr. Neeta Deshpande, who is a diabetologist practicing at Belgaum. So she'll be talking on remission for all.
A very good evening to all of you. At the outset, I would like to thank Dr. Purvi and Dr. Manoj Chawla and the entire team of DRS and WCPD for giving this opportunity. I would like to apologize for not being there in person due to unavoidable circumstances. So the topic that I'm going to talk to you about today is about remission of diabetes, but not how it is done and what is done, But what are the predictors and pointers towards achieving remission? It's a subject very close to my heart because we have been doing remission of diabetes in our center for the last 10 years, and hence it is something that I am closely associated with. So let me start by sharing my screen. Yes. So as I said, I'm going to be dealing with the remission predictors and pointers. So I do not have any disclosures for this particular talk. So the overview would be predictors and pointers. Of remission based on method of remission. When we talk about remission, we are always, as days went by, they came out with even more and more data to tell us what the predictors and pointers could be. Now, these were the program related predictors of remission. That is nothing to do with anything else but the program per se. And you can see here that based on the BMI, what you can see is the people getting remission. So, weight loss was the strongest predictor of remission at 12 and 24 months, irrespective of baseline BMI, with absolute weight loss in kgs as well as percentage weight loss. Both of these were equally good predictors. Also, the numbers of remissions increased in a stepwise manner with weight loss. More the weight loss, more the likelihood of getting remission. And you will see that this is borne out in all the other methods also, that it is the weight loss that is the one that predicts remission. And then weight loss is achieved as early as 4 weeks were significant predictors of remission at 12 and 24 months. It means that the early weight loss that you get, that is predictive of remission. So if a person is losing weight very slowly, it means again, as against that, if a person loses a lot of weight in the first 4 weeks, there's more likelihood of remission. Higher program attendance obviously was also associated with achieving remission. What is new data that has come out from the same group about pointers and predictors towards remission? So here you can see that with more than 10 kg weight loss, 64% of early type 2 diabetes is reversible, which means that if you intervene early, so this is a pointer for you for counseling your patients. So if you intervene early, 64% with more than 10 kg weight loss can remit, but few data are available on factors predicting diabetes remission following diet-induced weight loss. So, second. Other than weight loss, so this is all new data that is coming out from everywhere. Other than weight loss, most predictors were modest overall, and reassuringly, none was sufficient to identify people for whom remission is not a worthwhile target, which I already told you. So it was weight loss that was the one predictor that was going to tell you, yes, this person is going to go into remission. Again, what they found was remission was more likely for men. Now, that again is related to weight loss. And how is that? Because larger weight losses are expected in men because of their higher metabolic rate, perhaps. And for those prescribed fewer anti-diabetes medications at baseline. So that means they are early in the disease. So again, that is a predictor. So remission was less likely for people with anxiety or depression, mainly due to smaller weight losses. This is probably due to high stress levels, high cortisol levels that precludes weight loss. So the weight losses are small in spite of a very low calorie diet because of the depression and anxiety. So these are factors that you should look out for when you are counseling for remission in your patients. Because if somebody is really stressed out, really depressed, you should know early on what to expect. Remission is a realistic aspiration for most people with type 2 diabetes diagnosed within 6 years. This was also the inclusion criteria for the direct. And achieving more than 10 kg weight loss should be a primary target of routine diabetes care at diagnosis. And I'm going to show you some data that they have done in primary care and before the escalation of therapy. So before you actually start to increase dosages of drugs just because glycemic control is not being achieved, maybe you should target weight loss of more than 10 kgs as much as possible before you escalate therapy. So these patients can get maybe better control or maybe even remit. So that is what is new. So this is again long-term remission of type 2 diabetes after very low calorie restriction and related predictors. So this is a study that came out in 2022 and there were 44 participants. They were successfully followed up after their remission, including 19 males and 25 females. And long-term remission was seen in 17 participants. That is 38% of those 44 participants after a very low calorie diet. And that was a median of 7.83 years. So compared with responders, so these are predictors now. Responders had a shorter disease duration that is coming out in all the studies. The earlier you intervene, more remission. A lower fasting blood glucose, a higher fasting insulin level, and better HOMA-B, that is pancreatic secretion ability, should be more after, and this is after a very low calorie diet. So these were the predictors in this particular study, and you can see that though the number of participants are less, you can see that they have followed them up for a long time. Acute insulin, because they did OGTTs. So acute insulin response, insulin area under curve in intravenous and OGTT in responders were higher than those in non-responders after a very low calorie restricted diet. So these are some good pointers for you to understand who are those people in whom you can really attempt remission and be successful. Multivariable logistic analysis of this study showed that higher post VLC of IVGTT and area under the curve predicted a longer type 2 diabetes remission. So this is another study which tells you about these predictors and pointers. Now this is what predicts drug-free type 2 diabetes remission. Now these are insights from a 8-year general practice. This is in the UK and Dr. Roy Taylor was also involved in this. This is an 8-year general practice service evaluation of a low carb diet. Now here the modality is different. It is not low calorie diet, it is low carb diet with weight loss. So this is what they have seen. So this is like an observational study. So what they did was all the patients coming in, they gave them advice on a lower carbohydrate diet and weight loss routinely between 2013 and 2021. in a suburban practice with 9,800 patients. A conventional one-to-one GP consultation was used. So it's your typical doctor-patient interaction in which you tell them about a low-carb diet and weight loss. And this was supplemented, of course, by group consultations. And as necessary, they also did personal phone calls. So the result was 39% of them chose the low carb approach. It was offered to everyone, all the 9,800 patients, but it was 186 people who opted for this. After average of 33 months median, the weight fell from 97 to 86. That means it gave a mean around an average weight loss of 10 kgs. So this was what was attempted. So low carb diet, 10 kg weight loss. The median A1C fell. Now, of course, these are in millimoles from 63 to 46. And importantly, remission of diabetes was achieved in 77% with type 2 duration less than 1 year. That means you intervene early, give them a low carb diet, you can actually achieve remission in 77% of them. So this is not a VLCD, it's a low carb diet. And this fell to 20%. That means it was 77% in early type 2 diabetes. But as it goes to more than 15 years, that rate falls down to 20%. I suspect that in India, that 20% may be higher because of our high carb diets inherently. So if we were to have low carb diets, even if the diabetes duration was greater than 15 years, then yes, perhaps we can get remission much more than 20% that is shown over here. Overall, remission was achieved in 51% of the cohort. Now, this is an important study that I am pointing out because this is in a general practice. This is a low carb diet, not a VLCD, and it is offered to patients as soon as they come to you at the first time. Again, the mean LDL cholesterol and mean systolic blood pressure also decreased, obviously, because the weight also reduced. And the conclusions of this particular study was that a practical primary care based method to achieve remission of type 2 diabetes is described in the study. A low carb diet based approach was able to achieve major weight loss with substantial health and financial benefit, and it resulted in 20% of the entire practice type 2 diabetes population achieving remission. It appears that type 2 duration less than 1 year represents that window of opportunity. It's really very important to catch them young in their journey of diabetes for achieving drug-free remission of diabetes. The approach can also give hope to those with poorly controlled type 2 diabetes. That's what I've always been saying, that even if you don't get remission by that particular definition, you are definitely reducing the number of tablets, the number of medication, and improving the quality of life. And that's what this study concluded, that it gives hope to those with poorly controlled type 2 diabetes who may not achieve remission as per definition, but they had the greatest improvements in diabetes control, at least as represented by the HbA1c. So this is very important to note. Now, I have just one study to tell you about early. There are many studies that talk about early use of insulin for remission of diabetes. I'm just going to show you one of them, and that is, if you can see it here, predictors of sustained drug-free diabetes remission over 48 weeks. So it's a short study following short-term intensive insulin therapy in early type 2 diabetes. So yes. So the objective in this study was, in early type 2 diabetes, short-term intensive insulin therapy for just 2 to 4 weeks can decrease. This is the fundamental behind it. You can decrease insulin resistance, reduce glucogonemia, improve beta cell function, and even induce a remission of diabetes that can last up to 1 year in some patients. However, little is known about the predictors of such a sustained remission. So patients with early type 2 diabetes less than 7 years, 4 weeks of insulin followed by placebo therapy for 48 weeks. And OGTT was done every 12 weeks. So they could serially assess insulin sensitivity, alpha cell response, and beta cell response. Diabetes remission was defined as an A1C less than 6.5 without medication. So what did they find? They found that 56% of the participants remained in remission post the insulin therapy at 48 weeks. So now they made a comparison between those who had remission and those who did not have remission. What they found was that there was no difference in waist, body mass index, insulin sensitivity, or glucagon profile either at baseline or over 48 weeks. There was no difference. Remission group had a lower baseline A1C and better baseline beta cell function that was then sustained across 48 weeks. So the key here was better baseline beta cell function. On logistic regression analysis, however, shorter duration of diabetes supplanted baseline A1C. So when they did the regression analysis, they found here again that it is duration of diabetes that matters. So particularly diabetes duration less than 2 years predicted persistence of remission. There are many more studies, the origin study, etc., which I have not touched upon due to lack of time. So I just gave you a prototype. So the conclusion of this study was that the key determinant of the likelihood of inducing sustained drug-free diabetes remission with short-term intensive insulin therapy is early intervention, particularly within the first 2 years of diagnosis. So this study showed that it is duration, not the weight, not the waist, but duration of diabetes, because it talks about the beta cell reserve. Lastly, bariatric surgery. Actually, it should have come first because we learned about remission of diabetes mainly from bariatric surgery. But since bariatric surgery is not available to all, it somehow gets a place, quite low in the hierarchy. So this is a study where they have shown predictors of type 2 diabetes remission after metabolic surgery in Asian patients with a BMI less than 32.5. So they had 112 patients with type 2 diabetes undergoing metabolic surgery. And the basic data was collected, clinical variables were measured, and then the statistical analysis was done. And what they found was they had created a score called the ABID score, where they looked at the age, BMI, insulin use, and duration. So this is the ABID score: age, BMI, insulin use, and duration. And this is age less than 38, more than 38, BMI more than 29, less than 29, insulin use, yes or no, and duration in years less than 6.5 and more than 6.5. So patients with greater ABID scores had a greater probability of diabetes remission. It was as simple as that. So the greater your score, according to this particular score, greater was the chance of remission. So diabetes remission occurred in 38 of the 112 patients. 90 patients underwent Roux-en-Y while the remaining underwent sleeve gastrectomy. They looked at weight, glucose, and lipid metabolism parameters, which were improved significantly after metabolic surgery. So what did they conclude? They concluded that metabolic surgery significantly improved variables of anthropometry, so weight loss, glycemic metabolism, and lipid metabolism in the short term. The ABID score, they said, is a simple and easy to implement predictive scoring system of diabetes remission after metabolic surgery with a BMI less than 32.5. So these are also the things that you use even in the direct trial. So age is not so much, but they use BMI that was more than 27. The direct trial did not take insulin users, and they took patients with diabetes less than 6 years. So the same kind of scoring can actually be applied even over there. Sorry. So using this score system, the Asian patient who has the best chance of diabetes remission should be under 38 years with a BMI more than 29, not an insulin user, and should have a diabetes duration of less than 6.5 years. So this is actually very, very similar to what you would see even in a VLCD program. These are the predictors and pointers even over there. Then there was another study, again, where predictors of complete, this is again after bariatric surgery, predictors of complete remission in patients more than 65 years of age, and this was a multi-center study. So they looked at patients more than 65 years, type 2 diabetes, undergoing bariatric procedures. Responders were one who achieved complete remission and non-responders who did not achieve complete remission. And they had 146 patients in whom 51 were responders and 95 were non-responders. So what they concluded here was that complete remission of type 2 diabetes occurred in 1/3 of patients over 65 years. This was study only for patients over 65 years in a long-term follow-up. And the predictors again here were shorter duration of diabetes before surgery and higher weight loss after surgery. So again, it is duration and weight loss. Which one is more? Probably weight loss. So this is how I have taken you through the journey of looking at pointers and predictors of remission, type 2 diabetes remission, after very low calorie diet, low carbohydrate diet, insulin in the first 4 weeks, and after bariatric surgery. So, to summarize, diabetes remission can be achieved by multiple means. We all know that. General pointers and predictors are as follows: younger age, early intervention, most important, a higher BMI at baseline, males, and less number of oral anti-diabetic agents, and also for non-insulin users. But at the end of it all, if you look at all the studies, this is the bottom line. The quantum of weight loss is the most predictive of remission. So thank you all very much for a patient hearing. And again, apologies for not being there in person. Thank you.
So if there are any questions to any of the speakers, Dr. Desai, Dr. Gandhi, and Dr. Singh, you're welcome. Yeah.
I think the gut microbiome research which we showed, there are lots of challenges. The type of pattern of the gut microbiota differs in the Indian setting. It differs in the if you take a sample from the Denmark. So it has become very difficult to define whether there is a clear-cut association with the diabetes or not. So your take up on this point. At many these days there is some these laboratory, some lab companies, they are selling decode or biome like test of 10,000, where they take the sample of the feces and they give you that this is your profile of the gut microbiota. They have got a scoring system. Oh, I think this is not validated. So whether you are also advocating to your patients or not.
No, definitely no, sir. So I don't think it is validated, but it is a thought process which has started, and I think eventually
Hello.
we will get more evidence and easier way to identify and deal with it. Gut microbiota, yes, will vary as I discussed earlier, depending on the so even while the child is being delivered, whether it is a vaginal delivery or a C-section, then initial weight of the child, use of antibiotics in infancy. So everything affects the gut microbiota throughout the lifespan. So that is how it is going to vary, and I don't think we can change it, but we have to observe those changes and then identify how it is affecting us.
Hello. One more question is that this is the era of fecal transplantation. I don't think you showed any slide on that. FMT.
Sir, I had just mentioned a bit
Oh, you
because
just
my
mentioned
topic
it.
was, sir, origin of diabetes and not the
Because
management.
lots of work is being done at the AIG
Yes,
Hyderabad.
yes.
I'm aware about that.
Yes.
And this has become also to change the whole pattern of gut by the
It
fecal
can be-
transplantation.
Yeah, it can be the isofecal transplant means of the patient himself or a cross person also. So that is what they were saying. Maybe a lean person's poop will be more costlier later on in life as we go and as we see how it progresses, because leaner people will have a beneficial gut microbiota, and therefore their fecal material will be more beneficial if it is transplanted to others who have metabolic diseases, I guess.
Yeah, I think yes, sir.
Sir, madam, actually, my question was related to the same. As far as intestinal microbiota is concerned, we understand the importance of the microbiota, but in your practice, how do you actually implement it? Means, should I tell all my patients to have curd every day? Should I tell them to have Econom or sachets which are available of probiotics and pre-diabetic?
Yes, they are advocating that also, but I would say, as sir, showed in his slide, that eventually we have to change our lifestyle, early dinner, getting up early, avoiding late nights, and changing the dietary pattern, increasing the fibers, and having natural food sources which are probiotics, will definitely be more useful, I guess.
Hello. I think your question is very valid. There is so much of
very
science.
well, yes.
Yes, there's so much of science. But what is the utility of this science if you are not going to do something
Implement it.
into our patient? So I think that Alka showed lastly the prebiotics and postbiotics, but there is not a single recommendation all over the world, any guidelines saying that you should routinely prescribe that.
Sir,
So that point is quite
let me
clear.
interrupt you at this. One more important thing is, suppose I'm a diabetic of 5 years, and today I say that, okay, she's telling me you improve your microbiota. How do I know I really have a very bad microbiota? I may not have any symptoms of intestinal.
That question I took, I told.
That is
I
what
mean,
he asked me. So
pathogenic
there are
symbiotic
look,
microbes.
there is a already tests are available in the market. Only thing there is
How reliable are they?
They are reliable, but they are not validated because this is just beginning of a process.
So this is conceptual.
Look, this science is just a beginning of the process. But what I say that common sense wisdom, that is most important.
Sir, I got your point. You have given very good points. I got each and every slide of yours, and I'm going to go and read it at home also. That's very valid, sir. Sir, now when you talk about taking long breaks between two meals or long fastings, or some people say 12 hours fasting, 14 hours fasting, it improves your metabolism. It allows your gut also to clear up and regain its normal functioning. Sir, in diabetic patients, how do we really implement it? People in diabetes, they are on so many
That's a
things.
very big problem. That is a very.
So how do you manage?
Yeah. So that we do by doing. There is also in diabetics. There is lots of papers which have done the research of the intermittent fasting and the time restricted feeding. There is a clear pattern and there is a guidelines also how to do that by monitoring or by reducing the time duration and modifying the drugs. So there are lots of things are coming up. So just wait. I think in.
So I will have to put my patient on CGMS and then tell them, "Chalo,
Yeah,
fasting
that
karo."
would be much better. Yeah.
I think we are.
Yeah. Okay, sir.
Because it's already 6 o'clock.
Thank you, sir.
Thank you very much for a very interesting presentation and discussion. Let's pass on to the next. Let's have a group photo.
Let's have one group photo. For our next interesting session, I would like to call Dr. Dhruvi Hasnani and Dr. Neeta Shah for chairing this session of pre-pregnancy counseling. Okay, we will start with the session. Let's talk before sex. For that, Rukia Surya and Pranjali Shah from Mumbai in conversation with Dr. Lotika Purohit.
Good evening and welcome to this session on preconception counseling. Can I have the slides? At the outset, I want to thank Manoj and Purvi and the rest of the team for inviting us to discuss about this very relevant topic. So with me, I have Dr. Pranjali as well as Dr. Rukaiya. वो नहीं उनका so you can can we have their introduction slides, Dr. Pranjali and Dr. Rukaiya? नहीं दिखा. No, 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 sit, sit. Actually, you can't see, okay. So, Dr. Pranjali is Director and Chief Diabetologist at APT Diabetes Clinic and Research Center in Mumbai. And Dr. Rukaiya is also a diabetologist practicing in Mulund area. And so today we will be talking on let's talk before sex. Okay. She is a diabetes and thyroid specialist with an experience of 15 years. And so welcome to this session.
Thank you, Lotika.
Yeah. So we all know that most of the time, by the time the patient comes to us, so a lot of times we know that people with diabetes, they come to us most of the time after they have conceived. And, then it's a big dilemma for us as clinicians, diabetologists, to figure out what to do next. So today let's discuss about, I'll just start the. So we'll just discuss on how we can, manage this before a woman gets pregnant. We have three case scenarios which we have got. Okay. And I'll just. What is the necessity for having preconceptional care? Like I said, a lot of times the women come to us with unplanned pregnancies. Most of them are pregnant before they, come to visit a gynecologist or a physician. A lot of times these women have various nutritional deficiencies. In our country, the most common, of course, is iron deficiency, folic acid deficiency, B12 deficiency, all these things are there. And a lot of times, no, the organogenesis that we know, most of it takes place in the first 8 weeks. So a lot of times before the first time, you can hear? Am I audible? No? Okay, so should I use this mic? Okay, I think that will be. Now is this audible? Yeah, better. Okay. So like I said, most of the times we have people who come to us with unplanned pregnancies. The organogenesis window is usually in the first 8 weeks. And most of the times the woman visits a doctor after that. Also, it's better to optimize the maternal nutrition before the pregnancy because we can reduce the cases of high-risk pregnancy as well as low birth weight babies because that's what we see all in our patients. So we'll start with this case scenario of Sia. She's a 28-year-old female. She has been a type 1 diabetic for the since the age of 9. She has recently got engaged and she has come to say that she wants to get married next month. She is currently on basal bolus therapy and she regularly monitors her blood sugar. She has continuous glucose monitoring all the time. Her time in range is also above 70% is time in range. Her HbA1c is about 7.2. Now, do you think that she is fit to conceive? Anjali, would you like to start?
Thanks, Lotika. So this girl, she's type 1.
Yeah.
And the duration of diabetes is since 9 years. So we should counsel her about the pre-pregnancy, preconceptional care.
Yeah.
The target HbA1c in preconception is less than 6.5. So definitely her HbA1c is on the higher
A little
side.
on the higher side.
And since she has a longer duration of diabetes, before conception, we should tell her to screen for the complications to avoid and prevent maternal as well as the fetal complications.
Yeah.
So definitely in this patient, we need to help her to understand the benefits of good glycemic control.
Yeah.
And we need to keep her HbA1c about 6% in this case.
Yes, that's right.
You want to
So
add
Kaya, would
something?
you like to
Yeah,
add
yeah.
something to
So
it?
I'm very happy that Sia has actually come to us asking that, am I fit to be pregnant?
Yes. So
Because
she's come at the
yes,
right
she's
time
come
to,
at the
you
right
know,
time before, most of the time the patient comes to you when they're already pregnant. So there are 6 weeks of pregnancy when the UPT will be positive, and when they come, the organogenesis is already over. So,
That's right.
which is great about her that she's come to us because her duration of diabetes is longer. She can be having microvascular complications
That's
because
right.
it's been a long time that she's diabetic, almost 11 years. So one needs to screen for microvascular complications. Her retina needs to be checked. Her urine albumin creatinine ratio needs to be checked to see she doesn't have any proteinuria. And also because she's a type 1 diabetic, one needs to get her TSH done
That's right.
and an anti-TPO antibody done so that we know that she does not even have those other autoimmune disorders along.
Okay.
So these would be the three investigations that I would do to say that, whether not except diabetes, does she also have any other complications?
Okay.
And Pranjali was absolutely right in saying that, yes, uh, HbA1c target should be less than 6.5
That's
and
right.
her TIR now needs to be like 70% at least
Yes.
for
That's
her
right.
to be fit.
Okay. So, in this case scenario, you wouldn't immediately advise her to have a pregnancy. So, in that case, would you advise her some contraception?
Yeah, definitely.
Yeah.
We need to
What?
discuss with her as well as we need to keep gynecologist in the loop because
Yeah.
gynecologist can discuss with the patient about which type of contraception can be used. And
Yes.
along with that, it's like a teamwork. We need to
Yeah,
work
that's right.
hand in hand and we need to work on the glycemic control and the gynec will take care of the health, the contraceptions.
Okay. What about any nutritional deficiencies? Do you think that any evaluation for nutritional deficiencies, or maybe we can start some
We can
nutritional
start with her
supplements
on
or something?
Folvite because she is planning pregnancy, so folic acid would be started. And also, I would like to get her vitamin D and B12 levels checked. Iron studies, hemoglobin needs to be checked so that all these other parameters, like I would see it in any other patient who wants to plan pregnancy, being diabetic or not. So it's very important to understand that she is able to conceive the pregnancy also,
That's true.
and
Yeah. Yeah, so that she's able to conceive. That's right. That's very important. And of course, she should be in an optimum state to, undergo
absolutely the
and
womb
have
has
a.
to be in an optimum
That's right.
state to
That's
accept
right.
the
So
fetus.
it has to be, that she has to be totally fit to actually conceive and have a healthy pregnancy. At the same time, she should also not be stressed, and because she herself is a type 1 diabetic, so we have to keep in mind her risk of CVD and renal as well as retinal states. So these are the things that we need to do. So that's nice. Now, let's go to the next case. So we have Revati. She's a 32-year-old female executive. She's been diabetic for the last 3 years or so. Her BMI is 28 kg per meter square. She is currently on metformin, DPP-4, and an SGLT2 combination. Her HbA1c is 8.9%. Now she is planning a pregnancy. Do you think she's suitable for conception?
She is, so my diagnosis would be she's type 2 diabetic,
Mm-hmm.
she's overweight,
Mm-hmm.
late pregnancy, and
Mm-hmm.
she's on multiple oral hypoglycemic agents.
Yes.
So for now, I'll tell her, please have contraception till you get fit. So her
That's right.
HbA1c levels need to come down.
Mm-hmm.
And for that, I need to stop her oral hypoglycemic agents like DPP-4 inhibitor and SGLT2 inhibitor that she's already on. So she
Okay.
continues with her metformin, and I would put her on insulin
Mm-hmm.
as a basal bolus therapy or as a premix insulin to just
Yes.
get her HbA1c levels
Yeah.
less than 6. And also for her, we would definitely screen for all the patients the complications
The
for diabetes
complication.
as
Yeah,
well
because she's
because she's
type
a
2
type 2
diabetic,
diabetes.
so
At
all the
diagnosis,
comment.
the type 2
Yes.
diabetes can have complications, micro and macro
Definitely.
both.
Definitely. So, Pranjali, would you like her to do more intensive monitoring? Maybe consider a continuous glucose monitoring or.
Yeah, definitely. I would like to start her on continuous glucose monitoring. Along with that, I'll be working on her lifestyle, her mental well-being because she is a busy female executive, so she might
Yes.
be handling a lot of
Oh,
stress.
yes. Yeah, yeah.
So we'll be working on her stressors. We'll be working on her breathing techniques. Along with that, blood sugar monitoring.
Mm.
Plus, she's on the overweight side, so we'll check her lipid profile. And if the patient is on statin or any other medications, then we need to stop before she gets
Yes,
pregnant.
that's right.
So at least for a month before her conception, we need to stop the medications.
Okay.
And then we need to be strictly, she has to follow the dietary changes.
Okay, fine. Also, what about vaccination? What is your, because that's the current buzzword, there are a lot of vaccinations and things like that, which most people take. So, any thoughts on that?
So you can go ahead.
So vaccinations 3 months prior is okay. If
Okay.
the patient is already got pregnant, then we would not tell her to take it now.
Yeah, okay.
So if the vaccination has not been done and if there is a risk of infection, then yes.
Mhm.
Being diabetic, non-diabetic does not change the criteria for vaccinations.
Okay. Anything else?
Yeah, so we need to tell her your HbA1c is less than 6.5 without having any hypoglycemic episode. Definitely you can go ahead with the pregnancy plan.
Yeah, definitely.
Till then,
What weight loss would you like kind of
so she's on, like, I would suggest to less than 24 kg BMI, 22 to 24
That's right.
BMI. Yeah.
That's right. Of course, I mean, she can get pregnant, but currently because she's already on OADs, which we don't know what is the
Yeah, so stopping
long-term
SGLT2 inhibitor
consequences. Yeah, so we
may
need to stop.
actually make her gain weight.
Yeah.
So she has to be more vigilant with her
Yes,
lifestyle
that's
now.
right.
Even adding insulin will put her
Will
on
probably,
weight.
yes,
So
make
that's
her
why one
further
needs to be
weight,
more
yeah.
vigilant
So
about the weight.
probably we need to have a kind of, maybe
A nutritionist on the board.
to to
Yes.
discuss the diet with her and maybe give her a plan to follow, as well as some, like you said, mental health counseling and things like that also, because there will be some component of emotional eating and, which is there, and maybe that can be done. And of course, subsequently, once her HbA1c is closer to 6.5 is when we can plan. We can also add the nutritional,
Folic acid
supplements
can
and
be
things
added,
like that.
vitamin
That
D can be
yeah,
added, calciums can
calcium
be
can be
added.
added. Yeah. Okay. So good. So that's nice. Now let's go to Harshita. Harshita is a 34-year-old female healthcare professional. The reason why I said healthcare professional, because I think most doctors, by the time they finish their, pardon?
Doctors are bad patients.
No, no, not because doctors are patients, but bad patients. By the time they finish MBBS, by the time they finish MD and DM, they're at that age where, time is running out, and then they decide that they want to get
The
pregnant. But
biological clock is also
the
running out.
biological clock, yeah, that's why. So that's why 34-year-old. And she's had gestation. Now, this lady has had gestational diabetes in her last pregnancy, which was about 5 years ago. She has been trying to conceive since then. But BMI, of course, is 31. Her HbA1c is currently 6.8, and she's not on any medication. So in her case, she's not a diabetic. She was a gestational diabetic in the last pregnancy, which was about 5 years ago. But currently, what would you advise her? And because the thing is, she's not able to conceive, so she wants to undergo IVF. So is she fit for that also?
So this is actually the best time. Just during gestational diabetes, the patients are very motivated and they follow everything. What really needs to be done is this after they deliver. This is the time that they really need to take care of the cells, especially not gaining weight. Because if during between the pregnancy, that window is very important. If they take care of themselves at that time in terms of their diet, their nutrition, their weight, then their chances of developing a second GDM
That's right.
is lesser. So once a GDM, her chances of developing diabetes would be 10 times, but if twice a GDM, that would be 15 times.
That's right.
So it's extremely important that, now that she's come saying that she was a GDM 5 years ago, but unfortunately her BMI has gone haywire.
Yeah,
Her,
she has
so
gained weight
yes.
post the first
So
delivery.
right now the biggest focus for her would be losing weight.
Yeah.
I think if she loses weight, her HbA1c will also come under control. So I would probably not put her on any medications. Just give her a calorie deficit diet, make sure that she loses weight, exercises. And even in spite of losing weight and her HbA1c doesn't come under control, then I would consider adding metformin probably. Now it depends on, we do not have much time in hand because she wants to go in for IVF. So
That's
she's
right.
told, and maybe the gynec has called me and saying that, pick the patient fit for pregnancy. I want to go ahead with the cycles.
Yeah.
So that's always the dilemma that we are dealing in, the time that we have in hand. So if she wants to go ahead with IVF and see lifestyle, she has to lose weight. Even in the 3 months that she can
That's right.
still have weight loss while undergoing
Because
IVF
especially
therapies.
and especially since she's planning IVF, and that because of the hormones and all, there is an additional weight
Additional
gain.
weight gain.
So that's why it's better that she does lose weight also. Anjali, what would you like to say?
So in this lady, I would like to screen for other metabolic
right.
problems as well. Like I would like to do lipid profile, HSCRP values. I would like to screen for her cardiac issues, like
State.
whether she's high risk of
Also, I think her retinopathy as well as
exactly, yeah.
albuminuria can be screened because
Yes.
I mean she's been a gestational diabetic 5 years ago, but it's better to have it
So
screened
screening,
rather than
and then
yeah.
we can start her on
Then we can
same
start
workload.
her
Yeah.
on medication. Yeah. And besides that, what else? What other things would you recommend that?
Because she's overweight,
Mm.
one should also not forget about the obstructive sleep apnea.
Yes,
That's also very common in people who are obese, and that could be one of the reasons why she has this pre-diabetes range, and she gets gestational diabetes. So
Yeah.
that could also be one of the reasons why she's not able to lose weight. So getting her checked on that terms,
Yeah.
and giving her correct measures
Mm.
would be of utmost
Also a
importance.
healthcare worker, so she's a sedentary worker, so maybe increase in activity levels,
Yes.
reduce stress, and all those other
And disturb sleep cycles.
yes, disturb
Yeah.
sleep cycles, all that further add to the weight gain. So that's why that is those are the things that would be there. Any other comments or anything
No,
else
it's
you would
all
like to
the
add?
same thing. Like we need to monitor her sugars, and then
Yeah,
the same like other
that's right.
cases.
So I'll just conclude what are the checklists that we have. Range. We need to keep the HbA1c less than 6.5 at preconceptional level. And we need to review and adjust the medications that if the patient is on medications, we need to review that. We need to adjust to see to it that the medications are all safe. Diet, nutrition support should be there. If they are overweight, they need to come to the normal weight. The BMI should be less or as close to 24 as possible. They should have regular exercise, provided there are no other contraindications to that. Folic acid supplementation is something that we should give. Monitor and manage complications, like we need to check for the other complications, especially the eyes, the heart, the kidney. All that needs to be evaluated. Any other comorbid conditions like high blood pressure, lipids, all that needs to be evaluated. In case there is, some genetic issue, we probably need to do a genetic evaluation. Vaccinations, if required, need to be updated. Any mental health concerns can be evaluated and addressed. And counseling.
So concluding, I would like to say now, the counseling plays a very important role
That's right.
in, yeah, and nowadays we have seen that younger generations are ready to accept whatever we tell them because they are health, they are aware about their health
They're
issues
more
and all.
aware
Yes,
about, yeah.
yeah. So if we counsel them
Because
properly, if explain them, yeah,
whatever we tell, they cross check with the social
exactly,
media
and they
and
follow what
all the
advice we give them.
influencers and things like that. Yeah.
Yes.
So yeah,
So teamwork plays a very important role
that's
in
important. Yeah.
pregnancy.
Yeah. Rukaya, what would you
So
like to add?
it's extremely important that the day the patient walks into you with even obesity, we need to counsel them that you might have a risk of gestational diabetes. So So it's always important to have a planned pregnancy rather than unplanned pregnancy. So every type 1 diabetic patient that we are treating who are at a younger generation, we need to have this conversations with the patient and the family about things. And once a GDM, she needs to be more proactive to not become a GDM in the second pregnancy.
The
So
postpartum period is very important.
is as important as the partum period.
Yes, definitely. Like now, I think a lot of gynecologists say that the next 3 months when they do lactation is the fourth trimester, wherein for the woman it is very important to see that she loses weight and comes back to probably her pre-pregnancy weight and definitely does not gain more weight.
So that is very important to tell the family and the patients. They just wait because they know that the diabetes will go away as soon as the baby is delivered.
That's right.
So they are waiting to eat everything as soon as the delivery is due.
No.
So we need to focus and tell them that it's not. This is not over. You're just getting you're just getting a you're able to see the future.
It's actually the window of
the
opportunity.
window of the future that
But
you are seeing.
Most times, you find that the woman's mother and mother-in-law have this joint conspiracy to see to it that they gain weight. Not gain weight per se,
They
but
eat a lot
to
of
see
high
that their
calorie food.
lactation is healthy or whatever. So they give them a phenomenal amount of ghee and very very rich foods and things like that, which maybe helps in lactation, but definitely it makes them gain weight. So I think that is something that we need to address, that they should not gain further weight and all. Okay. Now we are open for questions. If anybody has any questions, we can address them.
So that's a very wonderful session. Thank you so much, Dr. Lotika, Dr. Rukia, and Dr. Pranjali. I think definitely one piece of reinforcement that whenever people are coming to us, yes, maximum times these are spontaneous pregnancies, and I think that is the window which we really need to influence. Sometimes we feel that that opportunity is already gone because the A1C is already high. So reinforcement of monitoring, and of course, this is the population which are really very well. Open to all the suggestions and advice that we give. So maybe we can come up with some of the more and more educational programs around this, so that more and more people can learn of how to ensure that these pregnancies are much more protected via the different trials that we have. Which helps both maternal as well as.
So we always said that a healthy womb gives a healthy baby. Yes. But I think it's the healthy woman gives a healthy womb, and that would give a healthy baby. So one needs to understand that first she needs to be healthy, and only then she can have a healthy baby.
Absolutely. I think genetic programming, that's very.
Thank you, speakers.
Yeah, Vasanthi, you can.
Madam, I do not know whether my question is pertinent to the present talk because I entered little late. But I want to know your idea or your thoughts on metformin being continued during pregnancy. Your panelists as well as madam.
Yeah, so if the patient is already on
Metformin,
metformin,
yeah.
so definitely we can continue metformin. There are some guidelines in US, they don't recommend, but here we are continuing metformin. If the patient is already on metformin and on the overweight side and patient is having PCOD, history of PCOD, then we can continue. If there are some like if the patient or the pregnant lady is having severe deformities or some scan shows, then definitely we need to stop the metformin. If there are no contraindications, a fetus is fine, female is healthy, definitely you can continue metformin throughout the pregnancy.
Fair enough. And secondly, weight gain is a very big issue in pregnancy, particularly if the patient is on OHAs and then we tell them that pregnancy में हम लोग OHA नहीं दे सकते हैं ज़्यादा. We have to switch over to insulin. So they gain weight with insulin as well as with the nourishment, as madam said, that mother-in-laws are conspiring with us. So all these things add up. So how do you counter it? Do you tell them to walk every day or do some,
Yes,
you
of
know,
course. Light
exercises?
exercise is always recommended. The
But they
patient
don't
can
do it.
walk unless the gynecologist has advised she needs bed rest. So according to the diabetologist, she can always exercise. And so that's why it's a team effort. The dietitian has to be on the board and she needs to follow a specific calorie diet, and only so that she's not getting too much of weight gain, and plus her sugars are well under control. So unless the family is on your side, you won't be able to achieve it.
Exactly.
So the patient and the family has to be on your side. But I think, pregnancy is such a time that they are absolutely open to suggestions and they do
Receptive to what
everything.
you say.
At other times, maybe they would not listen, but during pregnancy, they are,
During pregnancy,
yes,
they usually
they're most
do
easy
listen.
to convince at that time.
Fair enough. Thank you.
And if they're planning a pregnancy, definitely they are more open to suggestions. Unfortunately, what happens is, like we said, that most of the time they come without planning a pregnancy, and then it's very difficult. A lot of times they come with HbA1c of 8, 9, 10, 12, whatever it is, and then it is a big challenge. So that's why pre-pregnancy counseling is something which is very, very important, and I think it should be done for all people with diabetes or history of gestational diabetes. Anything else? Vasanti, you want to ask something? Okay. Neela, 1 minute, can I have the screen back again? So, I just wanted to formally invite you all to save the date, because we are going to have Maharashtra RSSDI on 15th and 16th of March. Shashank is here, Manoj is here, and all the other team members who are here all invite you for this grand event. Thank you.
This time, Holi with Maharashtra RSSDI.
Pardon?
Holi with Maharashtra
Yes,
RSSDI.
Holi with Maharashtra RSSDI.
Thank you.
For the next session, I would like to call Dr. Vimal Pahuja and Dr. Sylvia for chairing this session.
Good afternoon. I present Dr. Sashan Joshi, consult endocrinologist, affiliation Lilavit Sear Joslin Clinic, publication honors achievers. 1,000 published publication, authors of 100 books, ranking in the top of 0.5 in the field of general and internal medicine across 106 authors globally. Padma Shri Gov of Indian 2014, International Clinical of the Year Award 2012, American College of Endocrinology, President Indian Thyroid Society, President Indian Academy of Diabetes, past President International College of Nutrition, past President Endocrine Society of India, past President Association of Physicians of India, Emeritus Editor Japi, past Dean Indian College of Physicians, past presidents, and past Indian Charter Chair American Association of Clinical Endocrinology, in past chair IDF Southeast Asia.
Just two more words. He is an endocrinologist of endocrinology, and he has taken the endocrinology to next level. He has brought glamour to endocrinology, and he's put the India on a world map in terms of the work India is doing. So thank you so much, sir.
Thank you, Dr. Pooja and Sylvia. And at the onset, I want to thank Manoj and Purvi Chawla in particular that they allowed me to talk on this talk. And I have to talk on the computer is tired for the day because it looks to that it's hung up. चलो हो गया? हाँ? ये छोटा होता है. I want it in the big screen. Okay, so we have our slides on board. I'm going to talk on the Amplify TIR study of a combination of SGLT2 inhibitors and DPP4 in the Indian population. This is my duality and conflict of interest of the talk. So we all know that glycemic assessment in diabetes is beyond A1C now. And though A1C is the gold standard for glycemic control in diabetes, there are a lot of limitations because A1C cannot assess hypoglycemia or glycemic variability. It doesn't allow us to get at the frequency and the magnitude of short-term fluctuations of glucose. It doesn't tell us the inter-day and intra-day variations on glycemic excursions. We know glucose gets affected by kidney disease, hemoglobinopathies, chronic liver disease, iron deficiency anemia, and then the glyco-HB is not accurate. So A1C doesn't actually reflect the true glycemic exposure, as I call it. And therefore, we have moved the gear from a glycemic triad to a glycemic pentad. So in the good old days, we should say that we manage fasting sugar, postprandial blood sugar, and A1C. That was the triad. And today, when we talk in 2024, we are managing a pentad. So we are not just looking at fasting, PP, and A1C, but we are also looking at glycemic variability and hypoglycemia. And we know that glycemic variability and hypoglycemia contribute to the vascular complications of the disease. We also know that the glycemic excursions trigger oxidative stress. And when there is oxidative stress, you get angiogenesis, you get pro-inflammatory cytokines released, you get long-lasting epigenetic changes. And even when there is normoglycemia, there is a memory of the negative memory, as we call it. Just like we have glycemic legacy, we also get a negative memory of the oxidative damage, which is caused, and eventually we get formation of the glycemic advanced end products. So if you look at CGM, it has been a game changer. And if you look at the self-monitoring data recorded over a period of 60 days, for example, you can see that gradually you can see a downward trend which is evident from say 9.4 to 7.5. But the glycemic variation still remains the same. So sometimes you may see that the A1C has come down, but the variability has still remained. In fact, you will see as you improve the A1C, the risk of hypoglycemic events which are highlighted in the circles actually goes up. And therefore, if you look at the amplitude and time, we are seeing a lot of variation of people above the range, below the range targets. And therefore, it is very important that when we talk in 2024, the glycemic variability is a better predictor of hypoglycemia than A1C. It's a very consistent predictor of hypoglycemia. We know hypoglycemia is responsible for morbidity and mortality. We know a lot of glucose fluctuations, frequent and large, are independently associated with diabetes-related complications. And we also know that when there is a lot of glycemic variability in the ICU, then there is a mortality which is there. So when we see glycemic variability, you can get severe hypoglycemia. We see that it is directly proportional to the development of autonomic dysfunction, mainly cardiac, and sudden cardiac death can occur, arrhythmias can occur, macrovascular complications can occur, microvascular complications like albuminuria and retinopathy can occur in 40 and 60% of patients. And the prime driver of cardiovascular events, which is the primary cause of death, is all contributed by glycemic variability. Therefore, as I told you that whether it is the biological mechanisms which cause endothelial dysfunction and oxidative stress, or whether it's the clinical consequences which cause fibrillation, cardiovascular events, myocardial infarction, the neointermittent growth, the need for revascularization with angioplasty and bypass, the vulnerable plaque, various other things are linked directly to glycemic variability. And we have now a tool in CGM which actually we can map now. And the green is 70% should be in target in range. This is called as TIR. And this will replace the entire A1C, which is time in range. And 70% should be in green, which is 70 to 180. Less than 4% grade 1 hypoglycemia, less than 4% less than 70, and less than 1% grade 2 hypoglycemia or severe hypoglycemia less than 54. And then grade 1 hyperglycemia is more than 180 but less than 250, which is less than 25%, and more than 250. 250, why the 250 cutoff is there? It's an arbitrary cutoff, but it's mainly a ketoacidotic threshold. You start getting ketoacidosis after glucose goes up beyond 250. And that is why that cutoff is there. And then we can actually have a metric to look at it. So as I told you that glycemic variability is important. And for every 10% increase in time in range, there is a 60% increased risk of retinopathy, 40% increased risk of microalbuminuria, and 25% increased risk of peripheral neuropathy. And as I told you, there is a direct linkage with heart disease. And next month is September, we'll be celebrating World Heart Month. As we talk today in London, European Society of Cardiology is talking. And we have looked at lot of data now to look at impact of glycemic variability on cardiovascular outcomes with type 2 diabetes. ADVANCE was the first study which looked at visit-to-visit coefficient of variation and looked at impact of A1C to visit-to-visit variation was associated with increased risk of vascular events, microvascular events, and mortality. DEVOTE 2 looked at direct association of glycemic variability with severe hypoglycemia. And Takashi published a study from Japan with acute coronary artery syndromes, and there you could see the mean amplitude of glycemic excursion was associated with increased MACE, independent prognosis of poor prognosis, and many more data worldwide have just studies, including Digami and others, which showed that there could be a positive mechanism. A lot of people ask me this question, how does glycemic variability cause nerve involvement? Because it's a very complex equation here. We have short-term glycemic variability, long-term glycemic variability. And when we get oxidative stress, we activate neuroinflammation, we cause hyperphosphorylation of the tau protein, and we get memory defects and cognitive dysfunction. When we get a lot of oxidative stress, we overactivate the NRLP3 and the autonomic ganglion synaptic transmission, which causes cardiac autonomic neuropathy, which causes arrhythmia and sudden death. And we also activate, when you get glycemic variability, the NADPH oxidative stress, the NF-kappa beta pathway, inflammatory response, and you get tingling, numbness, or diabetic peripheral neuropathy. So this is a mechanism that when there is variability of glucose, you get diabetic neuropathy, you get cardiac autonomic neuropathy, and cognitive impairment. And that data is very clear-cut. So many studies have shown that variability of A1C is strongly correlated with diabetic peripheral neuropathy and cognitive impairment. Can drugs impact glucose variability? For example, metformin. No direct head-to-head comparison, no major impact on GV. Sulfonylureas, we know, are deleterious to health, mainly because they have hypoglycemia in the risk equation. Gliptins reduce glycemic variability. So gliptins worldwide, excluding probably Asian countries, including India, have replaced sulfonylureas completely. Because sulfonylureas don't have durability with them and they have a risk of hypoglycemia. And gliptins have data to suggest that they reduce glycemic variability. So do SGLT2 inhibitors. And clearly that evidence is very clear-cut. GLP-1 receptor agents, great agents, again reduce weight, reduce glycemic variability. Alpha glucosidase inhibitors, again great agents, they can reduce glycemic variability. And therefore, several studies have been done in which they looked at gliptins replacing sulfonylureas. This was the top TIR study. Teneligliptin on glycemic control through parameters in time in range, which was done by two people who are there in the audience, Dr. Bansi Sabu and Suhas Erende. And they very clearly showed that this gliptin, which is a third generation gliptin called teneligliptin, okay, clearly got patients in a multi-center open label study in range. Indian population. So this was an Indian study which was done. And what did they do in this top tier study? They basically put patients on 20 milligram of teneligliptin for 6 weeks, did first CGM, pre-treatment, post-treatment, and then second CGM again in phase 2. Uniform diet pattern, no addition of any anti-diabetic drug. And clearly you can see they got a large population by phase 2 in range. So most people were able to come in range. And then there's also data to suggest that we have now generic dapagliflozin. And dapagliflozin, when compared head-to-head with placebo, 50 patients each, head-on with CGM, you could see that the glycemic variability is controlled. So again, when you compare head-to-head a teneligliptin and dapagliflozin, clearly you can see the glycemic improvement will happen. So when we compare SGLT2 and gliptins in combination in the Indian population, the amplified TR study, the data of which I'm presenting here today, and I'm happy Dr. Ajay Kumar has arrived, who is our next speaker. We were a little worried where you are. Okay. The teneligliptin dapagliflozin in the test arm versus sitagliptin dapagliflozin in the comparator 1 and linagliptin empagliflozin in comparator 2 arm. Worldwide, the first compound in the fixed dose piece was actually launched as linagliptin empagliflozin. That met the US FDA and EMA approval. Sita-DAPA and Tenli-DAPA are actually Indian combinations. We are first in the world to actually make them. And this is a study, Amplified TR, where we looked at evaluation of efficacy of this fixed dose combination of a DPP4 and SGLT2, improving the CGM data. So let us look at what is the data. So as I told you that we have to look at glycemic variability, long term and short term. And if you look at the data here, 40% in range, 20% low, compared to 100% in range. So that is how the movement will occur of glycemic variability. Why were these two combinations combined? Is there any synergy to it? Possibly yes, because they have complementary mechanisms of action. A gliptin and SGLT2 will balance the endogenous glucose production, the EGP. We all know that the DPP4 inhibitors they switch off the alpha cells, so they stop the glucagon diarrhea from the alpha cells. They switch on the beta cells only when the glucose is high. So they have that secretagogue effect without hypoglycemia. They clearly have the incretin blunting of action and pharmaceutical 2 to 4-fold increase in GLP-1 in the gut. Then the SGLT2 inhibitors clearly increase the glucose resorption, and we are able to do that. So these are independent of the pancreatic cell functions. So from an efficacy standpoint, safety standpoint, and clinical practice standpoint, when we combine the two, we get synergy. As I told you, this synergy was first documented, and people also think that the side effect profile may be less, because there was a hypothesis generated that when we use a gliptin with SGLT2 inhibitor, the incidence of genital mycotic infections is less because it is presumed that even in the fungus, the DPP4 enzyme is inhibited and you don't get the genital mycotic infection. So that is an anecdotal observation from various phase 3 clinical trials which got extrapolated. So clearly cardiovascular and renal risk factors benefit, the CV renal outcomes benefit, there are no overlapping toxicities, there is no increased risk of cardiovascular events or weight gain or hypoglycemia. In fact, the genitourinary infections may come down. Again, that is, as I said, work in progress, no drug-to-drug interactions. And you can use it with any other agent, it's an oral agent. So this study was a prospective, multi-center, randomized, open-label study of teneligliptin dapat 20 plus 10 compared with the compare it over a period of time at the end of phase 2, you can clearly see that there is a drop in the EA1C in the teneligliptin dapagliflozin group by 35%, sita-dapa 34%, and lina-empa 54%. And the percentage of population achieving TIR is around 23 to 29% across board. So there is a sustained significant reduction of average glucose and time in range across all the three groups at the beginning of the study and the end of the study. So this is the data which is available. When you look at time above range, again you can see a consistent significant reduction of time above range across all the three groups, which is very comparable. And if you look at time below range, which is hypoglycemia, again you can see a very, very consistent range across all the three groups. So when we compare the various parameters of the mean amplitude of postprandial glucose excursion, 1 RPP values, 2 RPP values, there is a very sustained reduction in various study groups. And therefore, when you look at the mean postprandial glycemic excursion, which is the MPP-EG, or the 1R or the 2R, you can see all the three combinations show a directionality of positivity. And when you look at across patient study groups, the tenli-dapa dropped the A1C from 8.4 to 6.85, sita-dapa from 8.44 to 7.12, and lina-empa from 8.81 to 7. So they were at a higher baseline. And similar data is seen in fasting and PP without increasing the hypoglycemia. So clearly you can see across board in the triad, whether it is the A1C, fasting and PP, a significant and sustained reduction of fasting, PP and A1C is seen across all three groups. And fasting was significantly better in the tenli-dapa group compared to sita-dapa versus lina-empa. If you look at the kidney function on eGFR, on creatinine, on BUN, again you can see a very, very clear-cut reduction on the renal parameters across all the three arms at the end of phase 3. And clearly when you compare A1C, fasting and eGFR with creat and BUN, the data is very, very clear-cut. So summarizing very clearly, what I wanted to highlight in this presentation is that glycemic variability is an independent risk factor for type 2 diabetes. And many speakers before me also highlighted this point. Amplify TIR, which is time in range, was a study which compared the efficacy of teneligliptin with dapagliflozin, a Make in India compound, in combination for improving the glycemic variability with parameter of CGM. We know now that if you want to maintain glucose and you want to prevent diabetes-related complications, glycemic variability is a tool to be considered. And glycemic parameters and GV parameters and the renal parameters clearly were improved across board with all the three combinations, with some advantages of the FDC, which was under question. So clearly we see some robust data, which I thought I should present to you. I'll be happy because I have finished a little before time to answer any questions which you have. But the whole idea of the presentation was that we are moving gears from simple fasting, postprandial and A1C to a pentad of a focus on hypoglycemia and glycemic variability. And when we have gliptin and SGLT2 combinations available with us, we not only get benefits in terms of glucose lowering effect, in terms of weight neutrality and lack of hypoglycemia, but also some cardiorenal benefits. And apart from that, some cardiovascular risk reduction. But beyond that, we also are trying to achieve a time in range. And the global thinking now in the technology world is to achieve time in tight range. So that is the next thing. But this current trial, which I showed you, we showed you that an Indian compound FDC, tenligliptin dapagliflozin, was at par with a Lina-Empa or a Sita-Dapa. Thank you for a patient hearing.
Thank you, sir, for such a wonderful and insightful deliberation. We have some questions. You want to open the questions? Or... Yes.
Dr. Shashank sir, since the advent of the basal insulin, it was promoted that basal insulin will definitely reduce your glycemic variability. And it has done that beautifully. Now the question comes, should we start with basal insulin first or only depend on OHA? When is the point when you actually start the patient on a basal insulin, irrespective whether he really needs to go for a insulin dosage or you have completed 3 doses or 3 different OHAs or 4 different OHAs? Do you feel that starting a basal insulin will be a better instrument to control the glycemic variability and bring TIR more into our hands?
So good question and a very simple answer. See, insulin's line extension is hypoglycemia and weight gain. That's number one. Number two, most people who need basal insulin, actually, if you give them an SGLT2 inhibitor with a DPP4 inhibitor and a metformin, they don't need the basal insulin. See, what had happened is that we didn't have this in the armamentarium. See, insulin is the longest surviving anti-diabetic drug for more than 100 plus years. After insulin, fundamentally came metformin and sulfonylureas after World War II, 40s, 50s, and 60s. So fundamentally, we had only 3 drugs till the end of the century. It was only in the end of the century some alpha glucosidase inhibitors came on, and then suddenly we had in the last 2 decades a spurt of gliptins and SGLT2 inhibitors. With the advent of gliptins and SGLT2 inhibitors, insulin will cause hypoglycemia, insulin will cause weight gain, and the basal insulin concept was based on Lou Monier's concept, a French physiologist who said that if your A1C is above 8.5 and 9, fix fasting first, give basal insulin at bedtime so that the hepatic glucose output is reduced and next day morning fasting is reduced. That is still the conventional way to give insulin. Now, type 1 diabetes or secondary diabetes or gestational diabetes all need insulin. It's only in the type 2 diabetes space that we need, but that's a glucocentric view. But insulin has no impact on hypoglycemia and weight gain. It has no impact on glycemic variability. It will cause more glycemic variability. It doesn't have cardio-renal outcome study. It doesn't impact the cardio-renal outcome study at all. So at best, insulin is a glucocentric molecule only working on the glucose pathway, but doesn't have the pleiotropic benefits. See, Dr. Eugene Brunwald wrote a beautiful editorial in the European Heart Journal saying that just like statins were the molecules of the last century, SGLT2 inhibitors are the statin of this century. And clearly they are the game changer. So there is no brainer in this. And they clearly have a cardiorenal impact. They modulate the endothelial function. We still don't understand why we get this thing, but these are offloading agents. So the hospitalization to heart failure clearly comes down. And that's clearly a class effect. I don't think it is molecule specific. Me and Ajay many a times talk for molecules, but I can tell you very honestly and upfront that some of the effects are class effects, some of the effects are molecule specific. The data generation may be molecule related, but the generation of the class effect is very clear cut.
I take your point. I take your point that
so don't be wedded to a basal insulin when you have agents which can also have an impact on cardiometabolic health and glycemic variability both.
Okay, can you place this combination as the first upfront treatment for a newly diagnosed?
Oh yes, absolutely. In fact, if you see some of the current guidelines which are coming in selected patients, this can be a reasonable option as a first line or a second line. But I would still put conventionally this as a second line combination. But it is emerging data is showing and compelling data that, in fact, now we have triples.
Yes.
A gliptin, metformin, and a SGLT2 inhibitor can be a easy triple
The upfront treatment.
upfront.
Fair enough. Thank you.
Yeah. Yes, ma'am.
Only one question.
Yes.
Any people? Sorry, is there any difference in the cost with the combination?
Yes. So the Lina Impa is prohibitively expensive, while the Sita Dapa as well as the tenligliptin Dapa is much more economical. So it's almost one third or one fourth of the cost. So the cost, see, India, tenligliptin as well as dapagliflozin are generic. So their cost is substantially lower compared to, for example, Europe or US. It is still high. Here they are off patent. So they have lost their patent. So we have a larger population having access to these drugs.
No further questions. Thank you, sir,
Thank
for such a wonderful session. So our next speaker is Dr. Ajay Kumar. He is a director, Diabetes Care and Research Center, Patna, India. He is a principal investigator of several phase 2 and phase 3 studies in development of new molecules in diabetes. He was a principal investigator for ICMR INDIAB study for Bihar, global expert for development of newer insulins and GLP-1 based therapies, and global expert for premix insulin guidelines, author of several chapters in textbook of diabetes and medicine, several publications in peer-reviewed journals, and delivered more than 1,400 lectures at national and international meets. So I welcome sir and invite him to give his talk. Thank you so much.
Honorable chairpersons, ladies and gentlemen. At the outset, let me thank Dr. Manoj Chawla not only for inviting me, but also showing his perseverance when I had a major problem in coming tomorrow, and then he managed to create this slot for me on a Friday evening so that I can have my family function tomorrow evening. Thank you, Manoj, very much. Coming to my topic, I think we just heard that the therapeutic canvas of type 2 diabetes has been completely usurped by SGLT2 inhibitors in last 15 years. And what we have seen that this therapeutic canvas has been colored in multiple shades by various SGLT2 inhibitors. And it's very interesting to understand that this molecule was invented through a very counterintuitive mechanism of action. A symptom of diabetes was converted into the mechanism of action of a particular therapeutic agent, and that's how the SGLT2 inhibitors were invented. And you can see the entire spectrum of type 2 diabetes, and going on to the cardiovascular and renal complications, SGLT2 inhibitors have been tested at every stage, and whether we are talking about empagliflozin, canagliflozin, or the dapagliflozin, or any SGLT2 inhibitor that we are talking about. And what is very interesting to see that when we look at the natural history of type 2 diabetes, at every stage, it plays a very significant role. It plays a role in the prevention of type 2 diabetes, preventing the clinical spectrum in going into a bad situation, and preventing the cardiovascular complication, preventing the recurrent events, whether we are talking about the renal events or the cardiovascular events. So SGLT2 inhibitors have really taken the world by storm. And all these statements are backed by some very elegant scientific publications, which are humongous, absolutely humongous. And it is important to understand that 2/3 of these publications are in high impact journals, so a lot of credibility behind what we are talking about. The entire story or the journey of SGLT2 inhibitors for clinicians like us started with the phase 3 study in type 2 diabetes, where it showed significant reduction in the HbA1c with an additional benefit of significant weight loss. And subsequently, the cardiovascular outcome trials demonstrated for the first time that you could actually reduce the cardiovascular death and many other cardiovascular outcomes which are bracketed as 3-point MACE. Going on further, what we saw in the DAPA CKD and DAPA HF trial, that irrespective of the fact that whether your patient is a type 2 diabetic or a non-diabetic, in patients with chronic kidney disease and heart failure, dapagliflozin will give you benefit. All the SGLT2 inhibitors will give you benefit. And when this benefit was seen in heart failure with reduced ejection fraction, it was tested in DELIVER study to look at its ability to reduce the events in patients with preserved ejection fraction. Then we come to the second row of a study, the DAPA mechanism, etc., where it looked at the mechanism of action of this drug as to why so much cardiovascular or renal benefit is coming. Then 6 minutes walking distance test, again in heart failure with preserved ejection fraction and reduced ejection fraction. Then we had the DELIGHT study, which looked specifically in the renal outcomes in patients with type 2 diabetes and renal failure, real world data, and very recently, role of dapagliflozin in acute myocardial infarction and heart failure. So you can see the canvas of studies which have been done with SGLT2 inhibitors and particularly dapagliflozin. If we divide these studies, DELIGHT and DAPA CKD is dedicated to the chronic kidney disease, and all the other studies are either dedicated to cardiovascular outcomes or looking at the mechanistic studies. But going beyond these studies, what is very interesting is to look at this spectrum of studies that now I'm going to show you. We are also looking at the role of dapagliflozin in patients who are on hemodialysis, peritoneal dialysis, patients with end-stage renal disease, whether further nephroprotection can be done, whether we have patient treating with hypervolemia, where it has a specific role to play. There are many patients of heart failure who need very huge dose of diuretics, and still they are not responding. Whether addition of dapagliflozin will be helpful in that. Dapagliflozin has shown robust role in reducing the incidence of renal stone and all the parameters of PCOS. And then we have understood the mechanistic studies very well, and also its role in the non-alcoholic fatty liver disease, improving renal anemia, chronic kidney disease and heart failure in frail patients, because large number of our population now beyond the age of 75 are quite frail and suffering from multi-system disorders, where it has a role to play in that situation. And finally, patients with sleep apnea. And what I'm going to do is to look at few of these studies to give you some recent data about dapagliflozin. Now, historically, when you look at the studies of dapagliflozin, the time frame, the number of years since the diagnosis, and the degree of CKD, what you can see here, that we have studies like DECLARE, which recruited patients with very good EGFR, close to 80 to 90%, and we have also studies here where the EGFR was as low as 25 or 30. And across the spectrum, you demonstrated that there was significant benefit in almost all the studies. So first, I'm going to show you some data about the renal outcomes. And this is the DAPA group, huge study looking at a comparison of dapagliflozin versus incretins, whether DPP4 inhibitors or GLP-1 receptor agonist. And what we see very clearly that the decline in the EGFR is much lesser with dapagliflozin, as you see on the left-hand side, and the reduction in the urinary albumin creatinine ratio on the right-hand side is much more robust with dapagliflozin as compared with incretin-based treatment. Then looking at the other renal parameters like new onset CKD, loss of kidney function, doubling of the serum creatinine, or the composite of renal outcomes, each one of them were impacted much better by dapagliflozin as compared to the incretins, whether DPP4 inhibitor or a GLP-1 receptor agonist. What about patients who have entered into the stage of hemodialysis or peritoneal dialysis? The whole idea is that at this stage, when you give an oral drug, what is the dialyzability of that particular drug? Whether it will increase the risk of that particular drug and whether it continues to be effective in that situation. And what you clearly see here in this particular study, dapagliflozin given on the day 1, day 3, and day 7, and that clearly showed that a very small amount of the drug is dialyzable, and therefore it retains its action, and there is no increase in any significant side effect. So this is a very important study that tells you that even at this stage, dapagliflozin can be extremely useful. Then looking at the DECLARE study or the other study, DAPA CKD study, there were studies which actually looked into what happened to the hematocrit. And it was clearly shown that when you use this molecule for control of blood sugar or for cardiorenal protection, actually you are getting additional benefit of anemia correction, and that was very clearly seen in this particular study. Somebody can ask a question that if dapagliflozin is so good, SGLT2 inhibitors are so good, possibly all the benefits are coming because of its diuretic action, because the major impact was on the heart failure hospitalization. So why not the conventional diuretics like furosemide or torsemide should be equally effective? It would not, because there are seminal differences between the two molecules. What you see here on the left-hand side, if you use a conventional diuretic like furosemide, from a hypervolemic state, you achieve the euvolemic state, and then you go on to have the hypovolemic state. And when you have the hypovolemia of that kind, what will it lead to? It will lead to some increase in the renal deterioration and activation of the renin-angiotensin pathways. All these things are undesirable. But when you use a molecule like dapagliflozin or SGLT2 inhibitor, you achieve from hypervolemia to euvolemia, and then you have this volume set point. You don't go down further like a hypovolemic state here. And therefore, you do not increase the serum creatinine, you do not activate the renin-angiotensin system, and therefore, you do not produce all those undesirable effects. And that is the essential difference between the conventional diuretics and the SGLT2 inhibitors. Now, moving on from the renal studies, let's move on to cardiovascular studies. And I think each one of us know about this, that whichever cardiovascular outcome we are talking about, cardiovascular death, all-cause mortality, heart failure hospitalization, first heart failure hospitalization, 3-point MACE, 4-point MACE, cardiovascular death, each one of them is favorably impacted by the use of SGLT2 inhibitors. Now, think of a patient of heart failure whose eGFR is less than 25. Now, what can we expect? Now, obviously, when eGFR is low and you continue to use dapagliflozin, few patients will deteriorate and few patients will not deteriorate. Will that affect the outcomes? And that is the interesting data that I'm going to show you. And this is the cardiovascular death or worsening of heart failure. And irrespective of whether the eGFR continues to be less than 25 or more than 25, the results are the same. Still, you get the cardiovascular benefit. And similarly, when you are looking at the adverse effect, again, less than eGFR 25 or more than 25, the benefits are there. And this clearly shows that even when the eGFR goes less than 25, you continue to reap the cardiovascular benefit with dapagliflozin. And same thing happens in patients who have got severe heart failure. When you have got severe heart failure, all these patients obviously have increased in-hospital mortality. That was seen in DELIVER study, DAPA heart failure study. But when you have got very low eGFR in these patients, whether you are talking of any of these endpoints, all heart failure hospitalization, in uncomplicated heart failure or complicated heart failure, with a very low eGFR, you continue to reap the benefit of using an SGLT2 inhibitor. Why do we get all these benefits? That's a million-dollar question. And many theories have been proposed. But what is most important is that now we have this mechanistic study called the DAPA-MODA study, which clearly shows that when you use a molecule like this, you reduce the left ventricular end diastolic volume, you reduce the end-terminal pro-BNP, left ventricular mass, and the left atrial mass. So when you reduce all these parameters, obviously the cardiovascular benefits are likely to ensue. As you can see here in the chart form, the reduction in the left atrial volume, reduction in the left ventricular mass, and very robust reduction in the NT-proBNP. All these are obviously going to translate into cardiovascular benefits. Then the situation comes in a patient of heart failure who is resistant to huge doses of diuretics, huge dose of furosemide, etc. Then what do? You have two options. You can either use a very potent drug like metolazone, or let's compare metolazone with dapagliflozin. And that is what exactly was done in this particular study. And when you look at the efficacy parameters, the change in weight and the congestion score was equally affected both by the dapagliflozin and the metolazone. But the benefit comes in the safety part, where you see when you use a drug like metolazone, you are likely to increase the serum creatinine, deterioration in the renal function, But in case of dapagliflozin, there is no deterioration in the renal function. So even at this stage in patients with resistant heart failure with huge doses of diuretics, addition of dapagliflozin is going to be extremely beneficial. And now the recent study about dapagliflozin use in acute myocardial infarction. This was the study, very clear-cut, STEMI or non-STEMI. There should not be past history of chronic heart failure, and then you are looking at impaired LV systolic function, and these patients should be hemodynamically stable. And what do we see here? We are looking at several outcomes: death, hospitalization for heart failure, myocardial infarction, atrial flutter fibrillation, onset of type 2 diabetes, NYHA class movement from 1, 2, 3, 4, whatever, and weight decrease. Now, when you look at the primary outcome and the key secondary outcome and compare dapagliflozin with placebo, it comes out as a winner. But obviously, this difference is not seen in all the individual outcomes that we are talking about. There is difference in the quantum of benefit when we are looking at the individual outcomes. But when you actually do look at the primary outcome, which is a composite of these 7 outcomes, there is very clear-cut benefit with the use of dapagliflozin. And that actually tells you that in patients with acute myocardial infarction and impaired left systolic function, patients without prior diabetes or chronic heart failure, dapagliflozin will give you the benefit. This is extremely important and a very nice study. And now let's look at few of the other studies. What about patients with non-alcoholic fatty liver disease? And you can see the huge number of studies, and the bottom line is that almost all of them have shown significant benefit, few of them statistically significant, few of them showing only the trend. And what are we looking at? We are looking at in NAFLD patients, change in the liver enzyme or change in the lipid metabolism. Almost all the studies showed reduction in the liver enzymes, which is beneficial in patients with non-alcoholic fetal liver disease. But when we look at the lipid metabolism, not every study showed the benefit. So this has to be understood that the primary benefit is coming from reduction in the liver enzymes, and that itself is sufficient in patients of non-alcoholic fatty liver disease. Correction of renal anemia. That's another very nice study. As you can see here, there was very clear improvement in hemoglobin level when you use dapagliflozin. And we know the mechanism, the increase in hematocrit, oxidative metabolism, all these important mechanisms actually help you achieve a better hemoglobin in patients of chronic renal failure when you use a molecule like SGLT2 inhibitor. And I was talking about these elderly men and women who are very frail and whether use of dapagliflozin would be good in these patients. Now you are looking at these frail patients in the chronic kidney disease spectrum, and what we are looking at, so many outcomes. Primary outcome, I will not read each one of them, but basically you must appreciate that the primary outcome or secondary outcome is a mixture of all the renal outcomes we are talking about. End-stage renal disease, renal failure, need for dialysis, doubling of the serum creatinine, more than 40% or 50% decline in the EGFR. All these are the usual renal outcomes. And they were all looked in these frail patients of chronic kidney disease. And you can see here, there is a very clear benefit by using a molecule like dapagliflozin. And similarly, now move on in the frail patients with cardiac problem, heart failures, and you see once again, all the parameters which we are looking at, worsening heart failure, cardiovascular death, or anything, heart failure, hospitalization, all-cause death, cardiovascular death, you can see here that dapagliflozin is showing benefit even in elderly frail patients. We are generally quite worried in using a molecule like SGLT2 inhibitor in elderly patient because they are on multiple drugs, they are frail, they could be in heart failure, and therefore we think that this patient will be suffering from a lot of hypovolemia, can go into significant drop in the blood pressure, and we can do harm to them. But this study has clearly shown that in frail patients, elderly patients, in chronic kidney disease, in severe heart failure, you can continue to use molecule like SGLT2 inhibitor and derive the benefit. You can see here all the outcomes that I was talking about in most of the studies, either significantly or non-significant trend towards benefit accrues by the use of dapagliflozin. This is what I was talking about, prevention of renal stones. In this very elegant studies, SGLT2 inhibitor was compared against GLP-1 receptor agonist and in another studies against DPP-4 inhibitor. And you clearly see in comparison with GLP-1 receptor agonist, there was 31% lower risk of kidney stones. And in comparison with DPP-4 inhibitors, there was 26% lower risk of renal stones. So very clear benefit that when you use a molecule like this, you are reducing the risk of formation of renal stones, and that is quite good. And then let's go to the end stage renal disease and think whether dapagliflozin will give you benefit. Now we have known through various trials that in a stage 2 or a stage 3 CKD, you derive great benefit. Now we are looking at a stage 4 CKD, and you can see that the graphs are almost similar. That tells you that even in the end stage renal disease, very low EGFR, you still continue to get the benefit of SGLT2 inhibitors. But at this point of time, we will continue to use it only when the EGFR is more than 20. We are not going to start an SGLT2 inhibitor in patients who have got an EGFR of less than 20. This has to be understood. And finally, polycystic ovarian syndrome. We have large population with polycystic ovarian syndrome, which is largely driven by all the parameters of the metabolic syndrome. So obviously, when you use a molecule like this, all the parameters like body weight, fasting plasma glucose, insulin resistance, DHEAS level, all of them are reduced by the use of dapagliflozin in this particular study. Obviously, that is going to give benefit to these patients of PCOD. And then we have the sleep apnea associated with heart failure. Now we know that if you have heart failure and on top of that you are obese, sleep apneic, then your risk of cardiovascular death or heart failure hospitalization is much more. And if that is much more, as you can see here, worsening heart failure, cardiovascular death, what can we do? It can have both reduced ejection fraction or preserved ejection fraction. So let's use SGLT2 inhibitor and then see what happens. This is the data from the DAPA-HFS study and the DELIVER study, and you see here that the benefit continues in these patients of sleep apnea with heart failure. And then there was a dedicated study which was done for this, which is called DAHOS study, efficacy of dapagliflozin in treating heart failure with reduced ejection fraction and obstructive sleep apnea syndrome. And what you see here, all the sleep parameters improved and all the cardiac parameters also improved. More interestingly, the BMI reduced, the end systolic contraction reduced, all the scores that we look in the heart failure, they improved, CRP decreased, and the interleukin-6, the inflammatory markers decreased. So what we clearly see, you are getting cardiovascular benefit, and you are also getting benefit for the sleep apnea scores, which are extremely important for these patients. And finally, look at the meta-analysis looking at the incident gout when you are using SGLT2 inhibitors. And this is very interesting that you keep on looking number of observational studies with large number of patients, and you see 30% reduction in the incident gout, or those who are known to have gout, the recurrent flares of gout. And then subgroup analysis from many studies, RCT in fact, and in fact, every single study has clearly shown that SGLT2 inhibitors will lead to uricosuric effect and therefore reduce the uric acid, and it will reduce either the new onset of gout or in patients with existing gout will give you the benefit. So ladies and gentlemen, this is my last slide. And what I would like to show you this very interesting slide, which actually gives you the complete spectrum. Here on the left-hand side, you have diabetes mellitus, heart failure, and chronic kidney disease. And now you have to look at this slide from a very different perspective. Patients of type 2 diabetes in heart failure, patients of type 2 diabetes in chronic kidney disease, or chronic kidney disease without type 2 diabetes, heart failure without type 2 diabetes. So we have the entire spectrum that we are talking about. And what we see, any parameter that you look at, you see a green line there. Occasionally one or two where it did not reach a statistical significance or data is not available, but they are very few and far between. I am not going to read each of these outcomes because that's what I talked for last 30 minutes. So what you see here, that this is a molecule which has really stood the test of time in the entire spectrum of type 2 diabetic patients with heart failure and chronic kidney disease, And chronic kidney disease and heart failure patients without type 2 diabetes, it has shown clear and consistent benefits across various studies over last 15 to 18 years' time. Thank you very much for your kind attention.
Thank you, sir, for such a lucid talk. And I'm sure your talk must have incited a lot of thoughts and questions. If you have any questions, yes. I have some questions too.
Mike, please.
Hello.
Yeah.
Thank you very much, sir, for such a nice description of dapagliflozin. Sir, I have only one small question. Forxiga has done all this for the investigation of dapagliflozin. But then empagliflozin also is coming out with such trials. In your practice, sir, have you seen any differences between empagliflozin vis-a-vis dapagliflozin? That is part one. And secondly, would you ever leave any diabetic patient without a dapagliflozin?
Without?
Giving him a dapagliflozin.
Sorry?
Would you leave any patient without a prescription of dapagliflozin?
Okay. So the first question, whether there is any difference between dapagliflozin and empagliflozin, and the makers of the two companies will always show you the difference. But as clinicians, we clearly know that there is no difference. And whatever difference is propounded by the companies is based upon the trial design. Say, for example, the makers of empagliflozin will tell you that cardiovascular death was impacted by empagliflozin, but it was not impacted by dapagliflozin. But then you should also know that in EMPA-REG study, 99% of the patients had established cardiovascular disease, whereas in the DECLARE studies, it was a ratio of 60-40. So we were not talking about the same inclusion criteria.
Exactly.
And similarly, dapagliflozin has shown some benefit elsewhere. And there, the makers of dapagliflozin will claim that benefit. What we know that SGLT2 inhibitors as a class show you 99% similarities, and therefore you are free to choose any of them. And I'm quite happy using empagliflozin, dapagliflozin, or whatever. Even I would say that I'm quite happy using any molecule, even if it is, if my patient cannot afford the original, inventors of dapagliflozin and empagliflozin, and what we have in India, our own dapagliflozin costing 10 rupees or 12 rupees, I'll be quite happy, because I know that the bioavailability studies have been shown before they get approval. So yes, of course, if my patient can afford, I will go for the inventor drug, because we know that for sure that that is going to be quite effective. But if my patient comes and tells me that, no, this is not, I cannot afford this 65 rupees drug or 50 rupees drug, then of course I will give a 10 rupees or 15 rupees drug. So in my opinion, whatever differences are shown are based inhibitors in every patients of type 2 diabetes? The answer is
As
no.
a preventive, sir. As a preventive.
Sorry?
As a preventive of complications. Sir, the patient may not be a case of heart failure. The patient may not have NAFLD.
Okay.
But I'm using it for future protection.
So uncomplicated type 2 diabetes.
Exactly.
Now I understand. You would have noticed that the international bodies like ADA, ESD, European Society of Cardiology, they have all shown that today metformin no longer remains the first line agent to treat type 2 diabetes. That statement came on 23rd of December 2022, right? So since that time, we believe that we do not necessarily need to prescribe metformin to every patient of type 2 diabetes. And that has precisely happened because of the humongous amount of data which has come with SGLT2 inhibitors. But even then, I would not use SGLT2 inhibitor in every patient of uncomplicated type 2 diabetes, because I have molecules which are equally effective, and they also provide the benefits in terms of cardiovascular or renal benefits. Say, for example, today we have GLP-1 receptor agonist, and it is not only available in the injectable form, it is available in the oral form also. I do appreciate that it is very, very expensive, an oral semaglutide. But theoretically answering your question, there are patients' phenotype which will make me decide that which particular first-line agent I would use. So, not in 100% of the cases, but today I have seen the transformation or change in my practice that in last 5 years, almost 80 to 90% of my patients with type 2 diabetes are receiving SGLT2 inhibitors necessarily, because the affordability for GLP-1 receptor agonists continues to be extremely poor, and therefore SGLT2 inhibitors comes at the top, with or without other oral anti-diabetic.
And so in your practice,
Thank you.
thank you.
Sorry. Thank you very much. It's time. It's on time.
So with the paucity of time, we will not take further questions as inauguration is coming up in Delhi Hall. So thank you so much, sir, for a wonderful talk. And we all request you to join in Delhi Hall for the inauguration. Thank you so much. You can ask your questions though in the corridor. Sir is there. Thank you so much.